On behalf of all the committee members, welcome you all. I also welcome today's eminent speakers, Dr. Devendra Pal, Consultant Medical Oncologist, Dr. Ravikant Jhala, Consultant Allergist, Dr. Jayalakshmi TK, Consultant Chest Physician and Pulmonologist, Dr. Bhumika Madhav, Consultant Chest Physician and Pulmonologist, Dr. Kavita Modi, Consultant Chest Physician and Pulmonologist. डॉक्टर कविता आज आ नहीं पाएंगी, वो गिर गई हैं और उनको फ्रैक्चर हो गया है, सो डॉक्टर कविता इज नॉट हेयर. डॉक्टर रोहन औरंगाबाद वाला, कंसल्टेंट चेस्ट फिजिशियन एंड पल्मोनोलॉजिस्ट. डॉक्टर रश्मि मैनन, कंसल्टेंट ईएनटी सर्जन. डॉक्टर नन्मा निकालजी नंबियार, कंसल्टेंट डर्मेटोलॉजिस्ट एंड कॉस्मेटोलॉजिस्ट. डॉक्टर विशाल गुप्ता, consultant chest physician and pulmonologist. Dr. Abhijit Bagde, consultant pediatrician and critical care expert. Dr. Sandeep Mistry, consultant physician and pulmonologist. Dr. Nilesh Chinchkar, pulmonologist. Dr. Nilesh Chinchkar, consultant chest physician and pulmonologist. Dr. Vinod Chauhan, consultant chest physician and pulmonologist. Dr. Vivek Patil, consultant chest physician and pulmonologist. And Dr. Deepika Ugade, consultant chest physician and pulmonologist. I also welcome Dr. Ghanshyam Dulera, MMC nominated observer for today's CME. Once again, Navi Mumbai, in association with Apollo Hospitals Navi Mumbai, came together with this very interesting, practical and useful CME on allergy and asthma, basics to immunotherapy. Now, I introduce our first speaker, Dr. Devendra Pal. Dr. Devendra is consultant medical oncologist, hemato-oncologist at Mumbai Oncocare Center, Khanda Colony, New Panvel, with 12 years of wide work experiences. He did MBBS, MD Medicine, DNB Medical Oncology from Rajiv Gandhi Cancer Institute and Research Center, New Delhi, and Advanced Certification and Medical Oncology from European Society ECMO. Numerous prestigious awards, papers and publications nationally and internationally to his credit. Dr. Devendra is life member of various onco societies and associations. Now I invite Dr. Devendra Pal on dais for his talk on biological therapy in lung cancer management. Over to you, Dr. Devendra.
A very good morning to all of you. First of all, I want to thank IIM Navi Mumbai and Apollo Clinics for giving me this opportunity to stand in front of you and discuss about lung cancer, which is a very serious disease. And as pulmonologist, all of you must be suspecting and diagnosing these cancers, not very frequently, but somewhat frequently also. The treatment wise, these patients come to us, but these patients with respiratory symptoms, they report to multiple specialties, and oncologist is usually in India. In later stages, usually the patient comes to us. So I'll be speaking on broad topics covering the staging and broad treatment recommendations. I'm Dr. Devendra Pal, working at MOC, Panvel, Khanda Colony and Vashi. Can you get a laptop here? Because I cannot see the screen. One laptop I need here. But I cannot see it. So lung cancer is the second most common cancer as far as both the sexes are concerned. In India, lung cancer is the second most common cancer in men. Head and neck cancer being the number one. And lung cancer is number one killer all over the world globally. In India, lung cancer causes is fourth in number as far as incidence of lung cancers is concerned. But if you see men and female separately, lung cancer is disease mostly in men, also in women. Head and neck cancers are number one and lung cancers are number two. But if we segregate the head and neck cancers separately, like lip cancer, oral cancer, buccal mucosa, gingiva, then lung cancer becomes the number one. If you combine head and neck cancers, then lung cancer is number two malignancies, and is the fourth leading cause of cancer-related death in India. The unfortunate part is that lung cancers are diagnosed in later stages. So 44% of the lung cancers are diagnosed when they are metastatic, and only around 14%. This is a rather larger figure, but practically in India we see hardly 5% of lung cancers as early lung cancers which are operable, and 95% are either locally advanced or metastatic. As compared to the breast cancers, lung cancer, the mortality is quite high even in stage 3 disease. In breast cancer, stage 3 breast cancer is treatable to a large extent, and we can prolong the survival to a large extent. But most of the patients, even in stage 3 of lung cancers, they succumb to the disease and they die off. Early diagnosis definitely improves outcome in all the cancers, but unfortunately for lung, even those patients who are diagnosed in stage 2, they also relapse, and about 50% of patients diagnosed in stage 3A, they relapse. So the most cure in this patient is if they are diagnosed in stage 1A1 and 1A2, and this can be diagnosed if you are screening the lung cancers. If you are not screening, then symptoms, by the time they are symptomatic, it's usually advanced disease. At least they are stage 2 or stage 3, when the chances of cure are reduced. And you can see the chances of cure in stage 4A and 4B are negligible. Risk factors, we all know, smoking, tobacco is the most common cause of lung cancers, and 85% of lung cancers can be attributed to tobacco smoking. So smoking in any form, cigarette, bidi or hookah, whatever form, 85% of lung cancers are caused by smoking. And this is not only active smoking but passive smoking also. So those people who are smoking at home and only one member is smoking, the other members are exposed to second-hand smoke. And it is well proven that second-hand smoke also increases the risk of lung cancer. So even non-smokers living with smokers, they have increased risk of lung cancer. So it's our responsibility and duty to advise people not to smoke, not only for their health but for other non-smokers people's health also. Family history has very little role in this. Other important causes are like these environmental causes, like radon gas, asbestos, or radiation. Those patients who have been exposed to radiotherapy for their lymphomas, like Hodgkin lymphoma patients. Hodgkin lymphoma is a disease of young people, and previously there used to be radiation used to be the main treatment for Hodgkin lymphoma. So those patients who had received radiotherapy treatment for lymphoma, they used to have lung cancers as increased incidence. But now the radiation is not very important cause for lung cancer, because now with the improvement of the techniques of radiation, the radiation fields are quite restricted. So you can say most important cause of smoking as of now is tobacco. Broadly, we can divide lung cancers in non-small cell lung cancers and small cell lung cancers, but it's not enough. Now, over last 30 years, we have matured and we are classifying lung cancers into more molecular types. Like in NSCLC, we are broadly dividing into squamous and non-squamous. Squamous is only one category, but non-squamous again is adenocarcinoma, or large cell carcinoma. But they behave almost similarly. And small cell carcinoma is totally different ball game. So small cell carcinomas are usually diagnosed at an extensive stage. They are very responsive to chemotherapies, but they relapse bad and survival is poor. And there are no molecular treatments available for small cell lung cancers. And for adenocarcinomas, we have many molecular targeted therapies which have improved the outcome of these malignancies. So small cell accounts for less than 15% of all the lung cancers. These cancers are very rapidly dividing. Many times when patients presents with this disease, they are symptomatic for a short duration, and the survival of these patients is quite less. Although they respond very well to chemotherapy, they become totally asymptomatic within 1 or 2 cycles of chemotherapy. But the disease relapses, and the survival in this patient is less than a year. Most of the patients die within 8 to 9 months. And the treatment available for this patient is only chemotherapy and nothing else. In small cell lung carcinoma, recently we have some immunotherapy drugs also available with us, but the cure is not in sight for small cell lung cancer. We have atezolizumab and we have durvalumab, which can be used for stage 4 small cell lung cancers. But they are shown to increase the survival and PFS for some time, but they are not curative options. For non-small cell cancers, we have evolved from just one diagnosis of NSCLC to squamous, non-squamous, and now we have so many molecular categories of adenocarcinomas. And after identification of these molecular categories, we can target our treatment depending on these abnormalities, and outcome is improved drastically over the last few years. So we can say about 50% of lung cancers have molecular alterations, which we should aim to find out at the time of diagnosis, and we should target our treatment depending on the molecular alterations present. So the advances which have happened over the last 20 years have been more on the targeted therapy front and immunotherapy front. You can see if for chemotherapies, as far as chemotherapies are concerned, these two top yellow bars. So these are the only new treatments available, which have come up in last around 20-25 years. Most of the approvals for lung cancer treatments are for either immunotherapies or targeted therapies. The blue ones are the targeted therapies. There are so many targeted available, and over the years the approvals have been increasing as the time is coming by, and immunotherapies options also have been increasing, and now immunotherapies have approval for neoadjuvant, adjuvant and metastatic in all categories. So treatment for lung cancer, as we all know, is multidisciplinary. It should start with general physician, because most of the time patient goes to general physician and MD physicians. Symptoms with cough and all those breathlessness and all these things. So a team comprising of pulmonologists, radiologists, pathologists, medical oncologists, surgical oncologists and primary care physicians. They are important for early diagnosis, timely referrals and specific treatment to improve the long-term outcome. For stage 1 and stage 2, patients with NSCLC who have disease limited to one lung and not involving the mediastinum or so the stage 1 and stage 2 lung cancer are those cancers which are limited to the lungs or maybe N1 lymph nodes. So disease is up to, you can say, 5 to 7 centimeters. So in stage 3, when N2 lymph nodes are involved or T size is increased, and stage 4 is metastatic disease. And in stage 3, it's again multidisciplinary treatment. So in early stage, the treatment of lung cancer can be of curative intent. So we can aim for cure, and for actually this operability also has to be decided by a multidisciplinary team, because even if those lung cancers which are operable, they require preoperative treatment. So preoperative treatment for operable lung cancers are options available with us are chemotherapies and immunotherapy. It has been shown that if we start the patients on neoadjuvant treatment for those patients who are stage 1A2 onwards, it improves the survival and progression-free survival also. So even if patient is resectable, we expose them to neoadjuvant therapy, surgery, and then adjuvant therapy for the next few months. And those patients who are not operable, we give them just CTRT treatment and targeted therapies later on. The surgical treatment for lung cancers, it used to be pneumonectomies few years back, but now lobectomies are the standard recommended treatment for lung cancers. For those patients, and the decision has to be taken depending on the performance status of the patient and the pulmonary status of the patient, cardiorespiratory status of the patient. So the preferred treatment for those patients who are eligible for surgical treatment is lobectomy. Pneumonectomy is nowadays not done unless lung is severely damaged. For those patients who are poor surgical candidates, we can offer them wedge resections or segmental resections. And in carefully selected patients, the outcomes are very good. And in those patients who are not at all operable for even wedge dissections, we can offer them SBRT, which is stereotactic body radiotherapy. Surgery is the primary treatment for early stage lung cancers, and we can give neoadjuvant and adjuvant therapy to improve the survival for these patients. And there has been overall survival advantage has been proven with options of neoadjuvant therapy available with us in form of chemotherapy and targeted therapies. So you can see in stage 1B, 5-year survival still is 40%, and as the stage increases, the 5-year survival keeps on falling. So there is still a scope for improvement. The unmet need is there, that even those patients who are operated, they keep on relapsing because the disease is like that. So to improve, we have now some options available with us. So those patients who are operable, they have offered surgery, pneumonectomy or lobectomy is done, lymph node dissection is done. So as we can see in the previous slide, so the recurrences are quite high. From stage 1B onwards, the recurrences are quite high, and when the disease recurs, it is quite many times lethal. So we have options available for adjuvant therapy in the form of targeted therapies. So all the patients who are taken up for surgery, the tissue is analyzed for molecular testing is done on all the samples, and EGFR mutation is one of the common mutations which is seen in Eastern population. And it's been reported that about up to 25% of patients of Asian descent have EGFR mutations. And those patients who are EGFR mutated, we can offer them osimertinib, which is third generation EGFR inhibitor. And you can see the survival, the disease-free survival is improved. The yellow line is observation, and yellow line, this blue line is osimertinib. So if we give osimertinib in those patients who have been operated for lung cancers, the progression-free survival is improved. Now the trend is there for improvement of the overall survival also. So, but it is more helpful in stage 1B onwards and not 1A1. So adjuvant osimertinib provides highly effective practice-changing treatment for patients with stage 1B, 2 and 3A EGFR mutated non-small cell lung cancers after tumor resections. So those patients who are unresectable, what to do? Resectability has to be decided upfront depending on the lymph node stations involved. If the this slide is showing how do we stage lung cancers. So these are the loco-regionally advanced lung cancers, stage 3A, 3B and 3C. So 3A and 3B we call as operable or potentially operable lung cancers, and stage 3 is inoperable lung cancers. So why do we call stage 3C inoperable? Because here N3 lymph nodes are involved and T size is also large. So there is no advantage of operating them because most of them will relapse and survival will be very poor. In stage 3A and 3B, so either the T size is small or only N1 lymph nodes are involved, or if T size is more or less, the N is only 1. So in stage 3B, the T size is large or N2 disease, or if T size is small and N3 disease. So this way, as the stage increases from stage 3A to 3B, 5-year survival keeps on reducing. So for 2A and 3A and 3B, we can offer multidisciplinary treatment. Those patients, we can offer them concurrent chemoradiation. In those patients who are physically fit, we give radiotherapy and chemotherapy concurrently for around 6 weeks, and later on we can give them consolidation therapy. So the survival rates in those patients who have received CTRT keeps on falling because the disease keep on recurring. So there's a scope for further improvement in survival in these patients, and most of the patients, majority of lung cancer patients are diagnosed in stage 4. That is different issue. So for stage 3, the slide is not there. We can improve the survival by giving the consolidation treatment with them in form of durvalumab. Durvalumab is a monoclonal antibody which we can give after CTRT is finished and patient has responded to treatment. Patient is in reasonably good health. We can start durvalumab, which is immunotherapy drug, every 3 weeks in this patient with at a dose of 1500 mg, and it has been shown to improve the progression-free survival and overall survival in this patient. So those patients, the disease where the graph is downsloping, so it keeps this graph up for quite some time, and the PFS and OS is improved. But later on, after stage 3A and 3B comes stage 3C and stage 4 disease. So stage 4 disease is metastatic disease, and for metastatic disease we know that the treatment has to be palliative, and we only can give treatment to improve the progression-free survival and overall survival. So the targeted therapy options available for lung cancers, there are many targeted therapy options available, but most common targets which we use, target therapy which we use are EGFR, anti-EGFR agents, anti-ALK agents and anti-ROS1 agents. So and we have now immunotherapy drugs also available with us, which have shown to improve the survival, and lung cancer patients 5-year survival has improved to 5-year survival is improved to around 30 to 30% in these patients. So FLORA is the trial which was shown as to improve the survival of the lung cancer patient who have been EGFR mutated, where osimertinib has been used in first line. So the survival has improved from to around 12 months, where before availability of this drug, the survival with chemotherapy only used to be only 9 months. So this is just telling what is targeted therapy. Targeted therapy is therapy which precisely identifies particular target, like I just told, EGFR, ALK and ROS. There are many others. It attacks and inhibits the growth of the cell by affecting that target. It stops cancer cell growth. How to identify the target in cell? We do biopsies for diagnosis. We need more tissue to do molecular testing. So now we have broad panel next genomic sequencing available with us. So which tests around hundreds of genes. We can check limited testing by limited panels also, by using only limited genes which are involved. So 8 to 10 genes also can be tested. So on biopsy we expose those tissue to molecular testing, and we identify these targets. And 50% of patients with lung cancers can have targetable mutations. EGFR are most common, and followed by ALK and ROS1. So anti-EGFR agents available with us right now are divided into first generation, second and third generations. First generation was gefitinib and erlotinib, which came into vogue in early 2000s. Afatinib and dacotinib are second generation EGFR inhibitors, which came to us in 2010s. And osimertinib is available to us during the late 2010s. Osimertinib is third generation agent. It is irreversible EGFR inhibitor, and it has improved the survival and progression to survival of this patient to maximum extent. And it is very well tolerated drug. It is very well tolerated drug, and patient can carry on the activities, day-to-day activities. They can carry on to be in their profession, and the OS of patients given first line osimertinib has been shown to be 38 months. Immunotherapy is another kid on the block where we are enhancing the immunity, because the cancer cells are they express some antigens which fool the immunity of the body. So by analyzing those cells which are expressing PD-L1, program death inhibitor ligand, on the tumor cell, so we can give anti-PD-L1 agents, so which can inhibit the inhibition of the T cells. So T cells are activated for inhibiting the cancer cells. So there are many options available for immunotherapy, and we can select depending on the PD-L1 status. So we can classify PD-L1 status to less than 1%, up 1 to 50%, or more than 50%. And depending on whether PD-L1 is percentage is how much, we can add immunotherapy with chemotherapy. So if PD-L1 expression is less, we have to combine immunotherapy with chemotherapy. But if PD-L expression is more than 50%, we can treat this patient only with single agent immunotherapy. So to summarize, overall survival, 5-year survival of non-small cell lung cancer is between 10 to 15%, primarily because. So to summarize, I'll not look at the slides. So over last few years, we have come a long way. In early 2000s, the survival of those patients detected with stage 4 lung cancer used to be hardly 9 months. So by 1 year, hardly any patient used to survive. So over the years, we have so many targeted therapy available with us. Now we can classify the tumors in molecular ways, and we can target those molecularly identified lung cancers with molecular drugs. And the most common molecular drugs available to us are anti-EGFR agents, anti-ALK agents, anti-ROS1 agents. There are many others also, but these three constitute around 50% of around 50% of all the targeted therapy options available with us. So with the newest EGFR inhibitors, overall survival has improved to 30 months with new ALK agents, which are active even in those patients with brain metastasis. So the survival of these patients have gone up to 35 to 40 months. So the patient with brain metastasis carrying on for 35 to 40 months just on oral tablets is really mind-boggling. And we have immunotherapy drugs available with us, which in those patients it doesn't act in all the patients, but in those patients in which it acts depending on the PD-L1 status and other microenvironment factors. So the results are really nice. They are not the chemotherapy drugs. There are no adverse effect of chemotherapy with the immunotherapies, and 5-year survival in many of these patients have crossed 40%. And those patients who are earlier staged lung cancers, after surgery, we can give osimertinib as adjuvant therapy, and it has improved the progression survival to very good extent. And after chemoradiation, now we have immunotherapy available with durvalumab. We can give this to give as consolidation therapy, and it can improve the survival to a significant extent. So I think I have overshot the time. The role of general care practitioners in lung cancer treatment: you should have high index of suspicion for early and prompt diagnosis. AKT should not be started in any patient who is coming with pleural effusion. All the treatment should be guided by the proof. If there is no proof, we should not be starting any treatment. Brief the patient about importance of all the tests. Many times patients feel that we are investigating so much, but these investigations are very important. If we don't do biopsy, we will not get any tissue for molecular testing. If we do molecular testing only, then we can identify those drugs which can be most effective for these patients. Many times this treatment can be costly, but we can do something, and we can discuss about the options available. we should be able to take care of the complications. Many times the patients of cancer, they come to general practitioners and general physicians for treatment of complications. So we should be aware what are the complications with chemotherapies and targeted therapies, and we should guide them to be regular on their follow-up. Thank you so much. If any question, I'll be able to answer.
Thank you, Dr. Devendra Pal. Excellent talk. You are always wonderful speaker. Now I request Dr. Boricha sir to come forward and give token of appreciation to Dr. Devendra Pal. Thank you, Dr. Boricha sir. Thank you, Dr. Devendra. Our next speaker is Dr. Ravindra Jhala. Now I request Dr. Rashri to introduce our next speaker.
Good morning all. I am Dr. Rajeshri. I am a Navi Mumbai secretary. Our today's topic is allergy and asthma basic to immunotherapy. And our speaker is Dr. Ravikant Jhala. Dr. Ravikant Jhala is a consultant and medical director, Jhala Clinic, and affiliated with the Niramaya Hospital and Polaris Hospital, Kharghar, with 30 years of wide work experiences, numerous prestigious awards, papers, and publication nationally and internationally to his credit. Dr. Jhala is a life member of various allergic societies and associations. Now I invite Dr. Ravikant Jhala on dais for his talk on drug allergy when the solution becomes the problem. Over to Dr. Jhala.
Anyone can help? Yes. Yeah. Good morning, everyone. ये होगा PPT का? Okay. This is right, left. इसमें लिखता नहीं है. हाँ. Fine. Yeah. Thank you so much. Good morning, everyone. After wonderful, like the high mortality lung cancer in India. हाँ, ये बंद कर दे. आ रहा है आवाज सबको? Yeah. Fine. This is something very different topic today. We'll be talking about the allergies everyone knows and everyone is little bit curious about, and the awareness regarding the allergies and applied immunology and allergic disorders is very scarce, and people are still having some kind of conflicts and some controversies and everything. So hence this is an attempt for this particular very unique topic. In the beginning I would wish to thank all the teachers, from my parents, from my school teachers till the college, and my sir from whom I learned Allergy, Dr. D.M. Tripathi is present today just to listen to my talk. And thank you IMA, Navi Mumbai, thank you Apollo Hospital, Dr. Jay Lakshmi Madam, and all the Apollo people, and IMA Navi Mumbai, President, Secretary, and all the people over there, and all of you, the delegates, and I am also thankful to my patients. Because of my patients' cooperation today, whatever I am standing here in front of you. Yeah, so today's topic will be, you can be allergic to anything and everything on this planet Earth, actually speaking. Even if you're allergic to your spouse, do not show that you're allergic to your spouse. Yeah, so this is the definition of the, see, drug allergy is immunologically mediated response to a pharmaceutical and or formulation excipient agent in a sensitized person. Now, there's something which is drug allergy is something different, drug adverse reactions are different. Now what we have usually found is the adverse reactions are type A is up to 80%. This is pharmacological adverse effects, drug interactions, the two drugs interact with each other. That's 80% is type A. Type 2 is up to 20% non-immune mediated. We have drug intolerance, drug idiosyncrasy, and pseudo-allergy, anaphylactoid reaction. We have immune mediated, and we have there is a drug allergy. Now, this is the age-old type 1, type 2, type 3, type 4 allergenicity. We all know gel and Coombs when we learned during our MBBS classes, you know. The most common being IgE mediated, that is type 1, immediate hypersensitivity, in which we get urticaria, anaphylaxis, etc. And all of you are aware of that IgE levels are basically most important. Ig levels are actually used as an initial screening test for allergic diseases, and IgE antibodies mediate allergic diseases by sensitizing mast cells and basophils to release histamine on exposure to various allergens. Now these could be anything basically, like could be dust mites, 3, could be 6 dust, could be grass pollens, weed and shrub pollen, tree pollens, could be airborne fungi, could be insects, could be epidermals, could be food, could be anything, you know, basically anything on everything on planet Earth can give one antigenicity or allergenicity. Now, there's a type 2 cytotoxic reactions. Of course, there are timings like allergies occurs within minutes to hours in type 1. Type 2 cytotoxic hemolytic anemia is an example, one of the example, 5 or more days. Type 3 immune complex, serum sickness, drug fever, 1 to 3 weeks. Type 4 is delayed hypersensitivity, contact dermatitis, days to weeks initially, then can be faster. Now, not all drug allergies fit in gel and Coombs classification, right? So there is something called a pseudo-allergic anaphylactoid, icatibant. Now, icatibant induced reactions via MRG, PRX2, those by opioids, NSAID, etc. Icatibant is used to treat, it's a drug which is used to treat hereditary angioedema, right? So that's common, but of course we don't come across that, but we don't also think in that sense that hereditary angioedema, whenever we get angioedema, we never think of hereditary angioedema. We need to go to the depth of the history. And another thing is cytokine release syndrome, that is rituximab, which is used for non-Hodgkin's lymphoma, etc., induced fever, nausea, hypotension, etc. And pharmacologic effects, aspirin exacerbated respiratory disease. This is another common thing. Then there are clinical phenotypes, wherein we have cutaneous, exanthem, urticaria, fixed drug eruptions, organ-specific, drug-induced liver injury, and multi-organ, serum sickness-like things. Then chronological. Chronological is like immediate, that is urticarial, 20 minutes, for example, 20 minutes after taking penicillin, then delayed reaction, drug reaction, and eosinophilic symptom, systemic symptoms, dress, 2 to 12 weeks after carbamazepine. Now, all of you, dear audience, physicians, surgeons, chest physicians, general practitioners, super specialists, and all learned people over here, how important is knowing drug desensitization? As a specialist of whatever branch you may be, real-time practice, every one of you must have come across, like there is drug allergies, expectations are there, galore, see drug allergy patients right, left and center, many times we get. And we actually don't have these, so simple solution is what? Just refer them to me. Just joking. Refer them to an expert. Now, how many are available? See, most important is how many people are available for a proper drug allergy detection. Right? Scanty. Now, the irony. Drug allergy. The irony is demand is too high. Nowadays, if you see statistically, last few years, the antigenicity to the drugs have started increasing. We don't know the exact mechanism or exact cause of that. So demand is too high, very few centers are doing it. Drug allergy, an area many fear to trade. Now addressing the genuine demand, patient needs definite answers. Which drug they can use, which drug not to use. The stumbling blocks is uncomfortable topic. Mechanisms less known. Less education, less research, medical legal issues, many cases missed and many deaths unreported. We'll come to the one or two cases wherein the deaths are reported but the cause of that is not investigated well. Now the tragedy. Now this is 27-year-old history of one episode of rash with SOB, like shortness of breath within 30 minutes receiving after local anesthesia and diclofenac tablet, needed clearance for dental procedure, lined up for local anesthesia allergy testing. History of sudden death of the younger brother. 6 months ago at friend's home, 12 midnight, choking episode, foreign body, sudden death, family suspected foul play. Police case filed, autopsy inconclusive, case closed. History solves the mystery. Our history taking now turn more inquisitive and curious. A casual mention of the deceased having consumed some painkiller, likely NSAID, at 11 p.m. that night. Point completely ignored by the investigators. So this death could have occurred because of the laryngeal edema caused by any of the NSAID, which was actually ignored. NSAID-induced laryngeal edema, the likely cause. Missing the elephant in the room. Many such stories around. This is one of it. The unusual scenario. Already labeled as drug allergy. What is this unusual scenario? Many times we, like some of the general practitioners with due apologies, I'm not pertaining to any general practitioners, I have got some of the physicians, some of the people, they just write, allergic to this drug. Their physician or somebody has written and given it to them. So those are the things which are unproved and labeled as this. So already labeled, mostly referral cases, labeled by local chemists also, nurses also, children by parents. Many children are like, parents comes and tells us कि मेरा बेटे को इसका allergy है, ये drug मत देना. So because they don't know actually. So idealistically, one must try and detect. Treating surgeon, physician, dentist asking for a clearance with a poor workup. The facts, the silver lining. In children, allergies can be outgrown, 50% age 5 years and above, 80% 10 years and above. Drug allergies, when reported, the labels often turn out to be wrong. Patient's history, previous documents, and drug allergies usually unreliable. Skin testing, non-experts. Methods adopt wrong techniques, hence wrong label. Eventually, only 10% prove truly allergic. 90% are not allergic. Those are false labels. Outcome of the wrong label is deprives the patients from receiving important medications like antibiotics, local anesthetics, etc. Unneeded and expensive broad spectrum antibiotic usage leading to more side effects and query bacterial resistance. Patients tremendously disturbed. Drug phobics, drug cripples. Now this disturbance patient, see now this is a fear of the mind. Mind is a very important tool in our life. Mind is like, your mind is your greatest friend if it controls you, and mind is your greatest enemy if it controls, vice versa. It's written in Bhagavad Gita, I suppose, if somebody knows this. Yeah, well, and so one must be, like the psychological assessment or the psychological things when the patient of drug allergy comes is concomitantly important to be tackled. Now, what is the role of an allergist? As a management of allergies, there are 5 steps. The first step, history. In medical things, history is most important and essential. Meticulous history taking is important. Review of the medical notes, if there are previous, whatever, peacefully one must see all the things. Some of the patients comes to me like 5, 6, 7 files and all those people, everywhere. I need to see them very peacefully, no hurry at all. Listen to the patient, very important. Listening is important because when you have to, patient are talking, do not interrupt. One-to-one. One needs to be absorbed in the things what we are doing. We are many times not absorbed in even taking history. Now, mobile phones, like we always see, kuch tuk hua, chalo dekho WhatsApp, kuch aaya, kiska aaya, kya hai. Never do like this in your practice at all. Then true allergy or otherwise, type of allergy, severity of allergy. Step 2, physical examination. Now, physical examination, you will see this kind of things, drug-induced exanthet morbilliform rash, drug-induced urticaria, there's a drug-induced angioedema, fixed drug eruptions are like this. There's acute generalized erythematous pustulosis could be there. SJS, Stephen Johnson, and toxic epidermal necrolysis could be there. Then step 3, lab workup, in vitro test. In vitro, only serum tryptase is at this moment available. Fluorescent enzyme immunoassay, basophil activation test, and lymphocyte transformation test are still under trials in the world, not at all started yet. Step 4, this is another most important part. Step 4, gold standard, percutaneous, intercutaneous, and epicutaneous tests. This is skin testing. So percutaneous, that is modified prick test method, intracutaneous, intradermal method, and epicutaneous, that is patch test method. We see this. Now this is a prick test. Now these are all, see this is, I think this not working, doesn't matter. We need to always do the prick test, we need to do the controls, that's positive control, histamine dihydrochloride acts as a positive control, and glycerinated buffered saline acts as a negative control. We may do this prick test of any of the drugs. Intradermal also can be done with the dilution and all those things. That's into detail, like we won't go into detail right now. Anybody is interested can talk to me directly also, no worries. Step 5 is the gold standard, graded drug challenge test. That's number 1. Incremental drug challenge, drug provocation test, 2 to 3 steps maximum in this. So what are these? Graded drug challenge tests means if we need to do, there are different types. One is single blind, one is double blind, one is you know what you're doing, you are telling your patient also. For example, if I'm conducting graded drug challenge test, say for any PPI or say levofloxacin antibiotic. Now I inform the patient I am conducting test upon, he was probably previously query found allergic to levofloxacin. Now I am conducting that. So how would I conduct it? It's an oral challenge test also can be done. So oral challenge test, how do you conduct? Is you give the adult, see as per the weight of the patient, what is the per kg weight, body weight, what's the dosage, pharmacology, again, you have to go into depth of the pharmacology, right? So go there, see that what is the actual dosage recommended in our pharmacopoeia. Now then, what way you should, what is the things, what the patient, it's an individualized thing. It's not like a common thing, it's every patient's drug challenge tends to be differing from patient to patient. It's not like same. So you need to judge, you need to be the best judge for conducting that drug challenge test oral. So what dose you will give first? Say for example, you're giving 5% of the original dose first. Then wait for how many minutes? Say wait for 45 minutes. Then you're giving dose say 15% of the original dose. So that means you have increased 10%. So that way you increase. If the things are uneventful, we'll come to that later on in this thing. Sorry, this is a patch test. In the meantime, now there are pin chambers, or else if you don't have the pin chambers, you can have the square, like gauze pieces also, and there are pre-filled syringe of the patch test antigens available. Now, patch test antigen type 4 allergy, it's a contact dermatitis type of things and all. Now, what happens is, like for example, hair dye, I don't apply. Anyway, so hair dye, any hair dye in the world contains PPDA, that's called paraphenylene diamine. Now, without that PPDA, the hair dye cannot be manufactured. So, PPDA is a substance which is antigenic in hair dyes. So, that is a pre-filled syringe available, which are FDA, WHO, WAO approved, and that we have to put the hair dye patch, see the result after 48 hours. Similar to that, we can also do this test for n number of drugs like amoxicillin. There are 52 drugs right now available which are approved in India for conducting this patch test of the drugs. For example, amoxicillin, ampicillin, cloxacillin, chloramphenicol, doxycycline, all those things, and lignocaine, all those things. Now, then you need to have the knowledge of the things. For example, say a person working in cement industry or a builder or somebody, so he or she is going to the sites. Nowadays, so many constructions are going on in and around this area. So, what happens is, the potassium bichromate and ammoniated mercury, these are the two things which are present in this cement industry. Then artificial jewelry, whatever we wear, we have that nickel sulfate, cobalt sulfate and copper sulfate, so on and so forth. I won't go into any such further details. This is just the patch test things. We have to just apply, remove the patch after 48 hours, see the result. Now, result of graded drug challenge test and its implications. Now, here, what I was telling you before some time was, if the challenge is successful, that means what? Your challenge that for that particular patient, it is successful. That means it's a negative reaction. So now the patient can consume that drug safely, right? The patient stands delabeled. This is called as the patient stands delabeled. If the challenge is unsuccessful, that means somewhere in between the dose, patient started getting some untoward reaction, or sometimes we have to do this. I forgot to tell you, this needs to be done in an ICU presence. No, preferably I do it in ICU. Next door, I have my clinic, so I don't have the hospital. So if the challenge is unsuccessful, that means positive reaction. So no more use. So provide a drug from an alternative class, right? But there's a big question mark that what if the patient badly needs the same drug for which graded challenge resulted as a positive and no safer alternative drug is available? What would you do? These are, for example, iron salts in patients with severe iron deficiency anemia, rituximab in some lymphoma patients, penicillin in syphilis. These are some of the examples wherein there is no optional things. So what would you do? So drug desensitization is important. So what is drug desensitization? Is a temporary induction of tolerance to a sensitized drug by administering slow increment of the drug starting from a very small amount to full therapeutic dose. This is drug desensitization. That means once we desensitize that particular patient for that particular drug, patient and later on would be able to consume that drug. That means that allergenicity to that drug is gone away. Got it? हाँ एग्जैक्टली वो ड्रग डिसेंसिटाइजेशन का एक टॉपिक था, वो एक पूरा टॉपिक ही था यहाँ पे, बट हम लोग ने पूरा टॉपिक जरा थोड़ा सा चेंज हो गया, वही मैंने इसके साथ कल बात किया. इट्स अ होल itself is a good question. She has a good question. I'll just answer it after this talk. Okay, once we finish. Now, this is one of the case which was I learned this about 3 to 4 years back at Srinagar Institute of Medical Sciences. They do a lot of drug allergy things, And one of my friend, Dr. Taha, he works very well. Ruhi Rasool is a HOD there, and in June, I think, so June 23, no? It was, and I appeared in fact, I appeared on the newspaper of that area, Srinagar, Kashmir and all, because I had the talk of psychological triggers of allergic disorders, which was a very different talk. And then that time I went for 7 days, I was there and I learned this drug allergy things. And then I started, advocating it. So there was one of the case, I had happened to be in a hospital, this thing. A 22-year-old female admitted with surgery department from 3 days as a case of rectal prolapse, planned surgery for after 2 days, baseline investigations, normal clinical history. Day 1, generalized rash after receiving IV levofloxacin, no systemic symptoms. Day 2, anaphylaxis twice, remember this. First within 5 minutes after starting IV DNS. Second episode, 10 minutes after starting IV ringerlectate. Past history, patient has features of perennial allergic rhinitis, ignored. Many times we ignore, ourselves also. We have allergic rhinitis, naak hai ki manta nahi, so we ignore, Intermittent asthma, ignored. No history of drug allergy. Tolerated well antibiotics, NSAID, PPIs. All these things were earlier well tolerated. The culprit drug, Sherlock Holmes, IV levofloxacin, IV DNS, IV ringerlectate. Question mark, we don't know. Now, our mind is like a parachute. It works best when it's open. So now what to do? Review history. At admission in emergency room, more episode of generalized rash, shortness of breath, vomiting. Soon after a physical examination was carried out, consensus was what done? Surgery deferred for 4 weeks. No surgery because it could not be done because of the question mark. Now we need to plan something which is unusual. Something which is not usual. So unusual. At 4 weeks, what did we do? SPT, IDT and OCT for levofloxacin and metronidazole was done, which was negative. SPT for latex just came to my mind. Latex, positive, 3+. Skin prick test. Specific IG for latex, positive 9.6 KUA per liter. Latex poodle test. Latex poodle test, I don't know how many of you know, but if somebody wants to know, I will tell you. Fine? No worries. Now that came positive. Now the conclusion is what? Conclusion is latex-free operating and post-operative facility has to be provided. Pre-operative medication, regimen and anti-allergic medication covered till the wound recovery. The TRIM, Lionel Messi, who won the World Cup 2022. So TRIM is what? The surgical procedure was uneventful. It was detected that latex was the culprit. So downstream, latex avoidance strategy, do's and don'ts counseling, workup for allergen, immunotherapy for latex. Latex is a substance, one of the very senior surgeon from Alibag, happened to be my it's like a roaring practice, daily so many surgeries he used to do. He happened to have the positivity to latex allergy. He was given sublingual immunotherapy for latex for around 3.5 years. In the beginning it was 10 months it's like a treatment kit followed by the maintenance kit, and then he's now all right, he can wear all the latex gloves. Now take home message. What? Drug allergy is not an enigma. Delabeling is badly needed. It can reduce costs, antibiotic resistance and optimize patient outcome. The drug allergies have workable solutions. Interspecialty coordination needs to be there. Very important. So our intention is to be patient should get better. किससे अच्छा हुआ वो जरूरी नहीं है. मेरे से अच्छा हुआ, आयुर्वेदिक से अच्छा हुआ, होम्योपैथी से वो अच्छा होना जरूरी है. Right? Sometimes we feel कि नहीं ये मैंने किया, मैं कुछ नहीं कर सकता हूँ. Someone about 10-11 months back, one of the PhD from BRC senior scientist came to me and he asked me, after explaining so many things, and he asked me one question, Doctor, how many patients have you treated? So my instant answer was 0. Because I don't do anything. They only do. I just show them the path to go. The destination is with them. The rest all things, they have to be dedicated, they have to have self-confidence, they have to be positively thinking, they have to cooperate, they have to constantly listen to the things. Then they can go out of that. Thank you very much for being non-allergic and patiently listening to me. So kind of you. I have no concept of interest to disclose. Thank you so much. Any question? Now, one question she had desensitization. I'll just brief about that. How do we do desensitization? Is we basically, like any particular drug, once we find that this particular, confirm the thing with the graded drug challenge test that this is allergic to this particular patient. Now, what do we do? Now, we have to have the ICU facility in the hospital where we are doing, number one. Number two is we now either if it is an injectable or an oral things, we give a very minimal dose. So say for example, a particular drug is to be given, say for example amoxicillin clavulanic acid 625 needs to be given. So we do what? We give that pediatric dose, not even pediatric dose, say say 20% of the pediatric dose will be the first dose. Then observe for about 1 to 2 hours. If nothing occurs, just that same dose can be doubled, oral only. And then if nothing happens, we again wait and watch. But in case if something happens, then you need to stop the things at that moment. The same thing can be repeated after few days. There is no data or nothing is available as to many of the patients, like supposing if I have done drug desensitization of a patient at this moment, if it is failed, the same can get successful after say 15 days. There is, I don't know about that, what goes inside the body. Okay, nobody could go within the body and see things. All of these clinicians or something, we just, depend upon the history and the clinical and then we thinking that the investigations what we have sent is absolutely right and true to our knowledge. So this is how we do. And thank you, and I've taken much time. Thank you so much. Huh? Yeah, please.
Regarding the food allergy, nowadays we see that
Yes,
the people who go for the allergy, they would taste 20 type of foods they are allergic to.
Right.
Especially nowadays food allergy in general and that gluten in
Gluten,
particular.
yes.
How much is the desensitization treatment is effective?
Okay, fine. First thing is this number one is the for this one needs to undergo food allergy testing by modified prick test method. On the basis of in vitro test, we cannot put the patient on individually prepared allergen vaccine or immunotherapy. Now, immunotherapy can be of two types. One is subcutaneous, one is sublingual. For food, it is sublingually, it is available, every food, like any dals, any egg, this, that, like anything, whatever food you say, body soap, whatever, Now, most important food, like besan, gram bengal, for example, then eggs, then prawns, then fish. Ban karna chalel. So, whichever food, so as compared to the controls, it is how much? For example, control means histamine releases 6 to 7 millimeter wheel with 18 millimeter erythema. So now the particular patient who has come for food allergy, I have tested upon say 40 food allergens. Out of that, gram bengal has come to be positive 6 mm with 12 mm. So which is a common food because it is in so many things it is there. So we have to see this, that what is to be given importance. So gram bengal we will put as in a treatment kit, in the advice that gram bengal, that patient is advised to undertake vaccine, individually prepared vaccine or sublingual immunotherapy for gram bengal. This is number one. Then milk and milk products, that is also common. So those we can add. So whatever are strongly positive we can do. Now the treatment sublingual immunotherapy is from low dose to high dose and from low concentration to high concentration. We give them give the patient, and once this is called as treatment kit, which lasts for 9 to 10 months. Post treatment kit, there is something which is called as maintenance therapy. Now to get rid of a particular food allergy, it takes around 3.5 to 4.5 years minimum. So the compliance here is very essential and important. Compliance is based upon the clinician who is explaining to the patient in the beginning. You're preparing the mind of the patient. How You have to take this, this is your this, you have to accept. First thing you have to accept. You cannot choose your parents. I cannot choose my son or daughter, there's no choice. So you cannot choose your diseases. So first, they have to be well prepared by their mind that you accept this, that you have this allergy, and you have to explain to them that this is going to take this much time. And take preferably what I do is I tell them that whatever I have explained to you is written and signed by the patient, by the witness, somebody who is attending along with the patient, and my own signature. So this documentation, medico-legally, is also important, sir. Right, sir? Thank you so much for the nice question. Sorry, हाँ? बहुत बहुत शुक्रिया. फटाफट दे दीजिए. हाँ. My apologies, as I've taken much time. Huh? Sorry.
So thank you Dr. Jhala for excellent presentation. जो भी आपके questions हैं panel discussion में Dr. Jhala is there. Now I request Dr. Ghanshyam Dulera sir to come forward and give token of appreciation to Dr. Jhala.
घनश्याम जी, बहुत टाइम के बाद मिले हैं, बहुत शुक्रिया. Thank you so much. Thank you so much. Thank you so much. Thank you, madam.
Thank you, Dr. Dulera. Thank you, Dr. Jhala. Our next speaker is Dr. Jayalakshmi TK. Professor Dr. Jayalakshmi TK is consultant chest physician, interventional pulmonologist, educator, facilitator at Apollo Hospital, Navi, Mumbai with 27 years of wide work experiences. She did MBBS, MD chest medicine and completed her postgraduate European diplomate and advanced training from Singapore, Italy and MRCP from UK. Dr. Jayalakshmi had wide teaching experience, has also served as faculty, professor and HOD at D.Y. Patil Medical College. Numerous prestigious awards, papers and publications nationally and internationally to her credit. She is trained yoga teacher also. Dr. Jayalakshmi is life member of various respiratory societies and associations. She is organizing chairperson for today's CME also. Now I invite Dr. Jayalakshmi TK on dais for her talk on biologics in bronchial asthma, Indian experiences.
Hello. Thank you to Dr. Sangeeta for the very kind introduction. Thank you to IIM Navi Mumbai for supporting this session of ours. And today I am very happy to be talking to you about the biological treatments in asthma. So far asthma has been a disease which we are all seeing from many years treating, and most of the patients have very gratifying results with the current treatment which is available. We give inhalers, we may give some anti-allergics, and patient usually responds maybe once in a year or something. They will get an exacerbation which may require oral steroid, course of oral steroid. So we accept that, and then the patient usually is well cured. So some new concerns are that even those little steroid bursts which we give, even those can have harm on the patient when you are considering the long term. They can have harm on the growth, they can have harm on the metabolic profile of the patient. Nowadays there is a lot of concerns about the metabolic problems which patient gets, particularly the derailed sugar metabolism, weight gain, blood pressure, all these things as a result of prolonged steroid use. One burst, two bursts, we are not really concerned, but even those can cause harm. But now what we come to two terms. One is a difficult to treat asthma and one is a severe asthma. So difficult to treat asthma is about 15%. Now difficult to treat asthma may have patients who are not adhering to their medications. They are patients who have not been given full medications, or they are patients who are compliance is low. They may not be because of drug interactions, they may be having some issues. So these are the difficulties. These can still be overcome. We can teach them how to use, we can adjust our medication. But still we'll come to a last 5% of the patients who have severe asthma. You have given maximal medications. In our talk, I'll go through the GINA guidelines which tell what all to give and what all to add. Dr. Kavita is not coming, so her part on GINA guidelines I will cover briefly in my session. So please give me a little extra time for that. And so that also we are giving. After that also there are some percentage of the patients who are not getting control. So for them, what was the answer? In fact, asthma deaths have been increasing over the years in spite of all our medications which are available. Still, why? Why is the asthma deaths increasing? Why should anybody die from asthma when there is so much of treatment available for asthma? Patients' non-adherence is only one of the factors. So these newer medical treatments which have come, like biologicals, are really a boon. They are an answer. At present, of course, they are expensive. But as they are more and more used, they would come down in the price as well. And they are a boon for few reasons. One, they can treat asthma. So it is like the match, like how we had the first session where in the oncologicals there are newer targeted therapies being available. And these are really proved to be a boon for a lot of cancer patients. Similarly, so these patients, they act as a steroid sparers. So many of the patients who are started on these medicines, they actually go off steroids. Thirdly, the acute exacerbations, the life-threatening exacerbation, they really come down. So in a patient with severe asthma who has who is already taking maximal medications, for them, these biologicals are really a big boon. So this is just an introductory thing. So first, actually, we have been talking about, first I had come exposed to these biologicals when I had visited Italy. I had gone for a bronchoscopy fellowship, EBUS and others, but there they were using lot of biologicals. This was a center in Europe, so they had free treatment available. So they were part of a study. So they were comparing mepolizumab, benralizumab, omalizumab in various, so all their asthma patient would be put on, not only the severe asthma. So all the moderate to severe asthma would be put on. So they would have like a dental clinic. There are 4 chairs. Patient will come in the morning in the OPD. They will sit. Every day there will be 3-4 patients who are receiving the biological, and they would be comparing. So they had some 200-300 patients on biologicals, and it was safe. They were seeing so much of improvement, and so many patients were actually even going off the inhalers, which most of the severe asthma patients consider that the inhalers, so they have to take lifelong. So many of these patients were even going off the inhaler. So with this type of preamble, we'll just go into my session, my talk. So this was my experience with the biologicals. An overview of asthma, GINA guide shortly, and what are the biologicals which we are dealing with. So case 1 is a severe asthmatic patient. She was a middle-aged lady who was a teacher, who was asthmatic for many years. She was also diabetic. She had dyslipidemia. She had multiple hospitalizations. She had a history of COVID infection as well. She used to keep coming with breathlessness, wheezing, fever. We admitted. Now we found that these are the few important values here. One is the absolute eosinophil count, and one is the total IgE. So these are the 2 important values which we see in a patient who is coming with recurrent asthma. Are they eosinophilic subtype, and is their IgE raised? Because on these 2 values depend which biological we are planning to give for the patient. So for this patient, she also had an Aspergillus IgG positive. So we treated her as for ABPA, gave her steroids, itraconazole. X-ray was normal. CT scan was more or less normal, some small segmental epileptosis. So what did she receive? She received Levolin, Udecort, standard treatment, itraconazole. But in spite of that, she went on requiring multiple courses of oral steroid. So continued exacerbation. So we discussed with the patient that this is one of the options which is available. We can start you on mepolizumab injections. This will be once a month injection, and this will be given for a period of 1 year at least. Up to 6 months, we will see whether good response is there, and if no good response is there, then we will either stop or we will change the bulb. This was a discussion we had with the patient. Side effect wise, there is a small risk of anaphylaxis in all the patients with biology, but the risk is really small, 0.1 to 0.01%. We always administer the first injection in a hospital. For mepolizumab, the recommendation is that the next injections can be even taken at home. Usually we call them to the hospital and we administer the dose, but they can even take it at home with a trained nurse. So this patient has improved well. Now at least the oral steroid has stopped. So first 3 months she did not improve. After the 4th month, there is some improvement being seen. So we are still seeing now at the end of the year, we will really come to know. So this was one patient. This is another patient. This is a patient early days before the pandemic, before COVID. So this patient had come to me saying that I am getting recurrent exacerbations. The last exacerbation, patient had landed up in a hospital and he had been intubated. He had got a sudden severe exacerbation and his family is in Kerala. He's staying here alone. So they came very worried, saying that if these exacerbations continue like this, we cannot allow him to work. Child is studying in Kerala, we'll have to shift either the husband has to go or the family has to come, and they were extremely worried. So this patient had a raised IgE. At that time only omalizumab was available. We started the patient on omalizumab. And he responded very well to treatment. Symptoms improved. He stopped the oral corticosteroids, nebulizations, continued the steroid, continued omalizumab for 2 years and was able to continue work in Mumbai. So he came so relieved because his oral steroids had stopped. He was on continuous nebulization. So even first the steroids were stopped oral, then the nebulizations were reduced to the regular inhalers, which he continued. So last 1 or 2 years he's not followed up. In between the COVID pandemic, I don't know whether he returned or he didn't, but till then he was absolutely fine, did not get any exacerbation after that. So this was a very gratifying result which we saw in our patient. So this is another patient in whom again, so this is a lady who had received, so she's a middle-aged lady, she's continuing severe asthmatic. Around the COVID pandemic time, she had been started on omalizumab, which because of recurrent exacerbations, she received treatment for a year or year and a half, during which she improved well. She was off steroids, she was not getting any exacerbations. And the improvement lasted for almost a year. After that, again, slowly the exacerbations have started. So we have actually restarted her on omalizumab. We considered whether she can be given any other, but all the time her eosinophil will be just 0. So she was not really a good candidate for the other 2 biologicals where you need some, at least more than 150 of absolute eosinophil count. So she's been again restarted on omalizumab. So this can also happen once our patient is, but omalizumab can be given for a period of 2 years, 3 years. Even though it is given for a prolonged duration of time, there is no significant increase in the adverse effect seen with the omalizumab as such. So if the patient is tolerating it well and has no history of any anaphylaxis or anything tolerating, we can continue to give it. So it has been studied for 3 to 4 years as well. So this patient has been advised to take 1 more course of the omalizumab. So this is another patient. Now this patient was a patient with rheumatoid arthritis and ILD. She was on maximum rheumatoid arthritis disease modifying anti-rheumatic drugs. And she used to come with exacerbations. She occasionally used to be on oxygen. She would always come on wheelchair. Always I get depressed seeing her. She always had an asthma history also. Strong asthma history. She will have bronchi, not like a typical ILD which will only have crepitation. So she would have wheezing and recurrent exacerbations, seasonal changes. So we decided that we would put her on mepolizumab. So we started her on mepolizumab because we discussed with the family and these were her reports. The absolute eosinophil count was high, 718. So she was a high eosinophil subgroup. The chest X-ray shows some shadows. So usually we always should take a chest X-ray in asthma patient. Asthma patient X-ray should be normal, or there might be mild emphysema if it is a COPD or it's a long-standing asthma. But there will be no other shadows. There should not be, unless there is a infection or there is an. Many times interstitial lung disease can be there quietly masquerading as asthma. So you should always, if any shadows are there and you are suspecting, go for a CT scan. Make sure that there is no underlying interstitial. This patient of course had interstitial lung disease. So we gave her, because of the eosinophil, she was started on mepolizumab. And she really had a very good response. Like within few months, she was off her oral steroid. She would come walking to the OPD. And her son was quite smart. So he mobilized the medications and everything. And he would give the medication with a trained nurse at home itself. Only the first injection she took in the hospital. Rest she would take at home. And he was very happy. So he has continued the treatment for a year and he was even ready to continue. So we said we'll see her symptoms and if required we can continue for an extended period. She really improved. She comes walking, she doesn't get exacerbation, she's off the oral steroid, she's only on the treatment for the rheumatoid arthritis. So her rheumatologist who used to treat her, she was Dr. Varsha Babul. So she was like so impressed. Every time she would send all her other ILDs also to me, you start her on this medicine. So I said no, this is only for asthma subset. Because of her underlying asthma, we could start her and improve her. The ILD part will not really improve. The treatment is only the disease-modifying anti-rheumatic drugs. So this was another patient who had come. So he had started taking benralizumab, already started by another physician, and he had started improving so well that he was saying that he's never had such period of breathlessness free period, and he was so grateful that he was continuing on these medications. And he was also severe asthmatic, also a mild hypertensive. Even his hypertension had reduced once the acute attacks of asthma had started reducing. So this was another patient who had received omalizumab once for acute allergic dermatitis. He also had mild asthma, but his main problem was dermatitis. He had improved somewhat with the omalizumab, but he had again come to me saying that I want the further treatment, because with the omalizumab, once it is stopped, again my symptoms have started. So he was started on benralizumab, with which he had a significant improvement on his symptoms for allergic. So allergic rhinitis, nasal polyposis, these are also particular subgroup of patients where we can give this omalizumab as if it's a high eosinophil count subset, we can treat with mepolizumab and benralizumab. In this talk, I'll mainly talk about these three because these are the available medications. So we will come to that. So omalizumab, mepolizumab and benralizumab are the currently available medications. There are much more which are due to come, but this is what we have experience with at present. So this, as I told you, there are two definitions which we must remember: difficult to treat asthma and severe asthma. So difficult to treat, there are still many things you can do. Severe asthma, you have done all those things and yet the patient is not responding. Means is a true non-responder, and you may have to consider other therapies. So one of them is the omalizumab. One is to continue low-dose oral steroid. One is the bronchial thermoplasty was being tried, but since the results are not that good, it's not really being continued much. So you see how it is. 24% you have patients who are on step 4 to 5 treatment. Out of the 17% are difficult to treat asthma, and out of which around 3.7% are severe asthma. So these, considering the huge number of patients asthmatics, it's a very large number who are actually having severe asthma and who need this biological treatment which we, or additional treatment which we need to give. So it affects a huge number of people, national burden. Almost 50% of the patients are not well controlled, and it's a significant burden on school, work, hospital admissions, recurrent cost to the family, because the main young people are the ones who are usually having this problem of asthma. Of course, we have to always remember to check the inhaler, whether they are taking properly, ask them every time, ask them to come back, ask them to show. So there's a lot of issues in this inhaler use and inhaler therapy, but in this talk we are assuming that we are seeing that and then we are going ahead. So suboptimal adherence, this is one of the main problems for asthma control. So any patient who comes before you label as difficult to treat, severe, anything, always check the inhaler, ask them, ask the relative whether they are really, most of them will, instead of twice a day, they will take once a day. Instead of once a day, they will take alternate day. If it is inhaler, they may not be using it properly. Many times even with the some of the devices, they don't know how to open it, they don't know how to inhale properly. With the rota cap, all the devices have their own issues. You have to check, recheck, keep counseling and motivating them to use it. So this is about adherence. This is a GINA guide. So we have the GINA guide. We know that we have 2 tracks. We have the track 1 and we have the track 2. So in this there is a reliever as needed. So the main change in the GINA guideline was that use the reliever as needed with the inhaled corticosteroids and the long-acting bronchoagonist. So earlier it was you can just use a SABA as a reliever, but you always try to use an inhaled steroid also as a reliever, because the steroid component is one of the main treatments for asthma. However much patients, relatives, we resist the concept of giving steroid, we have to make the patient understand that inhaled steroid does not much go into the body. Inhaled steroid is a very small dose. Like when we are giving 200 of say formoterol of budesonide, it is 200 microgram. So 1 gram is 1000 micrograms. So you are giving less than 1/5 of a milligram. And out of that only 10% actually goes into the bloodstream. So even less than that, so about 20 microgram is going to the blood. It's very, very small percentage. It's like a homeopathic dose. This is what I try to explain. So it doesn't cause those side effects which people are really scared of, growth retardation, diabetes. It doesn't. So we must tell the patients, educate the patient about it, and encourage the patient to use their medication. So again you have, yeah. So oral thrush is one of the complications of the inhaled steroid. So to get around it, what I tell the patient is use the inhaler before food, so that automatically your throat gets cleaned. Of course, you advise them you rinse and gargle, but practically many patients don't rinse and gargle. So if they use it before food or even before brushing their teeth, before brushing their teeth in the morning, before brushing their teeth in the night, automatically your mouth rinsing, gargling gets done. So the chances of oral thrush become very less. It's only in patients who are very severe or in the ICU or something, then it becomes difficult to really monitor. They're not able to gargle, then the chances of oral thrush are there. So this is a trick which actually I use, and with that many patients. But still we have found even patients with inhaled steroid, even those who are not immunosuppressed, they have even esophageal candidiasis. Like many of them come with recurrent GERD or other gastric symptoms, and we ask them to undergo OGD-scopy. We have even found esophageal candidiasis in some of these patients. So all said and done, we should try and minimize the steroid inhalers which we are giving as much as possible. So it's always you have to weigh the benefit with the risk. If the patient is going to come with exacerbation, not able to breathe, feeling suffocated, not able to go to school, college, work, you have no option. You have to treat the asthma. So we have to just give the counseling as required. So now which treatment is for whom? So you find that in asthma also you have a eosinophilic subset, you have a neutrophilic subset, and you have a polygranulocytic subset. And this eosinophilic subset mainly is mediated by this IL-4, IL-5 and IL-13. So if you find these are the targets for these drugs which we are using, biologicals. So there is anti-IL-4 which is dupilumab, there is anti-IL-5 and anti-IL-5 receptor antagonist. So these are the two. Mepolizumab is anti-IL-5 and anti-IL-5 receptor antagonist is a benralizumab. So these are the two main drugs which are currently available. And also IL-13 and also IgE. Anti-IgE is omalizumab. So for omalizumab you need that particular IgE threshold. You must remember while giving omalizumab, the dose you have to calculate based on the weight and based on the IgE level. And also more than 1500 IgE, it becomes very difficult to give that much of omalizumab because you have to give it subcutaneously. And how much can you keep giving injection? You can't give 3-4 injections to the patient. So then the dose becomes too much, and the cost also keeps on increasing as per how much. So you have 150 mg in one vial, you give 300 mg. You can give 300 mg twice in a month if you need a higher dose. So this titration is required. So this titration is not required for patients with mepolizumab or benralizumab. It's a fixed dose. So you don't have to bother how much eosinophil it is. You don't have to bother. Eosinophil has to be high. So like more than 150 at least previous 1 year at least more than 150. So that is the revised guideline. If it's more than 300, all the better. So that's it. But you don't have to calculate the dose based on the weight. You don't have to do all that. It's a fixed dose for these patients. We'll come to how much dose it is. So that is the advantage. So basically this is the GINA guideline. What it says, you confirm the diagnosis, look for factors contributing to symptoms, see the inhaler technique, see if comorbidities are there. So remember to rule out gastroesophageal reflux. If it's there, you must treat. Rule out rhinosinusitis, like Dr. Rashmi is going to talk about rhinosinusitis now. So these are the factors which will prolong cough, worsening, breathlessness, wheezing, which if you miss, then it is no use giving biological to the patient and patient is having GERD. So this is right in the beginning, we have to rule it out. Any infection which is there, patient not taking the medications properly, home, patient may having pets at home, patient having a lot of exposure of building or undergoing construction right next door. I tell them you shift from there, because what is the use of giving biologicals when the patient is continuously going? If they have molds at home and that is causing trigger, if they have any aspergillus, so check for that aspergillus. Nowadays more and more patients we are finding that the ABPA profile is very high for aspergillus and we are having to give itraconazole for them or antifungal treatment for them. So rule that out. So these things have to be ruled out before you start thinking. Educate for asthma, consider all the other non-pharmacological methods. Air purifiers can also help. So earlier I used to not recommend, but there are studies which have shown that air purifiers actually lower the air purifiers, house, home, bedroom air purifiers. They lower the dust level in the environment and they can help in improving the nocturnal symptoms of asthma and other symptoms. After that you see, give the full treatment, give the all add-on treatments. Add-on treatments like Montelukast, add-on treatments, theophylline, So after all that, then you see whether the patient is getting well controlled with the asthma. Then they come into severe asthma. So once, so as we said, we can do a skin prick testing, like Dr. Bhumika is going to talk about the skin prick testing, and see whether there are any specific allergens which are easily avoidable, or which are easily, you can do the desensitization. Maybe that treatment may be better suited for the patient. If the blood eosinophils is more than 300, look for, treat non-asthma causes, see whether there is any helminthic infection in this patient that is causing the triggers. See whether there is any tropical pulmonary eosinophilia, whether that is causing. So these are the things. See whether it's a hypereosinophilic syndrome. So see for these. See whether there is any too much stress going on in the house. That can also trigger the asthma. Maybe the patient needs a psychological counseling, psychiatric treatment. That might also help. So these are the extra things which we have to do. You can check the sputum as well. See for the sputum eosinophilia. See for a high dose CT scan, see whether there is anything else, some small tumor over there, some small pleural effusion over there. Cardiac factors are often missed. Cardiac asthma patient is having a mild IHD or a heart failure, kidney failure, causing a small fluid overload. All these can cause breathlessness, worsen asthma, and we are not picking it up. They may have an ejection fraction normal, but they may have a diastolic dysfunction that can cause asthma-like symptoms. So these are the important things to rule about. So then once you rule that out, then you give the proper treatment, then you see about the cost. Then we come to the, and see whether the patient can take the cost of the treatment. The cost of the treatment, like for anti-IgE treatment, omalizumab, injection cost is about 11,000 for one vial. Usually we have to give 2 vials, so it comes to about 22,000. It's a once a month. If the IgE level is very high, we may have to give twice a month. So then it will come to about 44,000 in a month. So similarly, mepolizumab, after everything said and done, the cost comes to about 30,000 per month. Similarly, when benralizumab, with all the, although the actual cost of the drug is high, they have, company has some schemes by which they can do one something free. With all that, ultimately it comes to about 30-40,000 per month. A heartening thing is that many of these biologicals are now being covered by the insurance people. Some of the companies obviously cover for their employees, but some of the insurance also covers. So we can take the help of their health insurance and see whether this can be covered. So this is about the cost. So this discussion will have to be done with the patient.
How do you identify these subsets?
Yeah, I'm coming to that. How to identify. Okay, so basically in here also it is explained. So anti-IgE, omalizumab, it is increased IgE. So you look at the IgE more than 1000 or IgE only high with no eosinophil, no raised eosinophil, then it straight away omalizumab would be the right choice for the patient. Only if the eosinophil is raised would the other subsets come into action. That is the anti-IL-4, anti-IL-5. So in anti-IL-4 and anti-IL-5, it is more or less it is a high eosinophil asthma. Somewhere there is nasal polyposis, you can go for a benralizumab, which is more, but both of them have now been approved for the nasal polyposis. So mepolizumab as well as benralizumab have been approved for the nasal polyposis. So whether they have had exacerbations, how many exacerbations they have had in the last year, how much is the blood eosinophilia level. So based on these, and the last anti-TSLP, that is the thymic stromal lymphoprotein, that can be given for both patients with, even if the IgE is low, as well as if there is not much eosinophil, but that has not yet come in the market yet. So we are basically having these two. We are basically having omalizumab, which is for raised IgE. We are having mepolizumab and benralizumab, which is for raised eosinophil. So the IgE may be raised or may not be raised, but there have to be eosinophils. So that is basically. And between mepolizumab and benralizumab, there is not much different indications as such. They patients mostly are in the same subset of high eosinophil asthma.
Some of the patients they get frequently there's eosinophil even after the treatment,
Yeah.
treatment day, after some time again they get.
Yeah.
So what should
You can't do anything just for treating the eosinophilia. You can treat the anti-helminths. In fact, you can do an anti-helminthic treatment even before you put the patient on biological. You don't have to, you can see whether they have any tropical eosinophilia. Otherwise, if they are a subset of allergic patients who are manifesting with a high eosinophil type asthma, you can't really target to reduce the eosinophil. Of course, benralizumab will bring down the eosinophil. You give one dose of benralizumab, next blood count, the eosinophil practically will be 0. It really brings down the eosinophil level. So that is one of the things. But we don't do it to bring down the eosinophil level. That is not the target. Similarly, when we give omalizumab, the IgE level doesn't come down. You have to tell the patient first only. They will say, omalizumab liya, abhi bhi mera 1500 tha, abhi bhi 1500 hai. Utna hi rahega. Only the effect of that IgE will come down, not the number of the IgE. Although eosinophil will come down with benralizumab, it will not come down with mepolizumab so much. So you see whether the patient is eligible for the IgE. So in IgE, another thing is when you're considering omalizumab, see whether they are having a positive skin prick testing. Okay, so they have a specific IgE. Then you have the total serum IgE which is raised, and see how much exacerbations they have in the last 1 year. This is to see if they are eligible for the omalizumab. The anti-IL-5 or anti-IL-5 receptor blocker. Again, see the exacerbations in the last 1 year. See the blood eosinophil level more than 150 the previous one, or more than 300 any time in the last 1 year. Or if the patient is eligible for IL-4, again it is exacerbations, again it is blood eosinophils. Also you can see the FeNO, whether it is high, a high FeNO, taking oral corticosteroid, all is evidence for giving the benralizumab. And in TSLP you don't have to see IgE or this thing, you only see the exacerbations in the last 1 year. This is the recommendation from the GINA itself. So once you decide to start the patient on these biologicals, you tell the patient that we will be giving for 4 to 6 months. First 4 to 6 months there may not be that much response. After 4 to 6 months only we will be able to gauge whether response is there or not there, and then we can consider changing to another group of biologicals if there is no response with the first biological. Again depending on the eligibility criteria. So now we will talk about a few biological agents which are there, that is omalizumab, mepolizumab, dupilumab, benralizumab. So which are the biologicals? So although this is a busy slide, I just want to show this is the from the NEJM of 2022. So this was just to show. So benralizumab, dupilumab, mepolizumab, these are the main biological therapies which are available, and there are proper recommendations, doses. We'll come to one by one, so that will be easier. So when you see omalizumab, you have moderate to severe persistent asthma, positive skin testing, or in vitro reactivity, inadequately controlled. So we already discussed that. What is the dose? So it can be from 75 to 375 mg. It's all subcutaneous. And what are the side effects? You can have muscle aches, joint aches, fatigue, injection site reaction. So these injection site reactions can be seen in 5 to 10% of the patients. Muscle pain, joint pain, these are commonly seen. Similarly, we will come to mepolizumab. Here again it is 100 mg subcutaneously, and it is once a month. Treatment recommendation is for 1 year, but you can go on up to 2 years. For benralizumab it is 30 mg every month for the first 3 months. After that it is alternate month. So many patients like this because it is after the first 3 months you can take one injection every 2 months for the subsequent completion up to 1 year or 1.5 years. We will not go into the others because we are not. Won't go into the details of this slide, just to show that it is the eosinophils, the mast cells, all these mediators which are acting, which are triggered by the allergens, by the viruses, and which are actually provoking the asthma in these patients. So how you can see that all these mediators have been studied, and there have been targeted therapies tried with each and every one of the mediators, few of which are now we are using as a treatment. So here again you can see with IL-5, these 3 work. For IL-13, dupilumab, this one works. Omalizumab works for the high IgE. For the thymal stromal lymphopoietin group, this one works. So we have various, even for the low ones, even which are mediated through the neutrophils and the polygranulocytic, even for that there are biologicals which are available, which are not being used. So here again you can see how the biologicals are targeting the IL-5 and the IL-5 receptor antagonist. So you can see IL-5 is mepolizumab and receptor antagonist is the benralizumab. So we'll skip that. So of course there is cost, but we have to see whether the benefit is outweighing the cost. Even a single hospital admission, that itself takes a lot out of the patient in terms of finances, in terms of work days lost, and the quality of life itself. What is the quality of life for a patient who is continuously feeling breathless? That is a very subjective thing, and if you, most of the patients really, when we explain and tell them, they are very okay to use. It's only the cost, somehow they have to figure out how they are able to afford it, and many of them, they pay their own pocket and they use, and they say that we have so much improvement from what experience we are having. So I think biologicals will be more and more used in the days to come. About omalizumab, it inhibits allergen binding, suppresses the new IgE production, down-regulates the IgE receptor. So it down-regulates the action of the IgE receptor on the mast cells and basophils, reduces the efficiency of the antigen presentation to the T lymphocytes. So it has various mechanisms by which it works. It doesn't just bring down Ig level, which it doesn't mostly, but it reduces the effect of that Ig on the mast cells, the various mediators. And this is the effect which has been seen. So this is the results which are seen with the omalizumab, the reduction in the asthma exacerbations, the reduction in symptoms, reduction in the oral corticosteroid use, you can see in the graph. Similarly, for the IL-5 targeted therapy, it works on the eosinophils, basophils, mast cells. All these mediators which are released are reduced. It works on the differentiation, maturation, activation, survival, everything of the eosinophils. So this is a decrease in the asthma exacerbations, improvement in the quality of life, decrease in the airway wall thickening actually on the CT scan. That itself gets reduced when we use the mepolizumab. So these are the different effects. So these are the ones which are used. Now what is the problem? So it can cause hypersensitivity reactions. More is seen with omalizumab than with mepolizumab and benralizumab. In fact, for benralizumab and mepolizumab, there is an advice that patient can even take it at home. But for omalizumab, you have to give the injections in the hospital. Make sure that there is a cover in case there is an anaphylactic reaction which is happening. So we give it in the emergency room usually. The others we recommend at home. So these are the challenges of asthma management. Trial showing reduction in exacerbation from 25 to 60%, decreased hospitalization, steroid sparing. So this is the various effects of the biologicals. So this was just in brief about the biological treatments in asthma. So thank you so much. We can have the remaining questions in the panel discussion also. I will be there. So if any questions are there, we can take at that time.
Thank you, Dr. Jayalakshmi. You are always wonderful speaker. Now I request Dr. Asha Shenoy to come forward and give token of appreciation to Dr. Jayalakshmi. Now I request all the speakers present here, please come for group photograph. डॉक्टर देवेन पाल को जाना है, सो हम जो भी लोग हैं एक ग्रुप फोटो ले लेते हैं. आइए डॉक्टर रश्मि, डॉक्टर रोहन आइए प्लीज, डॉक्टर रविकांत प्लीज आइए. अच्छा हो आप एक ग्रुप फोटो आइए. आप थोड़ा सेट करो, आ जाइए. डॉक्टर देवेन सामने है, देवेन सर सामने है. एक दो नहीं ठीक है.
स्लाइडली और हम लोग तीनों शिफ्ट होना. रोहन सर आ गए.
Thank you all the speaker. Our next speaker is Dr. Bhumika.
Thank you, Dr. Jayalakshmi. Next speaker is Dr. Bhumika Madhav. She is a consultant chest physician at Apollo Hospital, Navi, Mumbai, with 8 years of wide work experiences. She did MD Pulmonary Medicine from D.Y. Patil Medical College, Navi, Mumbai, and her special interest is in bronchial asthma, COPD, pulmonary TB. She did advanced course on diagnosis of allergy and immunotherapy. Also, she did a diploma in pediatric sleep medicine. Numerous prestigious awards, papers, and publications to her credit. Dr. Bhumika is a life member of various respiratory societies and associations. She is the organizing secretary of today's CME from Apollo. Now I invite Dr. Bhumika Madhav on dais for her talk on skin prick testing and allergic desensitizational role in the asthma management. Over to Dr.
Thank you so much. I would like to thank Dr. Jayalakshmi ma'am for giving me an opportunity to talk here today. Thank you, IMM Navi Mumbai. Thank you, Rajeshri madam, Sangeeta madam, for the kind introduction. So I'm going to start with a case. This was a 28-year-old female who had come to the OPD. She had complaints of cough on and off since childhood, and she had symptoms which had worsened in the last 2 years. She had complaints of breathlessness, childhood history of asthma, occasional history of watering of eyes, and running nose was present on and off. She also had history of conjunctivitis on and off. Grandmother had an history of bronchial asthma. Vitally, the patient was stable. She had mild bronchi. So what investigations would you like to do for this patient? Okay. So this is a chest X-ray. The chest X-ray is normal. The CBC was done. It was normal. It had mild AEC, which was increased. Other blood reports were normal. IgE was mildly elevated. What other tests would you like to do for this patient? X-ray was normal for this patient. Any other test? Okay. PFT showed mild obstruction. Any other test you would like to do? So I'm going to be talking about skin prick testing. This is an additional test which can be done in patients who have a history of atopy. So my scope of lecture, I'll be talking a little bit about allergy testing. Mainly I'll be focusing on skin prick testing, the indications, contraindications, the procedure, interpretation, and a little bit about allergic desensitization. So what is an allergy? Allergy is a hypersensitivity disorder of the immune system. What is an allergen? Any antigenic substance which can trigger an allergic state is called an allergen. It can be a protein, it can be a chemical substance. So allergy is basically a type of hypersensitivity reaction. Dr. Zala has already explained to us in detail about the various types of hypersensitivity reactions. And it is basically a type 1 hypersensitivity reaction, and it is characterized by excessive activation of mast cells, basophils, and it's an IgE mediated response. Dr. Zala has already explained this to us. So type 1 is an IgE mediated response, type 2 is IgG or IgM mediated, 3 is again IgG or IgM mediated, and 4 is T cell mediated. Example of type 1 is basically our atopy, asthma patients, allergic rhinitis, all are allergic patients. Type 2 is can be seen in transfusion of mismatched blood type, and type 3 can be seen in RA, SLE. It is also the mechanism of hypersensitivity pneumonitis, and type 4 can be seen in allergic contact dermatitis. Now skin prick testing, basically we see the IgE mediated response, so it's a type 1 hypersensitivity reaction. So various tests which are there for diagnosis of respiratory allergic disorders. There are in vivo tests and in vitro tests. The in vivo tests include skin prick testing, intradermal testing, patch testing, and certain provocative tests. And the in vitro tests include serum IgE, total serum IgE, and then specific IgE, which are the immunocap or the Fadiotrope tests which are available. This is just a summary of all the various allergy tests that are used. Skin prick testing, I'll be talking about it in the next slides. So in the skin prick test, only the epidermal layer is pricked, whereas in the intradermal test, it goes into the dermis. The chances of anaphylactic reactions are slightly higher there as compared to skin prick testing. When we come to in vitro testing, the specificity and sensitivity of IgE is very low, and serum specific IgE is basically indicated in those patients where we cannot do a skin prick testing, and in those patients where we cannot discontinue the medications which are required to do skin prick testing. And if there is a strong clinical history and the skin prick test comes negative, that is when we can consider doing serum specific IgE test. So what are the indications of skin prick testing? Basically, Dr. Jayalakshmi has told us in detail about the history. The most important part is history taking. We need to, and Dr. Zala has also focused on history. History is the most important thing. We need to know the history of the patient. Based on the history, we can have an idea about what the possible allergen is. We need to know everything in detail, whether the allergy is at home, whether it's at office, whether it's on the way, the number of people who are staying in the house, everything we should know in detail. Once we have a detailed history, then we can do skin prick testing. We want to do skin prick testing basically to confirm our diagnosis and to tell the patient which kind of allergen we want to avoid, and the other and either to start immunotherapy. Common indications of skin prick testing are rhinoconjunctivitis, rhinitis, rhinosinusitis, asthma, dermatitis, food allergies which can cause anaphylaxis, acute urticaria, flare-up of eczema, angioedema. The allergens which are involved in these could be airborne allergens, aeroallergens, food and drugs. Drugs already sir has spoken about in detail. The uncommon indications are chronic urticaria where you're suspecting aeroallergens or food allergens being a suspect, in ABPA, in cases of migraine which could be related to food or other comorbid conditions, and in cases of Meniere's disease where food allergy is suspected. What are the advantages of skin prick testing? It is a simple, inexpensive, reliable and reproducible test. It gives quick results, and skin prick testing along with the clinical history is a very accurate diagnostic tool for diagnosis of allergies. When should you not do skin prick testing? When the patient is coming with acute exacerbation, that is when you don't want to do it. You do it when the patient is relatively stable. So if the patient comes in exacerbation, you probably have to wait for a month till he's stable and then plan for a skin prick testing. Absolute contraindications: pregnancy, severe dermatographism, in the absence of normal skin, uncooperative patients, patients who are taking drugs which may hinder action of epinephrine, and patients who are taking medications which cannot be taken and have to be stopped before the test. Relative contraindications, it is the age. So basically the age less than 5 is when we try and avoid doing a skin prick testing. But if the child is extremely allergic, you can consider doing it. It's a relative contraindication. Choice of allergen. The choice of allergen depends on the history of the patient, and it depends on the prevalence of certain allergens in the area. What is the maximum number of allergens that can be tested at one time? So there is no exact number of allergen which can be tested. There is no consensus on that. But there have been studies which show that about 50 to 80 allergens can be used at one time. But the most important thing is when you use an allergen, there should be a 2 centimeter gap between the allergens so that you don't get false positive reactions. The common allergens that we see are house dust mites, various kinds of pollen, fungus, insects, animals, pet animals, dogs, cats, and in the food we see commonly milk, egg, peanut allergy, soya bean allergy, wheat, tree nut, fish, shellfish, even prawn allergy is very common. So this is just a list of all the aeroallergens which are there in pan India. pollens, fungi, insects, the house dust mites which are there, which cause respiratory allergens. This is particularly for West India. So you can see in the pollen there are acacia species, in the fungus there are aspergillus species, mucus species, there are weeds, grass and other things which are there. So this is house dust mites. House dust mites are one of the most common causes of indoor allergens. These patients typically present with symptoms which are worse early morning or worse when they are inside their bedroom. And these are three types of house dust mites which are there. So house dust mites basically they feed on dead skin, and the excreta which is there, that is the aeroallergen part. So we inhale that and it causes problems. These are a few examples of pollens which are present, and this is a pollen calendar. So we have to keep referring back. So depending on the patient history, suppose the patient tells you that his symptoms are more during the rainy season, we have to refer back to the pollen calendar and see which are the in your area which are the common aeroallergens which are there, and then make sure that you test them as well. These are a few of the fungus. So preparation for skin prick testing, written informed consent have to be taken. The patient has to be explained about the risks of the procedure. Patient has to be told that there is a mild risk of anaphylaxis. It doesn't usually happen in skin prick testing, but you should let the patient know about it. And if there is any contraindication for skin prick testing, we do not do the test. One person should accompany the patient so that if there is any adverse reaction, somebody is there. And patients who have hairy arms, they are advised to shave at least 48 hours. And medications that are interfering with the skin prick testing have to be stopped. These are a few list of medication which need to be withheld during the before the procedure. So mainly antihistaminic. Antihistaminic have depending on which antihistaminic the patient is taking, between 3 days and 7 days it has to be stopped. Steroids, if the patient is on long-term steroids, then you have to stop them and then only do the procedure. For short-term steroids, there is no indication to stop it prior to the allergic skin prick test. When the patient has taken omalizumab, you have to wait at least 6 months before doing a skin prick testing. The procedure. So we need to have a emergency kit in place in case there is an anaphylaxis. So adrenaline, pre-filled adrenaline syringe should be kept in place. Steroid injection, antihistaminic, all should be kept before starting the procedure. We need to reassure and explain the procedure to the patient in detail. Site of skin prick testing is a volar aspect of the arm, upper arm and back. So we have to make sure that 5 centimeter and the volar aspect, and near the 3 centimeter in the antecubital fossa, we do not do the skin prick testing, and there should be at least 2 centimeters space between each allergen so as to negate the false positive reaction. Then after that, we mark the mark on the skin with a marker or a pen. Then we apply a drop of the allergen. We have a skin prick test kit which is there. We take the drop, we apply it, and with the help of a lancet, we go perpendicular, and just 1 mm, your depth has to be just 1 mm. You prick it, and then you wait for 15 minutes. After 15 to 20 minutes, you read it. There has to be a positive control and a negative control. Positive control is the histamine, and negative control is the saline. So this is a diagram showing skin prick testing. First we have marked, after that we have put the suspected allergen, then we have pricked it with the help of a lancet, and after 15 minutes we check the result. Interpretation. The histamine is the control, and it has to be read after 15 minutes, and the other allergen also has to be checked within 15 minutes. The wheel diameter, which see for the wheel when we see the interpretation, the wheel diameter of more than 3 mm is considered as positive. This is the grading of skin prick testing. Between 3 and 5 mm is positive, and we see the diameter. So not all erythema is going to be circular in shape. It comes in various shapes and sizes. So we see the mean diameter, mean wheel diameter. So the main wheel diameter we check by diameter which is of the largest area, we check that, and then we take the midpoint, and then we take a diameter from there, and then you divide it by 2. That is the mean wheel diameter. This is another picture showing the a positive response to skin prick testing. So what can the cause be of false result in skin test? We can get false positive if there is an impurity in the solution. If too much solution is used, if we during the when we do skin prick test, there should be no bleeding. It shouldn't be very deep. And if there is too much depth, then it can lead to a false positive reaction. And if the patient has dermatographism, then it can lead to false positive reactions, especially if it's severe dermatographism. False negative, if too little concentration is used, if it's expired, there is loss of potency there. If too little volume is introduced, if insufficient skin penetration is done. Extremes of age, drugs which interfere with immune response, and disease which cause an attenuation of the immune response. Cross reactivity and incompatibility. Cross reactivity occurs between various proteins which are similar kind, like different kinds of pollen can be cross reactive. Food allergies also cross reactivity can occur. And there could be cross reactivity between cockroach, mice, and shrimps as well. Allergen incompatibility. When this is especially important when we want to prescribe immunotherapy. So you cannot mix the allergens which are incompatible with each other. What are the possible complications of skin prick testing? There could be local complications and there could be systemic complications. The local complications basically localized swelling which could be seen in that area. There could be a localized wheal or flare. These reactions usually regress in 36 hours. And systemic circulations, it begins 15 to 30 minutes later. It could be anaphylaxis, it could be vasovagus syncope. So we usually ask the patients to wait after the skin prick testing, especially if they have a previous history of anaphylaxis, for at least 20 minutes, just to make sure that there is no reaction. The other non-allergic reaction could be mild headache or mild malaise and risk of infection, but this is very rare. It doesn't usually happen. So skin prick testing is the gold standard for diagnosis of respiratory allergy. Coming to immunotherapy, I'll be talking about it in brief. Immunotherapy is mainly giving a small dose of the allergen and building up so that the patient becomes has an almost normal life. Whenever we do a skin prick testing, we either ask the patient to avoid the allergen, or we obviously continue the pharmacotherapy and we suggest immunotherapy. Daily use of pharmacotherapy for allergic asthma and rhinitis symptoms can cause issues related to adherence, safety, and cost. And patients may not take the medications properly. So once you initiate them on immunotherapy, certain like house dust mites and all do very well after you initiate immunotherapy. So first we do the skin prick testing. You determine what is the causative allergen. Then patient selection is very important. The patient has to understand that treatment will be going on for a long time, maybe 3 years to 5 years. So a patient has to be explained about that in detail. Selection of the allergens. We cannot use more than 4 or 5 allergens. So if there are 20 or 30 skin prick which is positive, we cannot use all of them. We have to select only 4 or 5 allergens that can be used for immunotherapy. It is not a replacement of medical management, and it is directed to shift the patient from a status of allergy to normalcy. So there are two types of immunotherapy. There is subcutaneous immunotherapy and sublingual immunotherapy. Subcutaneous immunotherapy is basically in an injection form in which the patient is given injections in a weekly manner. There's an initiation phase and a maintenance phase. In the initiation phase, we give small dose of injection, and then you build it up, and then you put the patient on maintenance phase. The problem with subcutaneous immunotherapy is compliance of the patient. The patient has to come to the hospital, sit there for half an hour, wait there, and go back. He has to take leave from work, so it becomes very difficult. Sublingual immunotherapy is basically you give the vial to the patient, you explain to the patient how it's supposed to be taken, and the patient can take it at home. So it's easier for the patient to take it, the compliance also improves. For sublingual immunotherapy, there are concentrated glycerinated allergen extracts which are there. You choose the allergen that you want to give, and the patient takes it accordingly. So maximum 4 or 5 allergens can be selected, and we have to make sure that incompatible allergens are not put together, otherwise it becomes non-viable. Such as insects and other aeroallergens cannot be mixed because of high protease extracts in the fungal allergen. And also we have to make sure that we factor in the cross reactivity. So there is a build-up phase and a maintenance phase. The patient is usually advised to take the medication at home for 3 times a week, 2 to 3 times a week. So the first vial is going to be the lowest concentration. It's going to be around 0.01% of the concentration, and we start with 1 drop. So you tell the patient that he's supposed to take. There has to be the patient has to be nil by mouth for at least 4 hours. You ask them to take 1 drop. Then on the second day there's a gap. On the third day there's going to be 2 drops. You increase the drops, so on and so forth till you reach 10 drops. This is the first vial. The second vial is going to be 0.1% of the stock solution. You start with the same process. You give 1 drop on the first day, then you give second drop on the third day, and then you build it up to 10 drops. This is going to go on. This is the build-up phase, and then you reach the maintenance phase. So basically, maintenance phase is when the maximum tolerable dose. So whatever the patient is able to tolerate, the maximum dose which the patient is able to tolerate, that is the maximum tolerable dose, and that is the maintenance phase. If the patient has any allergic reaction, any itching in the mouth or ear, any irritation, you are supposed to explain to the patient that the patient has to come to you in case of any reaction. Anaphylaxis with sublingual immunotherapy is very rare. So these are the references which I have taken to make this presentation today. Thank you.
Excellent presentation, Dr. Bhumika. Now you are very good speaker. Thank you very much. Now I request Dr. Nivedita to come forward and give token of appreciation to Dr. Bhumika Madhav. Photo कौन लेगा आपके? Thank you, Dr. Nivedita. Thank you, Dr. Bhumika. Our next speaker is Dr. Rohan Aurangabadwala.
Thank you, Dr. Bhumika. Next speaker is Dr. Rohan Ketan Aurangabadwala. He is a consultant chest physician and pulmonologist at Apollo Hospital with 13 years of wide work experience. He did MD Respiratory Medicine from Jaipur and advanced training in interventional pulmonology from USA. Dr. Rohan has wide teaching experience, also numerous prestigious awards, papers and publications nationally and internationally to his credit. Dr. Rohan is a life member of various pulmonary societies and associations. Now I invite Dr. Rohan Aurangabadwala on dais for his talk on ABPA, that is allergic bronchopulmonary aspergillosis and severe bronchial asthma case-based discussion. Over to Dr. Rohan Aurangabadwala.
think very good morning to all of you. Thank you, Dr. Jayalakshmi and the IMA Navi Mumbai for this opportunity to speak on allergic bronchopulmonary aspergillosis and severe asthma. Very underdiagnosed entity, something which we do not consider when we are treating asthma. So the point of this talk is to just make sure that whenever we're treating patients with asthma, and it is not something which is easily controlled, or they are having recurrent symptoms, or they are having recurrent exacerbations, we keep this entity at the back of our mind always. So what is going to be today's discussion? A brief introduction. How do you diagnose ABPA based on the clinico-radiological features, immunological findings, the diagnostic criteria, cases to just make us understand better as to how we approach these patients, the staging of ABPA, and the overall treatment overview. So it was first described as early as 1952 by Hinson. What is perplexing is almost 70 years or 75 years even after it is described, it is still an underdiagnosed entity. So that is where it should ring our bells, that we should start thinking about it upfront rather than later in the disease when it becomes so severe that your lung parenchyma gets involved. So it's a complex pulmonary disorder caused by an immunological reaction to the Aspergillus fumigatus. Now, Aspergillus fumigatus is a ubiquitous fungus. It is everywhere in the atmosphere. So all of us, including most asthmatics that we are treating, are exposed to Aspergillus fumigatus and other fungi which are in the Aspergillus group. It has been commonly described in patients with asthma and cystic fibrosis. Nonetheless, it is not limited to patients of asthma and cystic fibrosis. Even patients with COPD, structural lung diseases, or post-tubercular changes can also have ABPA. If not treated, what's the worry? It can progress to lead to end-stage lung disease or parenchymal lung disease, and the patient can be oxygen dependent, have cor pulmonale, and a poor quality of life. Almost estimated 2 million cases in India alone, making it the most prevalent Aspergillus related disorder in our country. It's a Th2 CD4 T cell response leading to inflammatory chemokines and cytokine release. So what are the clinical features? Most of these features would be present in a lot of asthmatic patients. They can present to you with recurrent wheezing, poorly controlled asthma or uncontrolled asthma, a more scientific term. They may have fever at presentation, just fatigue or malaise, weight loss. They can present to you with hemoptysis, expectoration of brownish mucus. This is something which is characteristic in ABPA. It may not be present in all the patients. In literature, almost 30 to 70% of the patients in varying studies have had this symptom of expectoration of brownish mucus plugs. And a lot of time, the patient may be surprisingly asymptomatic. What do you mean by asymptomatic ABPA? An asthmatic who has ABPA, but with your usual treatment of asthma, they do not have any symptoms. The symptoms are under control. So this is as far as the clinical presentation of ABPA goes. Coming to the radiological features. A lot of time, X-rays also can give you a clue to the diagnosis of ABPA. 50% of the patients may have a normal X-ray. But what has been classically described, or what is a teaching when we are doing our residencies or treatment, is if you start seeing opacities which are changing with each X-ray, the classical fleeting opacities, that is when your mind should start thinking whether we are dealing with ABPA. You can also have the classical finger in glove opacity. What do you mean by finger in glove? Because of the bronchiectasis and mucoid impaction, it gives an appearance as if you have gloved fingers there on the X-ray. And presence of bronchiectasis in a patient who has asthma should automatically trigger evaluation for allergic bronchopulmonary aspergillosis. What are the radiological features as far as CT chest is concerned? It will have bronchiectasis, predominantly central, but there can also be peripheral bronchiectasis, central lobular nodules, mucoid impaction, high attenuation mucus or HAM. This is pathognomonic. Presence of high attenuation mucus in a patient of asthma should be definitely considered as a sign of allergic bronchopulmonary aspergillosis. In fact, it has got 100% specificity. It is a rule-in test for ABPA. And very advanced diseases, you can end up having pleuroparenchymal fibrosis. It is the time that you miss the boat, and then it goes to just trying to make sure that the patient's quality of life is maintained. They do not have any hypoxia, worsening of cor pulmonale and stuff. So these are the CT images. At the top you can see the central bronchiectasis, also a little bit of peripheral bronchiectasis and mucoid impaction over here. So these dilated bronchi, the mucus can get impacted, leading to more cough. Secondary infections is a possibility. And as I said, high attenuation mucus. What do you mean by high attenuation mucus? If you look at the mucus here, it is almost as dense as the surrounding bony structure. So this is high attenuation mucus. This is very pathognomonic of allergic bronchopulmonary aspergillosis. Once you have these radiological investigations, the next step is to confirm. How do you confirm ABPA? It's based on a battery of immunological tests. What is available is the Aspergillus skin prick test. You have the Aspergillus fumigatus IgE, serum total IgE, IgG antibodies against Aspergillus fumigatus. What is available commercially in the market right now as an ABPA panel is a combination of Aspergillus fumigatus IgE, total IgE, and Aspergillus fumigatus specific IgG, and total eosinophil counts. So these are the immunological tests which are available. There is more research going towards components of Aspergillus, which is still not commercially available. It's going to be available in the near future. So those and studies related to that will give us more information that whether we are dealing with ABP or no, and the criteria may change in the near future. But as of now, these are the tests which are useful. Immunological tests. So first, let's talk about the Aspergillus skin prick test. It's an immediate cutaneous hypersensitivity. You can have a intradermal test which is more sensitive. However, the limitations are you need standardized antigen, trained personnel. There is a risk of anaphylactic reactions, though small. The sensitivity is around 88 to 94%. It can miss about 1 in 10 patients of allergic bronchopulmonary aspergillosis, and that is why it is not a good screening test. So you would not want to just do an allergic skin prick test, and if it is negative, say that patient does not have ABPA. So that's what I want to show with this slide, that that's not a good screening test. So what is a good screening test? Aspergillus fumigatus specific IgE. This is the hallmark or the screening test for allergic bronchopulmonary aspergillosis. There is a specific cutoff which has been mentioned by the International Society for Human and Animal Mycology, that is the ESHAM group, which has done maximum work on aspergillosis and ABPA. A cutoff of 0.35 kilo international units per liter is the criteria for ruling in or a screening test for ABPA. It has a sensitivity of 100% and specificity of 66.2%. So if the Aspergillus specific IgE is negative, it almost rules out ABPA. So the first test that you would want to order in a patient who is suspected to have ABPA is the Aspergillus specific IgE, and if that is negative, the story ends there. But you have to follow up. Sometimes initially a negative test, patient may later develop ABPA, but at that point of time it is not present. Limited utility during follow-up once you have established a diagnosis. So you have an ABPA patient, you have diagnosed, then there is no point repeating Aspergillus specific IgE once they are on the treatment, because rising or falling trends do not make any difference in the treatment of an ABPA patient. Coming to the total IgE, this is the next very important test for diagnostic criteria of ABPA. It's important in the initial diagnostic workup, and it is very, very important during the follow-up of patients once they are on treatment. Why are they important? For diagnosis, a cutoff of more than 1000 has been recommended, 1000 international units per ml. It has a sensitivity of almost 92%, a specificity of 40%. The cutoff, as I said, 1000 is the recommended value. And once you start treatment, this is what you are going to follow up. Once you see response, the Ig levels are going to start falling. And when you are having treatment ongoing, the least level that you achieve when you are on treatment is the baseline IgE level for that patient. So that will be the benchmark to see whether the patient is having exacerbation, whether the patient is having relapses, or patient is staying in remission. So once you start treating and the levels have reached a particular bottom and the symptoms have gone away, IgE that you achieve at that point of time. For example, if you started with 10,000 and now with 6 months of steroid treatment, you have reached a level of 2000. That 2000 is now the baseline for the patient, and that will be your benchmark to keep following up the patient in the future. if you see an increase in the Ig levels of more than 50% from this baseline, now it is 2000, 6 months down the line, patient starts having symptoms, and you do an Ig and you see it is 5000. So it's more than 50%. Even if you see 4000, it's more than 50% of 2000, which means now that he is going into an exacerbation of ABPA, and now is the time to start treating them with maybe steroids or maybe itraconazole. That's going to be a case-based approach. Aspergillus fumigatus IgG antibodies. So this is 100% specific for ABPA and has a sensitivity of around 90%. If you have that along with Aspergillus specific IgE and total IgE, it almost confirms, or it's a good rule-in test for allergic bronchopulmonary aspergillosis. So these are the immunological tests which are there. Eosinophilia also initially was thought to be a very important marker in ABPA, but there are studies which have shown that ABPA patients almost to the tune of 20 to 25% can have a normal eosinophil count. So absence of eosinophilia is not an absence of ABPA. That is very important for us to remember. A lot of patients with ABPA are going to have normal eosinophil counts. Multiple reasons for that. If they are already on steroids, eosinophils may be suppressed. So whenever you are testing, you have to be sure that you are off steroids for at least a period of 2 weeks. That will give you a right answer. If it's not possible, you have to test on the minimal possible dose of steroid where the patient's symptoms do not exacerbate. So that's where you look at it. The cutoff which is recommended by the ISHAM group is 500. So a count of more than 500 total eosinophil is again one of the criteria for the diagnosis of ABPA. So the traditional criteria when it was first put across were the Rosenberg-Patterson criteria, which had a set of almost 9 major criteria and 3 minor criteria. These are no longer the valid criteria for the diagnosis of ABPA. That is why I'm not going into the details of these criteria. It is just to make you know that these were the initial criteria, and then we have come a long way to the ISHAM ABPA working group criteria, where these are the criteria which are most widely used, and there is a set of newly proposed criteria which is coming on from our country, from the PGI Chandigarh group, which is the biggest group working on allergic bronchopulmonary aspergillosis in our country and worldwide. We'll be showing in the subsequent slide. There are only a couple of differences between the two. Predisposing criteria, you need a background history of asthma or cystic fibrosis. The essential criteria, you should have both of these criteria. As I said, Aspergillus specific IgE greater than 0.35 and elevated total serum IgE more than 1000. Additional criteria is Aspergillus fumigatus IgG greater than 27. Imaging, HRCT, which is consistent with ABPA, that is presence of bronchiectasis, and peripheral eosinophils greater than 500. So if 2 of these 3 additional criteria are met, a diagnosis of ABPA can be confirmed. The newly proposed criteria by the working group in India from PGI, now you can see they have included the other predisposing conditions. So asthma, cystic fibrosis, COPD, post-tubercular fibrocavitary disease. These patients can also have ABPA. The essential criteria are the same as the previous ones. Additional criteria, they have put a specific value for the Aspergillus fumigatus IgE greater than 27 milligrams per liter, and the remaining 2 are the same. So there are a couple of differences between the ISHAM group and the newly proposed criteria, but if you go by this, it's pretty much going to give you a diagnosis for ABPA. So just to understand it on a case-based perspective, this is a 51-year-old female, has a history of asthma for the last 9 years, poorly controlled, coming to you with complaints of fever, expectoration of mucus plugs, increasing breathlessness. She has been treated for pneumonia thrice in the last 2 years. Now, next. Yeah, it's come. So these were the X-rays of the patient. And if you look at the X-ray on the left-hand side, you can see that the right lower zone there is an opacity over there. And now in the present X-ray, you can see there is a right upper zone opacity, right lower zone opacity. If you look at it carefully, it looks like a finger inside a glove. And the very fact that these opacities are changing, and patient has had 3 pneumonia episodes in the last 2 years, you start thinking whether it's ABPA. What is often done is these are treated as pneumonias, often misdiagnosed. People don't think that they are ABPA. They give antibiotics. At the time, they also give steroids because it's an exacerbation of asthma along with an infection. What happens is we'll give antibiotics, we'll give steroids, the patient will get better. We think that the episode of pneumonia has settled, and then again when there is a next exacerbation, patient may present with the similar symptoms. So it was actually the steroids which worked with the ABPA and not your antibiotics. These were not pneumonias, these were flare-ups of ABPA which were missed. So what happens is you do the next step. And now that we have had the criteria, anybody from the audience, what would be the first test that you would do in this patient? Yes, Aspergillus specific IgE would be the first test. That's what we do. 3.15, way above the cutoff level. So what is the next step now? Yeah, serum IgE in the Aspergillus specific IgG. Serum total IgE 10,900, very high. Something wrong. Then you get the precipitin test or the Aspergillus specific IgE, again positive. High eosinophil counts. An HRCT was done which showed mucoid impaction in the right upper lobe and bronchiectatic changes in the right upper and lower lobe. Enough criteria, all criteria is met. The diagnosis is ABPA, there is no doubt. This is ABPA bronchiectasis, confirmed diagnosis. Now coming to the next case. 44-year-old female, asthma for the last 10 years, high doses of inhaled corticosteroids for the control of asthma, has had frequent exacerbations requiring short courses of oral steroids. So clearly uncontrolled asthma going for the last 10 years, young female. I think there's something wrong with the marker. So what next would you do here? Same IgE. But what was done? This patient came to us from somewhere else. She had had a negative Aspergillus skin test done. So somebody had thought of the Aspergillus, ABPA, but unfortunately had done a wrong screening test. Negative Aspergillus skin test, said fair enough, this is not ABPA, we'll continue with the treatment of asthma. So, हाँ तो हमारे पास जब आए तो हमने next वही किया. Next, a serum Aspergillus fumigatus IgE level was done, which was again more than 0.35, 1.21 kilo international units per liter. A serum total IgE was, however, 612. So now it is not meeting your criteria for ABPA. So here what you see, there is Aspergillus sensitization because your Aspergillus specific IgE is high, but your total IgE is 612. Next. She had a positive Aspergillus fumigatus IgG. Again, the total eosinophil counts were not too high and the CT chest was normal. So what is this? This is not meeting your criteria of ABPA. So what is this? Next. This is something known as severe asthma with fungal sensitization. So what is severe asthma with fungal sensitization? You have Aspergillus specific IgE positive, but the other criteria is not getting met. This does not mean that this patient cannot develop ABPA in the future. You will have to keep a close watch. Repeat your serum total IgE at a later date of time. And if you see that the trends are rising, you would make a diagnosis of ABPA later. So it's a spectrum. You have asthma at one end, you have ABPA at the other, you may have fungal sensitization in the center, and they can move across the spectrum from purely being sensitized to ABPA or the Aspergillus fumigatus to developing ABPA in the future. So these are a subset of patients who are going to require a close follow-up in the future. Next. Coming to the staging of ABPA. Now that we know what are the criteria, once you have started diagnosing ABPA and treating ABPA, what are the stages? Stage 1 is asymptomatic. Patients have criteria for ABPA, but they do not have any symptoms. They are very well controlled asthma. Second is acute stage. That is when they present to you with a lot of symptoms. If your CT scan shows mucoid impaction, that is 1A. If it is without mucoid impaction, it is 1B. But they have uncontrolled symptoms. This is the subset of patients you're going to treat with your steroids. Second is response. Once you have treated, you will start seeing a response. So this is stage 2 of ABPA, where you will have clinical radiological improvement. And what is the criteria to label response? Your IgE levels, the Aspergillus specific total IgE levels. Total IgE levels will fall by greater than 25% at 8 weeks. So if you have started with 5,000 and if you now see that it is less than 3,750, 8 weeks down the line, you're seeing a 25% decline in the total IgE levels, which means the patient has started responding. Next. Now that you have started treating, response aa gaya, patient symptomatically has got better. But when you do your next IgE levels, if you see there is an increase of greater than 50% from baseline, you are dealing with an exacerbation. Now you can again have clinical worsening or radiological worsening. Stage 4 is a stage of remission, means patient has got a sustained clinical radiological improvement and your baseline IgE levels have stayed the same for more than 6 months. So if you've reached from 5,000 to maybe 1,500, patient is completely fine clinically, and for 6 months you have followed up and again the IgE levels have not gone up, you know that the patient is in remission. Now if he comes to you with a worsening of symptoms, next thing you're going to do is do a IgE level. And if the IgE level is still around the same, it is an exacerbation of the asthma and not an exacerbation of your ABPA. It is also differentiate, you have to differentiate between the two because the duration of steroid treatment between the two is going to be completely different. Then you go to something known as treatment dependent ABPA. What do you mean by treatment dependent ABPA? You reduce the treatment, patient has an exacerbation. You reduce the treatment, patient has an exacerbation. So greater than 2 exacerbations in a 6-month period with worsening clinical radiological features is treatment dependent ABPA. Next. In that there is glucocorticoid dependent asthma, where you cannot taper off the steroids below a particular cutoff. Patient continuously requires steroids, so that becomes glucocorticoid dependent asthma and ABPA. And last stage is the advanced ABPA. This is what you do not want. Why do you want to treat ABPA? Because you do not want to lose the lung parenchyma. Losing lung parenchyma eventually leads to hypoxia. Hypoxia leads to cor pulmonale. Cor pulmonale can lead to right heart failure, a poor quality of life. You don't want your patients to land up there, and that is why you want to diagnose it early, treat it early. Next. So approach to diagnosis. What is your approach? I've already outlined it to you, but this will clear it further. A patient with bronchial asthma or cystic fibrosis or COPD, screen them with Aspergillus fumigatus specific IgE levels. If negative, there is no ABPA. However, if it is positive, the next step is going to be to do the total IgE levels. If more than 1,000, you proceed with further testing. If it is less than 1,000 and your asthma is controlled, then it is something known as Aspergillus sensitized asthma, extreme right corner. If your asthma control is poor, but your IgE levels are less than 1,000, that is severe asthma with fungal sensitization. That was the second case which I showed you. So that is not ABPA, but there is fungal sensitization which is there. It is new term for that is Aspergillus fumigatus associated asthma, AFAA. Now if you have total IgE more than 1,000 and your Aspergillus fumigatus IgG is positive and your CT scan shows bronchiectasis, then it is Aspergillus fumigatus as an ABPA bronchiectasis. If it is normal, it is ABPA at risk. But if you have both the additional criteria positive with a normal CT scan, it is known as serologic ABPA. Even serologic ABPA needs treatment because they have symptoms. Next, third case, just to wind up with the last 2-3 slides. 26-year-old male, well-controlled asthma for 6 years, low dose of inhaled steroids. He is well-controlled, but as I said, persistently requiring low-dose inhaled steroids. It is no harm in ruling out ABPA here. What is the next test we do? We do the Aspergillus fumigatus IgE. It is slightly elevated here, but the serum total IgE is 300. So if you now go back to the algorithm, this is Aspergillus sensitized asthma because the symptoms are under control. So when symptoms are under control, is this Aspergillus sensitized asthma, does not require any different treatment from your normal asthma patient. Your low dose inhaled corticosteroids can continue and the patient may continue to be under control. Next. 43-year female, asthma, well controlled again, one exacerbation which required oral steroids in the last 2 years. So what is the further workup? You do your IgE levels, negative, end of story. Don't need to do anything further. Treat it as pure asthma, no further workup required. Only in the future, if she keeps having recurrent exacerbation, do you revisit whether you want to test for ABPA later. So what are the principles of treatment? You want to suppress the inflammation which is there in ABPA. What you use is steroids or antifungals for the same. And what are your goals of treatment? 1, reduction of pulmonary infiltrates, control of the symptoms of asthma, treat the acute stage of ABPA, prevent exacerbations, make sure they go into remission, and prevent any progression to bronchiectasis or parenchymal lung damage. You should try and meet maximum of these goals. with minimum adverse effect to steroids. So what is the baseline of treatment? What is the basic thing which holds true? Steroids is the cornerstone of treatment as of now. There are more studies coming up where they have initially just tried giving oral antifungals, but they are not the standard of care. Initial first episode of ABPA, you start with steroids, multiple regimens are available. You can start with 0.5 milligram per kg for the first 2 weeks and then taper further. Some people like to try 0.75 milligram for the first 2 weeks and then 0.5 for 4 weeks and then taper over a period of next 6 weeks. So initial 3 months of treatment, and at 8 weeks you would want to see whether the IG levels are responding. When severe exacerbations, there are papers which say pulse therapy can be used, but most patients do not require pulse methylprednisolone for ABPA. Antifungals, they have been used as steroid sparing agents. What do you mean by steroid sparing agents? You've treated it once, gone into remission, had an exacerbation, you would start with steroids, but you would also want to start antifungals like voriconazole or itraconazole. What it will do is it will reduce the fungal load in the airways, thereby reducing the inflammatory response which is induced by the fungus, and which will allow you to taper off the steroids faster and get off the steroids. So that will reduce the side effects the steroids are going to have. The treatment duration is typically for a period of 24 weeks, that is 6 months. There are papers for nebulized amphotericin B, but it's not a standard of care. It's one of the rescue approaches when everything else has failed. So it's not something that you should do in your routine practice. Anti-IG therapy, madam has covered. Omalizumab also does have some role. There are a few papers which suggest that with high IG levels, when everything else is failing, you can try omalizumab 375 milligrams subcutaneously every 2 weeks for a period of 4 to 6 weeks. It may give you a good clinico-radiological response. So to conclude, in my practice, I do screen most of my patients with persistent symptoms of asthma for ABPA. It is the recommended test, that is Aspergillus specific IgE. Do it for most patients. If you see high attenuated mucus, it is pathognomonic of ABPA. Please do not ignore. Please treat the patients. The new criteria are currently the most evidence-based criteria and precise definitions for the diagnosis of ABPA. And the aim of treatment is symptom control and to prevent progression to parenchymal lung involvement. Every alveoli that you can save by instituting right treatment is going to go a long way in preventing end-stage lung disease in these patients. Thank you for your patient hearing.
Thank you, Dr. Rohan. Now I request Dr. Ajay Tilve to come forward and give token of appreciation to Dr. Rohan. Thank you, Dr. Ajay. Thank you, Dr. Rohan. Now it's time for tea break. जल्दी से चाय पीना है, जल्दी से वापस आना है.
अंधेरे से उजाले पे न तत्र सूर्यो भाति न चंद्र तारका नेमा विद्युतो भांति कुतोहम अग्निः तमेव भांतम अनुभाति सर्वम तस्य भासा सर्वम इदम विभाति. इसका अर्थ है सूर्य खुद स्वयं प्रकाशित नहीं होता, ना तो चंद्र तारका, ना तो बिजली स्वयं प्रकाशित होती है, तो अग्नि कैसे होगी? उस परमात्मा जो स्वयं प्रकाशित है उसी से आभा मिलती है सबको उजाला देने के लिए. Thank you all.
Thank you, आप सभी का धन्यवाद. Our next speaker is Dr. Rashmi Menon. Dr. Rashmi Menon is consultant ENT surgeon at Apollo Hospitals, Belapur, Navi Mumbai, with 30 years of wide work experiences and worked in all the reputed hospitals of Navi Mumbai. She did MBBS, DLO and DNB ENT from Calicut Medical College, Kerala. Dr. Rashmi has wide teaching experiences also. Served as lecturer at MGM Medical College, Kamote. Numerous prestigious awards, papers and publications to her credit. Dr. Rashmi is life member of various ENT societies and associations. Now I invite Dr. Rashmi Menon on dais for her talk on nasal polyposis and chronic rhinosinusitis. I request all the doctors, प्लीज़ चाय का कप लेकर आप यहाँ आ जाइए और शांत रहिए प्लीज़.
Good morning, everyone, and thank you for the invitation today to speak on allergy and asthma. Big thanks to the organizers, the IMA Navi Mumbai, and Dr. Jayalakshmi for inviting me here today. You've been hearing about asthma, allergic rhinitis, and being an ENT surgeon, I'm going to talk about the ENT aspects, that is about nasal polyposis and rhinosinusitis. A lot of patients come to me telling me that I have sinus issues since childhood. But when you take the history, you realize it is not sinusitis, but it is allergic rhinitis. So I would like to tell you the differentiation between allergic rhinitis and sinusitis, and the various differential diagnoses associated with allergic rhinitis, and also about nasal polyposis and allergic rhinitis, and also about nasal polyposis and how to differentiate a nasal polyp from a hypertrophied turbinate. And I hope this will help you in your clinical practice. So this is a comparison between allergic rhinitis and sinusitis. When you take the history, most patients with allergic rhinitis will complain of itchy nose and itchy eyes, which is definitely not present in sinusitis. The nasal discharge in allergic rhinitis would be clear, watery, and running nose, whereas in sinusitis it is always thick and yellow. There is absolutely no fever in patients with allergic rhinitis, and most patients with sinusitis will complain of low-grade fever. Headache and facial pain is very, very rare, or absolutely nil in allergic rhinitis, whereas it is a very common symptom in patients with sinusitis. Now, sneezing is a very important thing. You get recurrent bouts of sneezing, about 15 to 20 episodes in a day in most patients with allergic rhinitis, whereas in allergic sinusitis, it is very rare, maybe 1 to 2 episodes of sneezing. The treatment, and another thing is the duration. The duration in patients with allergic rhinitis, it lasts for just 1 or 2 hours till the patient is exposed to the allergen, whereas in all patients with sinusitis, the symptoms will persist for at least a week or longer. And the treatment, of course, depending on the symptoms, it would be either anti-allergics and nasal sprays in allergic rhinitis with antibiotics and mucolytic. We'll come to that shortly. The terminology for it is no longer called as sinusitis, but it is called as rhinosinusitis because there is an inflammation of the nasal mucosa along with that of the mucosal lining of the sinuses. It is the 5th most common cause for prescribing antibiotics, and acute rhinosinusitis can be divided into acute, subacute, and chronic based on the duration of symptoms. And in acute sinusitis, the clinical symptoms last for about 4 weeks or less. The causative agents for an acute bacterial rhinosinusitis is generally a mucosal allergy, which could be because of an allergen exposure or because of an LPR. Now, this is a very important thing. Most patients with laryngopharyngeal reflux, there are studies which show that there is some amount of mucosal injury in the nasopharynx because of prolonged laryngopharyngeal reflux. Another cause is hormonal, that is patients who are pregnant. Infections, of course, bacterial, viral or fungal. And major anatomic obstructive pathology such as a narrow osteometal complex, or an enlarged frontal cell, an infraorbital cell, or any trauma or a neoplasm. Systemic conditions like aspirin triad, a ciliary dysfunction, cystic fibrosis, and any immunodeficiency can also be a factor for sinusitis. This is the how the process develops. The initiating event would be an inhalant allergen which causes a mucosal swelling. This results in an obstruction of the ostium, results in hypoxia and mucus collection which gets infected, resulting in sinusitis. Now this is what you see here. This is an concha bullosa. This is a normal middle turbinate. This is the inferior turbinate. This is the middle turbinate. This is an hypertrophied middle turbinate, also called as a conchal bullosa. This is blocking the maxillary sinus ostium. There is collection of fluid. It is also blocking the frontal sinus with collection of fluid. This is what generally happens in a patient with an anatomic disfigurement. Next. So diagnosis of rhinosinusitis, you have 2 or more major factors and 1 major or 2 minor factors, or the presence, completely 100% diagnosis is the presence of purulent nasal discharge. The major factors could be facial pain or pressure, nasal obstruction, facial congestion, a purulent nasal discharge, discolored, almost sometimes it is blood-stained nasal discharge, hyposmia, anosmia, fever which is low grade, and nasal purulence on examination. The minor factors would be headache, halitosis, fatigue, dental pain, cough, ear pain, or pressure. Now, these symptoms can mimic various other conditions also. So, hence, it is important that we have an idea of the differential diagnosis. So, one is rhinitis medicamentosa. Rhinitis medicamentosa, of course, patients will present with nasal obstruction, patients will present with watery running nose. But the important thing is to take the history, where you get the history of the usage of recurrent long-term usage of nasal drops, either xylometazoline or oxymetazoline. This is a very important factor in the diagnosis of rhinitis medicamentosa. The second is allergic rhinitis, as I had mentioned earlier. Either you will have itchy eyes, ears, nose, and any antihistamine will immediately clear the symptoms. Now, the third thing is migraine. This is something that is very commonly mistaken for sinusitis. So this is very important because most patients with migraine can also present with headache and rhinorrhea immediately after taking a bath. So this is not allergy, this is not sinusitis. The important thing is to take the history, where patients tell you that symptoms get aggravated with exposure to loud noise or bright light. The symptoms are aggravated more during the menstrual period, and any stress aggravates the symptoms. Any change in temperature aggravates the temperature. Exposure to AC and then coming out into the heat, this also tends to aggravate the symptoms. So it is taking a nap or lying in a dark room will alleviate the symptoms. So it is very, very important, because I see a lot of patients with migraine being treated for sinusitis. They are relieved because of the analgesics. Vasomotor rhinitis, where the mucosal swelling is caused by changes in the ambient temperature, any hormonal changes like pregnancy, or gustatory rhinitis, where the patient complains of rhinitis mostly after taking spicy food. So here also history taking is important. In viral rhinosinusitis, the symptoms last for a very short period, less than 10 days. So when we do a diagnostic workup of the patient, as I mentioned, a careful history is important. An asthma, migraine, any allergic symptoms, any history of past surgeries, and a history of your immunocompetency. In a physical examination, you will see a hyponasal, there will be a hyponasal voice, facial tenderness, pharyngeal secretions, middle ear effusion, tender maxillary dentition, and purulent nasal discharge. The culture swabs are generally not taken because most of the culture swabs turn sterile in the first 10 days. And if you want to take a culture swab, it is better to be taken from the middle meatus. I would advise you not to ask the patient to take a sinus X-ray, neither a PNS Waters view nor a Cardwell view, because this is not indicated these days. We do not ask for a sinus X-rays, and most patients do take a sinus X-ray and come to us. If any imaging is required, it should be a CT-PNS, and a CT-PNS is not needed in the initial stages of a sinusitis. Only when the symptoms do not resolve, or if the patient presents with some complications, is a CT-PNS required. Please do not ask for any imaging X-rays for a patient with sinusitis. Now coming to a CT-PNS, this is just an indication, just to show you what is a you can see, this is a normal frontal sinus X-ray, and this is an X-ray, a CT scan. This is a normal frontal CT scan, and this is the CT of a patient with sinusitis. This grayish thing is what shows the pathology. Now here you have a maxillary sinus which is pneumatized, which is normal, and this is a maxillary sinusitis of CT of a patient with polyposis and sinusitis. Treatment in a patient with sinusitis would be analgesics, antipyretics, decongestants, mucolytics, saline nasal irrigation. This is very, very important for all patients with sinusitis. Do not prescribe any sort of vasoconstrictor nasal drops like xylometazoline or oxymetazoline, because that makes the secretions thicker. Ask them to go in for saline douches. That helps the symptoms, that alleviates the symptoms, it clears up the nose. Antibiotics are not recommended in viral sinusitis, but in bacterial rhinosinusitis, we ask for them to take either amoxiclav, cephalosporins, or macrolides. Now this is a differentiation between a nasal polyp and a turbinate. Could you tell me what is this? This is a turbinate and this is a nasal polyp. How do we distinguish between the two? A nasal polyp is grayish white in color. This is a normal mucosa, pinkish. A nasal polyp, when you touch it, it is insensitive. When you touch a turbinate, there will be pain for the patient. You can pass a probe all around the nasal polyp, whereas in a turbinate, it does not go laterally. If you use any vasoconstrictor, like any nasal drops, the turbinate shrinks, but the nasal polyps remain the same. And one more thing, when you lift up the nose, what you see is not a polyp. What you see is generally the inferior turbinate. Polyps are generally deeper. I'm so sorry to say, but 90% of the patients referred to me as a nasal polyp from any practicing general practitioner turns out to be a hypertrophied inferior turbinate. So you just have to lift up the nose, touch it and see whether it is sensitive or not sensitive. That is the basic thing you can do to identify whether it is a polyp or a turbinate. Because the patients get scared. Oh, I have a polyp. What is the next step? Whereas in most of the cases, it is only an hypertrophied turbinate. So as I described, this is the difference between a nasal polyp and a turbinate. Symptoms of nasal polyposis: nasal obstruction, of course, rhinorrhea and sneezing, partial loss of sense of smell, facial pain, postnasal drip, and epistaxis when the patient tries to clear the nose by blowing it very strongly, or if it's an infected polyp. A differential diagnosis of nasal polyposis: benign neoplasms like an inverted papilloma, or malignant neoplasms which could be bleeding, friable and ulcerative, and an encephalocele. An encephalocele is a pedicle mass appearing medial to the middle turbinate. Now this is an encephalocele. You can see this is a CT scan. This is a normal cribriform plate. Here you see an eroded cribriform plate. You can see the mass coming down. This is the middle turbinate on both sides. The mass is medial to the middle turbinate. Polyps are generally seen lateral to the middle turbinate in the middle meatus. So this is just an identification between a polyp and a encephalocele. Nasal endoscopy, of course, is the primary investigation, and a CT-PNS to evaluate the sinuses involved and to rule out any any thinning of the bone. And in allergic fungal sinusitis, there will be radiodense foci, which I'll be showing you later, and also bowing of the sinus walls with impingement against the dura or the periorbita. As has been described, an allergy testing and an immunology evaluation is very important in patients with nasal polyposis to prevent recurrence. It is very important to control, because after surgery also, a lot of patients come back with recurrence because they do not control their allergic symptoms. Treatment would be steroids, both oral and intranasal, and the treatment of the allergy with antihistamines and leukotriene modifiers. We these days prescribe long-term low-dose macrolide therapy, that is clarithromycin 500 mg daily as an alternative to steroids. It is given for at least 2 to 3 months continuously on a daily basis. Antifungals, that is with itraconazole, is given for patients post-surgery for patients with allergic fungal sinusitis to prevent recurrence. As I said, if it's a small polyp, topical steroids, nasal irrigation, and a short course of oral steroids. No patient is advised surgery in the first instance. Follow up after a month. If there is improvement, continue the medication. If there is no improvement, only then advise a surgery or advise a CT scan initially, and based on the findings would be a surgical. If it's a large polyp, we start on oral steroids, topical steroids, antibiotics, and saline irrigation. Saline irrigation is very important for patients with polyps and patients with sinusitis. Follow up after a month. If it is improved, we continue with the same treatment. If there is no improvement, a CT scan and surgery if needed. Now we come to fungal sinusitis. Fungal ball, as I think as was mentioned earlier, we spoke about Aspergillus bronchopneumonia. The same thing you see in the sinuses. This is a fungal ball, which is either is called as an aspergilloma or a mycetoma. It is a dense accumulation of fungal debris which is seen in a single sinus. Just one of the sinuses is involved. It tends to develop in the older patients and causes non-specific symptoms. It could be identified as just with the nasal blockage, and a CT scan can show the presence of the fungal mycetoma. In 90% of the cases, it's only a single sinus. Occasionally, two contiguous sinuses are involved. Now, this is what I was talking about. A single sinus is involved, and there is no destruction. It has to be identified and separated from an invasive fungal sinusitis. This is not an invasive fungal. This is a local involvement of the sinus. This is the fungal ball inside the maxillary sinus, and all patients with a mycetoma, it is a surgical removal of the fungal ball and postoperative nasal irrigation to keep the sinuses clear. And allergic that was a mycetoma which is involving a single sinus. There is a condition called as allergic fungal sinusitis or AFRS, which involves multiple sinuses. This is also seen only in immunocompetent patients. It is not seen in an immunodeficient patient. This is to be separated from the invasive fungal sinusitis that you see in patients with immunodeficiency. Now, this is because, as was mentioned earlier, this is also supposed to be an allergic reaction to the aerosolized environmental fungi in an immunocompetent host. And there is thick fungus and mucin, which is seen in the sinus cavities and which has to be surgically removed. So here you see the periorbita, the eyeball is pushed outwards because of the fungal sinusitis. It is involving the maxillary sinus, it is involving the ethmoids, and it is involving the frontal sinus. But it is not a systemic thing, and it is only a locally invasive pathology which can be cured 100% by a surgical removal and post-op nasal washes and itraconazole. Can you just click on that? I hope it works. It's just a short video showing a fungal ball being removed from the maxillary sinus. Click on it. Yeah. This is it's thick, tenacious, and very difficult to remove the fungal ball from the sinus. Just a short video because I'm sure most of you are not interested in a surgical thing. Thank you.
थैंक यू डॉक्टर रश्मि. आई एम सॉरी, मैंने आपको इंस्ट्रक्शंस दिए थे कि सर्जरी मत दिखाइए. एज ए जीपी हमको केवल डायग्नोसिस आनी चाहिए कि क्या है क्या नहीं है. दिस इज मैक्सिमम, क्योंकि इसके बाद हम करेक्टली आपको रेफर कर सकते हैं. सो थैंक यू वेरी मच. नाउ आई रिक्वेस्ट डॉक्टर राजश्री हनुमंत पाटिल टू कम फॉरवर्ड एंड गिव टोकन ऑफ एप्रिसिएशन टू डॉक्टर मैनन.
Thank you, madam. Our next speaker is Nanma Nikhalji Nambiar. Dr. Nambiar is a consultant dermatologist and cosmetologist at Ayush Clinic Seoud with 20 years of wide work experience. She did MBBS from Grand Medical College, MD Dermatology from the KM Hospital. Dr. Nanma is a wide teaching experience, also served as a lecturer in a JJ group of hospitals and DY Medical College. Numerous prestigious awards, papers, publications nationally and internationally to her credit. Dr. Nanma is a life member of various dermatology society and association. Now I invite Dr. Nanma Nambiar on dais for her talk on allergic urticaria, a dermatological challenge. So over to Dr. Nambiar.
Thank you, ma'am, for the kind introduction. Good afternoon, respected senior doctors and my dear colleagues. Today I'm going to talk about allergic urticaria, a dermatologic challenge. PowerPoint. So the outline of my talk will be about the definition, classification, the etiology in short, and more emphasis on the management. So before the PowerPoint starts, I think I'll start. Yeah, so I'm sure everybody is conversant with urticaria. It's a fairly common skin presentation to be seen in your clinics. So I begin with this case. So there was a 57-year-old female. She came with red raised, itchy, transient lesions almost daily on the extremities since 2 months. On history, she said this is going on since the past 3 years on and off. The first episode began with she taking some specific food, and there was no history of drug intake, no fever, joint pains. There was no history of swelling on the lips, ears, face. So what do you think it was? On the basis of history, because these are conditions, there are some conditions in skin, on the basis of history itself, you can come to a diagnosis. Anybody? Yeah, so so this was actually, food allergy was one component. It had started with food allergy, but when she presented to me, the food allergy was around 3-4 years back. The onset was with that. But when she presented to me, she had this history since 3 years. So that comes to any wheal, any lesion which is persistent more than 6 weeks, the diagnosis is chronic urticaria. So there is a difference between acute and chronic urticaria, and why do we need to know that? That is equally important. We'll see in the next slide. So if you can see picture F, that is a characteristic wheel of urticaria, that is a central edematous pallor surrounded by reactive erythema. And as you can see in the pictures, the wheels can be, varying in sizes, different shapes. They can be oval, round, annular, serpentinous, etc. This is an urticarial drug eruption, again an annular eruption. So what could be the closest differential diagnosis if you don't know the history? Anyone? Yeah, exactly. So we will think about fungal infection. So what is the one thing which will differentiate, that one question which will differentiate fungal infection from urticarial lesion? That one question. Itching will be there in both. Well, central clearing can happen in both. Generalized also can be in both. You can see generalized tinea corporis in immunosuppressed patients. Family history can be present in both. Many times they use their own, they use a common towel and all, so the mother, the baby both are having. Yes, transient nature, that is the question, that one question. So transient nature of the lesions, you have to ask, do they go spontaneously in 24 hours, 24 to 48 hours? Then you are dealing with urticaria. Of course, if it is angioedema, it takes 72 hours, and angioedema will pain more than itch. This is the second closest differential of urticaria, which we call as urticarial vasculitis. Anyone how we can differentiate? Because in both you will get urticarial lesions. Yeah, that is one thing. But again, that one question, transient lesions. So urticarial vasculitis, the lesions will not be transient, they will be persistent. So the moment the patient says, no, it doesn't spontaneously go, it is maybe you're dealing with vasculitis. Second important thing is to ask the patient, do the lesions subside with pigmentation? Urticaria will never, resolve with pigmentation. So if the patient says ki, kala rang chhod jata hai, ya there is bruising, then you're dealing with urticarial vasculitis. These lesions pain, they don't itch, but they look urticarial. So if you look, if the patient sends you a photo, it will look like urticaria. So you have to ask whether it pains or itches, and of course, like he said, systemic symptoms. Presence of systemic symptoms, you have to think about vasculitis. This is acute urticaria on the trunk. Again, the wheel is visible. So the lifetime prevalence of urticaria is 20%. Angioedema means the lesions, the pathology is deeper in the dermis, and therefore you have swelling over the lips, face, extremities, genitalia, etc. So why this is important to differentiate? The treatment of acute urticaria and chronic urticaria can differ, especially if chronic urticaria doesn't respond to the regular antihistamines. Secondly, the trigger factors are different. Acute urticaria, usually it is foods, drugs, infections. Chronic is usually autoimmune in 50% cases. Third, you can counsel the patient. If you know that you're dealing with chronic urticaria, you counsel the patient that it's going to take a long time so that the patient is compliant with you. So we already discussed about clinical features. So there are autoimmune and autoallergic mechanisms. So in 50% patients of chronic urticaria, we see autoimmune mechanisms playing a role. And it is mediated by cutaneous mast cells and basophils. They release histamine and also other mediators like kinins, leukotrienes. In angioedema, you find that the mast cells in the deeper dermis and subcutaneous tissues are involved, and therefore you see that swelling. So, like I said, the other reasons of acute urticaria are stinging and biting insects, latex, contact with allergens, urticarial transfusion infections. But more commonly, it is infections, food and food additives and drugs. When you evaluate, like I said, the history taking is very, very important. Like we discussed the points before. Apart from that, history of associated diseases, you should ask symptoms related to that. So, for example, history of atopy. So if it's a child, then you ask whether there's a rash on the cheeks, whether there's a rash in the antecubital or the popliteal fossa. If even in adults we find atopic dermatitis, so again, the rash would be on the extensors. So you must ask history suggestive of atopy. There should be a history of any thyroid diseases you must ask, because that is again an association with chronic urticaria. Dermatographism in case of physical urticarias. Now, anyone knows what is dermatographism? Yes. So when you take a blunt end of a pen and you stroke on the volar aspect of the forearm, a linear erythema, that a linear flare is seen. That is dermatographism. It is, once you see that, you know you're dealing with physical urticaria, which is a part of chronic urticaria. And you know how to tell the patient that, again, it's going to take a long time. It helps to counsel the patient. The patient then remains with you if you're honest with the patient. It's my observation. So if there is a symptomatic dermographism, in the sense if there's a linear flare and you have itching, then it is called symptomatic dermographism. Why we need to know that? Again, it will run a persistent course if it's a symptomatic dermographism. So rule out any underlying disorder also, because many a times if a patient has, say, systemic lupus erythematosus or a condition, an autoimmune disease called bullous pemphigoid, the patient can present with urticarial lesions also. So we have to rule out the underlying disorders by asking specific history of that particular disorder. Look out for angioedema also, because in 40% patients you can have urticaria with angioedema. So laboratory testing, the current consensus is limit your testing. Only if the patient is very, there are patients who want to get the blood test done, then you may get it done. But there are specific scenarios where you should get it done. For example, in acute urticaria, yes, a complete blood count and a urine analysis would help, because it would rule out infections. If a person is not affording and he doesn't have symptoms suggestive of an infection, then you can limit even that. ESR and CRP are markers of activity of urticaria. So in chronic urticarias especially, this will play a role. Serum IgE again in chronic urticarias, we'll come to the significance later. And skin tests with fresh food or to aeroallergens if a patient gives a history suggestive of that. Otherwise, for every patient, we should not get these tests done. So chronic urticaria is divided into chronic spontaneous urticaria and chronic inducible urticaria. Spontaneous is also called idiopathic. There's no known trigger there. Inducible, as the name suggests, you can induce it by exposure to cold, heat, sun, vibration, pressure. So typically, even this cholinergic urticaria, okay, cholinergic urticaria is after the patient, exercises, they get this small tiny wheals. We call it as pencil on eraser wheels, like, those erasers, that small size wheels occur in cholinergic urticaria. So you have to ask the history regarding exposure of these agents. So this is again important to know. Chronic urticaria, the prevalence is 0.5 to 1%, but the important thing to know is that the duration is 2 to 5 years. So this helps in counseling the patient, one. And secondly, there are some patients who say that, that particular doctor, I came to you and it's all magically gone. You're a very good doctor. And when you see the prescriptions, the other dermats have also given the correct treatment. But what happens is, if the patient is presenting to me, say at year 4, or nearly year 5 or whatever, arbitrarily, and I give him a treatment, and then after that he doesn't get any time, he attributes it to me, but it may be because of the natural cause of urticaria. It had to go, and he came to me and it became better. So it helps in advising the patient right at the first go before giving the treatment. In adults, females are affected more. In children, chronic urticaria is less common. We mostly see children presenting with acute urticaria. 3rd to 5th decade of life, the more presentation is seen. The difference between children and adults, the presentation is, the severity is more in adults. Even adults, when we give antihistamines, adults are more refractory to antihistamine therapy. Associations we have already mentioned. Rarely malignancies, in certain malignancies also urticaria can be a presenting symptom. So when you evaluate, take a proper history of drug intake, very important. history of atopy, history of stress is important because many a times stress aggravates urticaria. So when you find that the patient is not responding to regular antihistamines, instead of jumping into, the more toxic drugs, we should rule out stress, spend some time with the patient, talk to the patient, give some agents which will help the stress as well as antihistamines. Like there is a tricyclic antidepressant doxepin, which we have found very useful in elderly patients who have a lot of stress in the family and who present with urticaria, and then we don't have to do any updosing for them. Systemic symptoms, alcohol, food. Now food and drug you should ask even in chronic urticaria, because sometimes in chronic urticaria these things can be trigger factors, like in my patient which I showed in the first slide. So in chronic urticaria, if you get eosinopenia or basopenia, it indicates severe disease and it indicates that this will persist for a longer time. C-reactive protein or ESR again indicates that the disease activity is more, if it is more. Anti-thyroid peroxidase antibodies and thyroid profile we can do because there are associations between thyroid diseases and chronic urticaria. So this is the natural history. In 30 to 50% patients, chronic urticaria spontaneously remits. It may persist beyond 5 years in 30% patients. Factors associated with persistence, like I said, more severe disease. If the patient presents to you with a more severe disease right at the outset, or he has thyroid diseases also with him, or there is presence of angioedema when he presents to you, all these are markers of persistence of the disease for a longer time. So important thing is to reassure the patient. The first and foremost to say that we don't have curative treatment in allopathy. There is a fear that the moment you say that you will lose the patient, but you have to tell the patient that you do not have curative treatment, you have a palliative treatment, you will control the symptoms. Nevertheless, in 1 year, 40% people, will go through, it will wane off completely. So that positive thing also you have to give to the patient. Avoidance of physical factors, avoidance of NSAIDs and specific foods if they are allergic to. So there is no need for a blanket ban that do not use. But yes, what we do in practice is we tell them to avoid additives, food additives, colored, these items like in biryanis and all, they put those colors, and restrict outside foods, specifically in acute urticaria and sometimes in chronic urticaria. Now, what is the stepwise approach? So, step 1 is to give second generation antihistamines. Now, there are 2-3 guidelines actually. There is, in one guideline, they have mentioned you can give first generation antihistamines, but that's not the first step to do. So, first thing to do is give any of these, cetirizine, levocetirizine, fexofenadine. Now, there are many studies, comparative studies, and there is no study which says this is better than that. So you can give any of this. Of course, among this, belastin is having the least drug-to-drug interactions. So maybe this has got a little edge over other antihistamines, other second-generation antihistamines. Side effects of antihistamines, we all know, cholinergic side effects, dry mouth, urinary retention, lack of psychomotor coordination. The most important thing which we are worried about is sedation. That is the reason we have started giving second generation antihistamines. Montelukast and ranitidine have got a good safety profile. Sometimes you may encounter diarrhea, headache in patients. In step 2, according to European guidelines, we updose the dose of second generation antihistamines. So you can increase it up to 4-fold. So say for example you are giving fexofenadine 180 milligram once a day, you can increase it up to 4-fold, but it should be gradually in say 2 weekly intervals depending upon the response. So you can even add montelukast, hydroxyzine, doxepin. This is varying in different guidelines, but these are the options available in step 2. In step 3, in one American guideline, in the American guidelines, they say hydroxyzine you can updose. If at all you do not want to consider the monoclonal antibody omalizumab, then you can try hydroxyzine in updosing form if the patient is willing to encounter sedation without any problem, and it will not interfere with his quality of life. In children 6 to 12 years, we give 25 milligram. Now in children less than 6 years, generally it is better to avoid, but in clinical practice, pediatricians and dermatologists do give hydroxyzine. Now step 4 is omalizumab, cyclosporin, anti-inflammatory and immunosuppressive agents. Out of this, anti-inflammatory and immunosuppressive agents there are only anecdotal reports, and they are, you encounter a lot of side effects with them, and clinical efficacy and long-lasting remission is not seen. So we generally in India, dermatologists are usually giving omalizumab and few give cyclosporin. This is a very important slide, role of glucocorticoids. We all know glucocorticoids have severe side effects, and there is a rebound phenomenon. When we give it for a longer time, we stop, we find that the urticaria comes up with a bang. So also, the patients have a tendency to self-medicate. They love prednisolone. They don't want to come to you. They'll keep on taking that, and they will land up in side effects. They do not appear to induce lasting remission. They do not alter the natural history. Therefore, steroids have to be given only in acute exacerbations of chronic urticaria, not otherwise. So you can give 40 milligram daily for 3 days, taper by 10 mg, come to 10 mg, or you can give it for 7 days and taper by 5 mg. Now, the very important thing is to even tell the patient the side effects of the drug which you are giving. So if you are giving steroids, you have to tell them that long term, if you take, you're going to, you're going to get obesity, blood pressure, diabetes, you're going to get a bone fracture. So that will refrain them from, self-medicating. So this is what the pointer is not working. So this is the same thing what I've said in European guidelines. So first is avoid the triggers and give a second generation antihistamine. The second step is, to so wait for 2 weeks, and then the second step is to increase it up to 4-fold. And if this doesn't work in another 2 to 4 weeks, then in step 3, according to European guidelines, you give omalizumab. Now omalizumab, if within 4 to 6 months you find there is no control, then you can add cyclosporin to the second generation antihistamine. Now this is only for chronic urticaria, that too chronic spontaneous urticaria, not for acute urticaria and not for chronic inducible urticaria. Now American guidelines, what difference is that in step 2, instead of only updosing, before embarking on these omalizumab, what they do is, suppose updosing doesn't work, they add an H2 blocker like ranitidine, they add montelukast, and they add first generation antihistamine like hydroxyzine. And of course, if this doesn't work, then we have the option of omalizumab or cyclosporin. Now, when to refer? So, if a patient has recurrent urticaria with angioedema, you have given second generation antihistamine, you have even increased it to up to 2-fold, 3-fold, 4-fold, patient doesn't have improvement, then you should refer the patient. This is because of 2 things. One, because the dermatologist or the allergy specialist will consider omalizumab, cyclosporin, with which they are more more used to, so they know what precautions to take when they are administering those drugs, and also because they will also look at if if the patient is having some underlying infection, like Dr. Rohan, when he discussed aspergillosis, I thought as if there is synchronicity, because yesterday I just heard about a case of aspergillosis which my friend, a dermatologist, faced. And I would like to share with you, this also was a middle-aged woman who presented with urticarial lesions. She was seen by a dermat, given second generation antihistaminic, didn't work. Step 2, they, she increased it up to 4-fold. And then the patient was given cyclosporin. All this while this patient was an asthmatic, a controlled asthmatic with persistent cough. And she was given some cough syrups, she was feeling better and wheezing on and off. So she was like, okay, I'm an asthmatic, so it's okay, it's getting better on and off. And then cyclosporin didn't work. And then this patient landed up in my friend's clinic because she was told that now the next thing is omalizumab. So she came to this friend of mine for a second opinion. When she saw her IgE levels, it was 4,000. And this cough, this cough made her think, why is this cough, not going? Last 2-3 months, she's been on these syrups, and she referred her to the pulmonologist, who did these tests, and it was found that this patient had bronchopulmonary aspergillosis. Now, the thing is, now this patient is doing well with steroids and itraconazole and was unnecessarily given cyclosporin. So this is a take-home message that history of atopy, IgE levels, and a proper referral should be done. Of course, this was the dermat's fault, not the... So omalizumab is a monoclonal antibody directed against IgE. Ma'am has spoken, Dr. Rohan also has spoken. So I'll just specifically say that if a patient has got a higher body mass index, then it is found that frequent doses are needed and higher doses are needed. You can use it with second generation antihistamines. And when omalizumab has not worked on its own, there are articles where they have found results with omalizumab with cyclosporin. Of course, it is not the first thing to do. It's like a last resort. It is safe in pregnancy. There's low incidence of side effects. Of course, anaphylaxis is an issue, as ma'am said. 300 milligrams subcutaneously every 4 weeks we give. Again, this has been updosed up to 600 milligrams. If the patient responds to omalizumab well, then after 1 year, you can taper, especially if the onset has been severe. So we don't taper it quickly. So there are early responders and late responders. If the serum IgE levels are high, then it is seen that the patient's response to omalizumab will be better. And that is again a reason why IgE levels will help. So it will help predict the response to omalizumab. There is no resistance seen with omalizumab. So if suppose a patient responds to omalizumab, you have stopped it and the urticaria recurs, then you can again start him on the same. So other therapies are methotrexate, mycophenolate, ligelizumab has been given by senior dermatologists also here, ASST and phototherapy, but these are just on the like ligelizumab and all, we have just been started giving. Tacrolimus is not given mostly in India. In the West, they prefer it over cyclosporin because this doesn't cause the gingival hyperplasia and hirsutism. But then these signs, hirsutism and all, is reversible. So if you discontinue, then these effects will be reversible. Cyclosporin, the advantage is when you do not have anything, as a last resort that is, it has got a rapid onset of action. Efficacy is similar to prednisolone. In few studies have shown lasting remission after discontinuation. If you use a low dose, say 2 to 3 milligram per kg, then the side effects observed are less. And of course, we should monitor blood pressure, we should do BUN, creatinine and baseline lipids when cyclosporin is on. In pregnancy, we prefer first generation, we prefer chlorpheniramine, dexchlorpheniramine. Second generation, we prefer cetirizine and loratadine. Children, again, cetirizine, levocetirizine and loratadine. In kidney diseases, now people are preferring belastin, again, as I said, because of low drug-to-drug interactions, and there is least sedation among second-generation antihistamines, and no interaction with alcohol. So my take-home message is, always explain the patient the natural course and prognosis of the disease. This is the first thing we should do. Oral steroids should be given only in severe exacerbation and for a short duration. Make patient aware of the side effects of steroids. Consider updosing of second generation antihistamines, and if that doesn't work, refer. Rule out atopy. Increased IgE levels more than 2000, refer to a pulmonologist if respiratory symptoms or if the patient is an asthmatic. Non-compliance, ask the patient whether you're taking the drug properly before thinking of updosing. History of stress, add first generation antihistamine if required before thinking of omalizumab. And of course, as a last resort, omalizumab or cyclosporin. Thank you so much for your patient listening. Thank you, Jaya ma'am, for this opportunity.
Thank you, Dr. Nanma. Now I request Dr. Suma to come forward and give token of appreciation to Dr. Nan. Nivedita. Thank you, Dr. Nanma. Thank you, Dr. Suma. Our next speaker is Dr. Vishal Gupta. Dr. Vishal Gupta is consultant chest physician and interventional pulmonologist attached with Apollo Hospitals, Belapur, and worked in all the reputed hospitals of Navi, Mumbai with 12 years of wide work experiences. He did MBBS, MD, DNB, respiratory medicine, advanced fellowships in allergy, asthma, sleep medicine, European diplomat in adult respiratory medicines, and American board sleep medicine, numerous prestigious awards, papers and publications nationally and internationally to his credit. Dr. Vishal is life member of various respiratory societies and associations. Now I invite Dr. Vishal Gupta on dais for his talk on anaphylaxis. Over to you, Dr. Vishal.
I'd like to thank IMA Navi Mumbai and Apollo Hospitals for organizing this, along with our Dr. Jayalakshmi, Dr. Bhumika, and the entire team at Apollo who helps us organize such good CMEs on a Sunday. I think it is lunchtime, everybody's tummy is rumbling. So, my topic is well covered by most other speakers, but some of the severe aspects that we deal with on an emergency basis are something that all of us should know. Because allergy has got two domains. One is the patient is quite safe, he has some chronic symptoms, and those patients who've had very acute symptoms. So those patients who come to us with some problem, my PPT is on. Right. So those patients who come to us with some of the other major problems, so why is this important? Recently, a person died. She had a cookie. She was a known peanut allergy patient, and she didn't know that there was a mislabeling on the product. So this is something serious. All right, it causes a fatal anaphylaxis in a person who has a known respiratory problem, and she is an asthmatic. She already has a known peanut allergy documented. The second is somebody who is unknown, somebody who just had an unconsciousness. Please remember, these people are not probably there in your OPDs. They are there in community at large. All right, they can happen to anyone sitting here, because the annual prevalence, or let's say population prevalence of anaphylaxis, is somewhere between 3 and 5 per 1 lakh people. And I'm sure that if we look in Vashi, there are more than 1 lakh people even at this moment. So somebody could have anaphylaxis anytime, anywhere. The most important place that we are most worried about is our OPD, in the wards, in the ICUs, and in the operation theatres, because that's where we have to work. And unfortunately, it is more common in the hospitals and in around the hospitals than it is in general population, because we have to administer medications, and medications are one of the foremost causes of the anaphylaxis as well. Food is the second commonest. So please remember that anaphylaxis can happen to anyone, anywhere. Anyone here can tell me which is the most important drug in allergy, or which is the first drug in allergy that was known? No, not the cause, sir, the treatment, I'm sorry. Which is the most important? Adrenaline. Sir obviously knows adrenaline is the right answer, but for all of us to know, adrenaline is not available as a tablet. It has to be injected. Has anybody injected adrenaline before? How do you inject it? Sorry, there is no subcute in the answer, okay? Never give subcutaneous adrenaline. That will cause a huge medico-legal problem. Patient will have a problem. Please remember, it has to be given in anterolateral thigh. Have all of you seen movies? Okay, army jawan dying. How do they give it? They take it on the anterolateral part of thigh. This is exactly what you have to do. Adrenaline will act in 3 minutes. All your antihistamines, oral corticosteroids after 3 days, after 3 weeks. Patient will not be surviving that long. Anaphylaxis is a temporary condition. Please remember, it's not a permanent problem for the patient. So it has to be taken seriously in that event. Why does it happen? Anaphylaxis doesn't happen to your first exposure to the allergen. It happens after second or third exposure when there is a potentiating effect. And therefore, anaphylaxis can go away and come back in the same patient in the next 1 hour. So you should know that patient, he got better, he has got hives, you gave him adrenaline, you gave some medicines, 2 days back, 2 days after that he can come back, or in the next 24 hours he can come back. Why? Because histamine is the culprit here. In all of our discussion, histamine is the most important pointer which needs to be looked at, and that is released by the mast cells. The mast cells are causing the degranulation which leads to histamine in the subcutaneous and the dermal tissue. I thank ma'am for the upkeep that she has kept, because the cutaneous aspects of anaphylaxis are already well dealt with. I am only going to be focusing on why anaphylaxis is important, because as respiratory doctors, anaphylaxis happens commonly to asthmatic patients, so they already have a pre-existing respiratory problem here. Okay, they are already asthmatic, they have come to you for an allergy problem, or they have come for a gastrointestinal problem. That means they have had loose motions and vomiting. This is usually because of smooth muscle contractions happening because of histamine release. The patient or the person can just be sitting silently in the OPD, suddenly collapse, or have involuntary motions or a vomiting episode, blood pressure will fall, and you have to act in the next 3 minutes. Thinking is not the option there. Solving is get the adrenaline. The easiest way to give adrenaline is take 1 cc syringe, 1 cc is to be loaded, give 0.5, wait. If you have not even checked his heart rate, if you do not know anything about the patient, if patient is not conscious, you have to give adrenaline in that 1 minute. You can assess in after 3 minutes. After 5 minutes, you can repeat the dose. After 10 minutes, you can repeat third dose. By the time you would probably have got help. So that is the reason why this topic holds importance for all of us. So I think the CNS events, etc. are pretty uncommon. The most common signs that we see in our OPD or in IPDs, including the ICUs and the OTs, is that there is an airway problem. The signs is the patient is unable to swallow and there is breathing difficulty with shortness of breath. There are cutaneous findings, hives, redness, itching rash and swelling which have developed in front of you within the next couple of minutes and hours, not in a few days. If the patient has survived the hives for more than an hour, the chance of death from anaphylaxis is very, very less. Stomach cramps and heart issues can also be there, of which blood pressure being falling is the first and the most serious indicator for death. So anaphylaxis is likely to be happening when at least one of these few minutes of issues have happened, and or there's respiratory and fall in blood pressure. Now, whenever we see patients in the outpatient also, there is a patient who comes to you with an acute problem. I would say that if there is a triad system and the person has had a few minutes of these problems and there is a known asthma condition, that itself becomes a possible candidate for anaphylaxis. So always look at that more seriously than the other OPD patients who are waiting in line. Blood pressure is the first record that we take in the outpatient. If it is found to be on the lower side, it is an urgent thing that needs to be attended to, and therefore epinephrine should be the basic thing in your OPD. Because all of us have syringes, we just need the epinephrine, which costs about 5 or 10 rupees at maximum. The next most important thing is those patients who have had any two of these findings, that means they've had no history of any hives, but they've had blood pressure or gastrointestinal symptoms which are acutely progressing, and those children who cannot tell us anything but just a drop in blood pressure and an adult with drop in blood pressure with a known allergen. So if they are known allergic to particular food or drug, if they've accidentally taken it and they've had a documented blood pressure low, you should probably look at that more seriously. I'm not going into the full detail. I have a list compiled for all of us so that Sangeeta madam told me to keep this very, very simple. So I'm not going into very, very many details, but foods and antibiotics are our biggest problems. In amongst doctors and especially among dentists, latex allergy is very, very common. So those history of just occupational exposures or the scenario in which you are, maybe in an ICU or inside an operation theater, drugs which are basically opioids like fentanyl, your propofol, all of these drugs are known causative agents for an anaphylaxis. When do we look for it? If you are finding a child who is an adult, a child who is less than 15 years, or a lady who is more than 15. This is actually biasing, but truly the history of atopy and asthma combined with a genetic history or a male-female predominance will give you an idea. If the patient has been on some medicines like beta blockers, angiotensin converting inhibitors, and if you combine both, the activation of the immune system becomes even worse. So therefore, the treatment will change based on what medicine the patient has been on. Please remember, angiotensin converting enzyme inhibitors and beta blockers, of them and AC inhibitors independently will cause non-immune asthma or non-immune urticarias. So these patients will not be dealt with by just giving antihistamines. Your first approach to be giving would be the adrenaline. So where does it happen? Supposing a patient is there who's been taking peanuts every day, but he is known to be a pro athlete. He has also consumed ethanol, that means alcohol, and he has also consumed NSAIDs, or he's had an upper airway infection, may suddenly collapse. And that is where you don't know. Probably this was because of an anaphylaxis, which was not a predominantly issue with him. He had a history of urticaria. He didn't know much about it. He was positive on sensitization, but on exposure to these triggers, exercise, alcohol, painkillers or NSAIDs and acute infections, these are situations which may potentiate him to go into anaphylaxis. And that is the reason why we need to be very careful when we are running marathons or when we are participating in activities or have had an exposure to NSAIDs, whether this issue can happen to us, because it is known that NSAIDs, 2.5% of people who take NSAIDs over the world will develop either an urticaria, a rash, or will have a hypotensive episode, which will fit with the criteria of anaphylaxis. And I think NSAIDs are one of the commonest prescribed medicines. In fact, not even amongst the antibiotics. NSAID is far superior to even antibiotics in causing the anaphylaxis. So cow's milk and hen's egg are common problems with children. With adults, it is sesame, peanut and fish. Now this is not Indian data, but in Indian data, I am sure Ravikant sir must also agree that chickpea along with brinjal is also a positive issue that we see causing anaphylaxis very, very commonly. Sesame is nothing but our til. So older adults will probably have more issues with seafood, dry fruits and nuts. So please remember that anaphylaxis can happen to a product, something that patient has already taken before and develops new sensitization after he is 50, after he is 60. So it's not something that he will either have in childhood and live with for life, but something that can develop later as well. There are other products also, but I'm not going into details of that. Drugs which are new onset drugs which have been used for the first time, or an activation of the immune system like penicillin sir pointed out, has been known to cause an activation of immune system which leads to histamine release. But this is not a conventional IgE method. So testing for IgE there probably may not make any sense. What we need to treat is the acute event, not focus on its IgE background there. And therefore drugs can actually cause pseudo-allergic reactions. So pseudo-allergic reactions are very common issues inside the operation theaters, and those are the only people who are not in the audience. They are the intensivists or the anesthetists, and they give medications like opioids along with medicines like NMDA antagonists, which are basically atracurium, vecuronium, pancuronium and neostigmine. Many of these medications are given day in day out to almost every patient in this room who is a lady who has had labor and who has had C-sections. Probably this medicine has been used. This probably has been a surviving episode for you, but for some unfortunate person it may be a cause for death. So beta-lactam antibiotics, cefotaxime and ceftriaxone, we were expecting to see, this is actually Indian data. So Indian data, I have only highlighted the important things for us to keep in mind are beta-lactam antibiotics, cefotaxime and cefuroxime, which we feel that amoxicillin should be the #1 cause, but it is not. Then comes diclofenac and paracetamol. It is outnumbering the antibiotics. the atracurium vecuronium, it is outnumbering the others as well. Why? Because this is more frequently used. Antibiotics like this, probably we do skin testing more alertly. We are giving more focus on, but these are the hidden problems. And can you see the rare thing that we did not understand is ranitidine. Ranitidine is known to be H2 blocker. Alright, we are sometimes using it in anti-allergic medications as well, but it is also a cause for anaphylaxis in a study done by us. So the problem is, ma'am, steroids technically are not here in the list, so I really don't know. So the fact is, steroids cannot probably cause anaphylaxis on their own, and if they do, that rarity is not enough. Ma'am, anaphylaxis is an acute emergency. So जितने में मेरा talk हो रहा है उसमें 3 anaphylaxis हो चुके हैं दुनिया में. In that emergency, if they have survived an hour, that means the entire scene, if they survived, that means the steroids can be thought of. And steroids cannot be used in prevention of anaphylaxis. Alright. At the same time, steroids are only a palliative measure for an underlying allergic problem like asthma, like some other respiratory problems. They are not an aspect of discussion when a patient's life is 3 minutes and steroids will act after 3 days or after 3 weeks. So steroids have a very long half-life. The half-life of epinephrine is 3 minutes, means 3 minutes में वो गया और 5 मिनट में वो घर से बाहर गया. That's it. So the reason why this is all important is because awareness is what will create more understanding. And even in the presence of NaCID, supposing you've given an NaCID, आपके सामने patient ने दवाई खाया, it will not happen in 5 minutes. The timeline is very, it's there, it's in the PPT. But a timeline में 15-20 मिनट patient घर जाने से पहले रिक्शा में बैठ के वापस भागते हुए आता है. With this phase, that means that your job is not to prescribe the steroid and say, oh, Baba, go home. It is to give epinephrine. 20 minutes you have to wait. Epinephrine se problem solve ho gaya. Then you can prescribe oral steroids if you want to, because it is NaCID induced this thing. Their steroids have no role. It is not IgE mediated. So the idea here is to understand that there is an angioedema which can happen on both eyes, both lips and both sides. So it's not unilateral. This is peculiarly unilateral. Even though I would agree that the mucositis is bilateral, some of the patients may have just unilateral symptoms. And this is more frequently seen with NaCIDs and non-IgE mediated methods. So I don't know why that happens. It should not technically, because IgG तो पूरे body में होना चाहिए. लेकिन fact is that this kind of scenario should give you a possible alerting idea as to why that happens. And when will this happen? For foods, 30 minutes after consumption of food, you will have respiratory or cardiac arrest. 15 minutes for venom if you are exposed to an insect bite, and 5 minutes for iatrogenic triggers. Most often it is NMDA intraoperatively, which is your vecuronium and pancuronium. So even the anesthetist will have 5 minutes to understand that okay, after 5 minutes the problem will going to start, but it gets serious within the next 3 minutes. So he has to be faster because his injection is intravascular. He has given IV injection, whereas the food consumed is 30 minutes, and that is likely to keep happening for the next 2-3 hours because food will gradually keep getting absorbed. This is the reason why understanding of the issue is far more important than actually being so active physically. Urticaria and angioedema will be about 62 to 90% of the patients, and very few patients will have only respiratory problems or only cardiovascular issues as their problem. So gastrointestinal issues, neurological issues, I am not going into it. I am just repeating this again for all of us, so some people who slept through the lecture by now. Again, wake up. And mucosal tissue, decrease in blood pressure, those who had 2 organ system involvement, persistent gastrointestinal symptoms, and those who had exposure to those who had blood pressure which is low after a known exposure to an allergen are the people who I would like to look at from the perspective of mine for anaphylaxis issues. So how do you start is you take a history. Obviously history is not from the patient. Okay, please don't ask patient what he has had. Patient is breathless and low blood pressure and you are asking him history is no sense. Please ask the caregivers. Okay. The second thing is you will have to obviously first, before thinking investigation, you will obviously start treatment. You give an adrenaline and you've already revived the patient. You can consider do a skin prick testing. You can do the blood tests. But always remember that there is a myth of doing serum tryptase levels. Serum tryptase levels have to be done 2 times within the first hour of doing the anaphylaxis. So you still have 1 hour to do anaphylaxis workup after the patient has survived the episode, and then repeat it after the next 48 hours to see that the tryptase level have come down. This is the only retrospective diagnosis of anaphylaxis. So please understand that anaphylaxis has a retrospective diagnosis. Clinical is the first and the last way to diagnose it. If patient survives it, you can discuss academically after that. Where you have to focus on is airway, breathing, circulation, disability and the exposure. So is the person consumed it? Is it intravascular? How have you given that positive, the dose of the allergen? How acute is the onset? Is it a life-threatening episode, and usually is there any skin changes as well? So skin changes you will call the dermatologist if there is time, but you will have to call for help nonetheless around you. You have to mobilize the patient. Never raise the head end of the patient. Head has to be down. Keep your patients hydrated. You will probably have to secure IV access. Difficult time to do that. Interosseous access. If patient can be revived, please try to ensure that there is good air around him. People don't crowd around him, which is commonly seen in Indian scenario. Along with that, there is a need for oxygen if you can get it. IV fluid is important, but adrenaline, you have to remember, is the gold standard. Even with your eyes closed, if you suspect or if you have thought patient has collapsed, the first drug is adrenaline. The second thing is use an eye gel. So eye gel basically, adrenaline ka dose, most people feel it's very complicated. It is the easiest drug I have seen in my life with the simplest dose. If you have 2 to 4-year-old child, you will give 0.1. If you have 4 to 7, you will give 0.2. This is 1 ml vial. So chance of you making a mistake is very minimal. Please don't get afraid of adrenaline. If you give 1 cc, what will happen? No, nothing will happen. Patient will still be alive with you only. He will thank you. But problem is that our assumptions have been beyond point. 0.1 ml, 0.2 ml for 4 to 7 years, and 10 years you can give 0.3. A child of school going age, 0.4 you can give, and more than 12. So I think secondary school will be 0.4, and more than that, any adult sitting in this room, 0.5 is the dose. There is no dose beyond that. So 1 ml, 0.5 is the adult dose. Anything less you can take down. School going child, toddler child, all those things you can give, and it is safe for any general physician to give without the need for an aggressive overthinking about ventricular tachycardia or other problems. So you have to repeat it 3 times if you can, 5 to 10 minutes. So 10 minutely if you assess the patient, and if you have no help around you, you can give the 3 doses, no harms. So so diagnosis is obviously made clinically. There is a rapid progression of problems. You have to keep an account of what is happening. Acute management, there is no contraindication to epinephrine in absolute terms. Of course, myocardial infarction in the acute setting may be a contraindication, but that is not easy for everyone to have. Myocardial infarction happens commoner than anaphylaxis. So it is less chance that you will probably have anaphylaxis and myocardial infarction in the same patient at the same time. But due to hypoxia and due to hypotension, he is likely to develop a myocardial infarction which you are not treating. So that should be the focus of our attention. Oxygen is the second most important thing. IV saline is the third most important thing. Salbutamol is the fourth most important thing. Again, I think antihistamines have been well discussed. Oral steroids have been well discussed. So I will not be taking time to discuss all of those things. This is something, somebody can play that video. This is an eye gel. For all of you who don't know this, this is a dumb person's intubation, and it is successful.
Appropriate for the patient, then iGel O2 can be inserted with the head in a neutral orientation. A proficient user can achieve insertion of iGel O2 in less than 5 seconds.
All Indians are proficient users, huh? I have seen that.
Soft tip into the mouth of the patient in a direction towards the hard palate. It is not necessary to insert fingers into the patient's mouth. Glide the device downwards and backwards along the hard palate with a continuous but gentle push until a definitive resistance is felt. Do not apply excessive force. The tip of the airway should be located into the upper esophageal opening. The cuff should be located against the laryngeal framework. The epiglottis should be held in place by the epiglottic rest. The gastric channel should open into the esophagus, and the incisors should be resting on the integral bite block.
You can pause the video. So the moral of the story is that if you are blind, if you are actually physically blind, you can only identify the mouth of the patient. You can put the eye gel and patient will be intubated and survive the episode. If you close your eyes also and do it, you will do it right. There is no way to make a mistake while putting an eye gel, and it is extremely well used by all of us when we do bronchoscopy for an issue which is emergency, or in an outpatient or an IPD setting when we don't have access to anything else. So I think most of us, if you have 2 minutes, you take an eye gel in your hand, it is about 5,000 rupees, can be reused as many times as you want through your whole life. It is a very, very good thing to think about. Keeping it with you in an emergency is something that will save your and patients' lives. Your life is more important, patients will definitely be helped. So this is a case which is quite simple. It is 25-year-old girl and she has been eating seafood regularly at a restaurant. Someday she has just come to you for abdominal pains with cough and sore throat, urticaria and swelling on the face which is happening only on one side. Her speech is good and tongue is swollen. Her blood pressure is on the lower side but periphery is warm. Why did I mention this? Is because in cardiac failure you will have periphery cold and blood pressure low. So that is how you have to look at. Check the periphery. If she is warm, that means she is the best peripheral vasodilatation, and that indicates histamine release. So what do you do is, the patient wants to know, she has come to you after 3 hours. Obviously, I have not put a case for an acute emergency because most of you may not be seeing a patient who comes with an urticaria in 5 minutes. It will probably take in 3 hours. So in this episode, what will you do? Will you still give adrenaline? You will not give adrenaline. Pardon me? So please pick up. I think it's very right to say that adrenaline still can be given. Adrenaline is more effective than antihistamine, hands down. Okay? Even for the urticaria. In the acute emergency setting, urticaria ke liye, the fastest treatment will be anaphylaxis, will be with this. Of course, we all thought, even I thought, the first thing will be that seafood is an issue. But she has eaten frequently. So it is not like I am saying that seafood is the cause for the allergen. It may be an NSAID, it may be premenstrual, it may be another episode which I don't know about. If I keep wasting time in using steroids or antihistamines, which are probably more effective in IG-mediated disease, I will waste the precious time of solving the problem, which epinephrine would have done in 20 minutes. And I can always buy time and see what is the next issue. I can draw bloods and assess the patient in time. So why did it happen? So what I have done probably is smart, or what the patient thinks I have done smart. Second is, why did it happen? I don't know. The answer is we have to still figure it out. Do the homework properly. Look for NSAID, which seems to be the common cause here, or if fatigue or stress or exercise or dehydration or premenstrual problems have caused this, which is predominantly one-sided issues. And will it happen again? Yes, it can happen again. Unless you figure out why this has happened, it was very likely that she will happen to have these problems more frequently. If higher doses are used, probably dose-dependent effect will kick in because of NSAID use. So this makes a very important case to understand and to talk to our patients, because the patients will have n number of questions. But these 3 basic questions, if we are able to answer, even in a general physician setting, as a specialist also, we first start with these 3 questions and then we try to figure out the next level of answers, which I have enumerated before. I just want everybody to look through this small important things. So severe and fatal anaphylaxis will be determined by the comorbidities and the concurrent medicines, mainly beta blockers, ACE inhibitors. Diagnosis has to be confirmed, doesn't require a specialist at all times, but referral is always encouraged, which is what we are here for. And some of the anaphylaxis are amenable to prevention through immunomodulation and proven guidance. Why is it proven avoidance? Because foods can be prevented, drugs can be prevented, alternatives always exist, and immunomodulation is for the venom allergies and the certain kind of pollen allergies which we treat on a daily basis. So immunomodulation sometimes works wonders for such patients. Specific cause of anaphylaxis suggested by patient's history will give us an idea where we should go next, because the patient's asthma will need treatment, the patient's allergies will need treatment, but their anaphylaxis is urgent. And patients, especially children and family with caregivers, will have to be taught how to manage epinephrine very effectively. If as doctors we abhor epinephrine, we are reluctant to use epinephrine. If we say epinephrine may not work in this patient and we may cause tachycardia, I am probably teaching the wrong thing to the wrong person, because the relative is going to be more afraid of the situation. So always our fear is what decides where the patient goes. I'm sorry, wo niche ka part cut gaya. I'll just read it out to you. If you have focused on what you have left behind, you will never be able to see what lies ahead. Thank you everybody for the patient listening.
Commonly used medication in the general practice, like injection diclofenac and injection xylocase, can cause anaphylaxis. What are the other medications which can also?
I think I had covered it, so the common ones I have put on the list over there. In India, the commonest things are like you're looking for cephalosporins, you're looking for NSAIDs. It's a very simple topic. Honestly, anaphylaxis, if it happens to, it doesn't happen to a large number of things. It happens to a large number of people with very focused things. So our attention is not to give attention to the rare possibilities of looking at a rare drug. What is important is that anaphylaxis is preventable, it is curable. It is the only thing in allergy which is totally curable, but we need to understand that every drug can potentially be it. So when we are taking precautions as to telling the patients, I always make a list of these things and I say, see, anaphylaxis can happen. You have to have it. You come here to the emergency. Don't sit at home and try Benadryl because that is precious time lost. After second day, epinephrine is not going to work. If I treat it right now, it works. Thank you, ma'am.
Thank you, Dr. Vishal. Now I request Dr. Prasad Kulkarni to come forward and give token of appreciation to Dr. Vishal.
Thank you, Dr. Gupta. Next speaker is Dr. Abhijit Bagde. He is a consultant pediatrician and lead pediatric intensivist at Apollo Hospital with 17 years of wide work experience. He did DNB Pediatrics and Advanced Fellowship in Pediatric Critical Care. At present, he is a secretary for the Indian Association of Pediatricians, Intensive Care Chapter, Mumbai. Dr. Abhijit has wide teaching experience also as a teacher for the DNB Pediatrics and College of the Pediatric Critical Care India, numerous prestigious awards, papers, publication nationally, internationally to his credit. Dr. Abhijit is a life member of various pediatrics and pediatric critical care societies and associations. Now I invite Dr. Abhijit Bagde on dais for his talk on approach to a wheezing child.
Good afternoon. Thank you for the detailed introduction. Today we'll be talking about asthma, but more importantly, in childhood, we see many different variables or different presentations which look like asthma. And I'm sure as clinicians, we all see them at different points of time. So let me not talk too much of asthma. I will more speak about different presentations and how to interpret those. Can I have next slide, please? Okay. So in today's times, these are common problems in our routine OPDs. A parent should call you and say, my child is having severe wheezing. It may be OPD, it may be a telephonic call. And then the second question is, obviously, I hope it's not asthma. And then I remember the old dictum that every wheezing is not asthma and every asthma does not wheeze. So why and how? Let's understand quick few case discussions and then we'll talk ahead. So this is a story of a 7-month child who has been well so far. Birth weight of 3 kg, now weighs 7 kg. So 6-7 months, 7 kg, that means he's not failing to thrive, he's gaining good weight. His milestones are all right, head holding, roll over, monosyllable, sitting, all have been achieved. So very likely there is no congenital problem. The weaning has been started, he has been on breast milk. Now the symptoms start. Fever for 2 days, cold for 2 days, cough for 1 day. And this has been so far the first major illness what brings to the pediatricians. And since yesterday he was a little cranky, today he is quite cranky and the cough is wet. The parents are saying, sir, is coughing. The way we describe it is a fruity cough. So what is this? When we ausculted this child, there was wheeze, but of course creps also. tachypnea, saturation 90-92, tachycardia, 170-180 heart rate, very irritable child, wanted to feed but couldn't feed. Whenever he was putting to the breast milk, he was crying. So what is this? Is this asthma? First episode? No, there is wheeze, but there are creps. So this is typical age, 7-8 months of child, bronchiolitis. The swelling to the bronchiole generally after post-viral infection or a viral infection. Generally RSV and lots of other viruses which cause this. The season is typically winter season. The child has been, as I mentioned, has been well before. This is the first major illness. And the treatment is IV fluids for hydration, warm humidified oxygen if the child is too hypoxic, so we prefer that high flow nasal cannula. Third, some nebulizations, 3% NaCl or Levolin, that is bronchodilators, but more of supportive treatment. Now at this point we also need to treat or tell the parents, even if the child gets admitted for 2-3 days, the cough persists for weeks. Because even if you discharge the child, they will start seeking for another opinion, thinking, no, this doctor has not treated my child well, the cough is still persistent. Because the cough persists for 2 to 3 weeks, and that has been described in the history. Okay, let's look at another case. 2-year child, history of fever for 3 days, the cough is very significant, the cough is more in the night, and that's a typical presentation even in adults today. The child has been otherwise playful, active. Her mother had a upper respiratory tract infection just 2-3 days back, and the child is active, not much of breathless, and the child has required nebulizations in the past. So typically cough more in the night, wet cough. Generally we start thinking towards, is this a child chest congestion kind of problem? Then when we see the child, it's a healthy child, playing, active, not distressed, but slight tachypnea. So what is the difference? The faster breathing rate is tachypnea, but retractions or work of breathing is distress. So no distress, but mild tachypnea, bilateral wheeze present, and more of harsh sounds. Even more than wheeze, it's more than harsh sounds that we see typically in children, and no hepatomegaly, no other problems. So what is this? The child has required once nebulizations in the past. So what is this? So we call this as a mother had infection, now the child has developed some infection, probably lower respiratory tract infection, but child is not unhealthy, child is not very sick, so it looks more like a viral LRTI. We call it as a VALRI, wheeze associated lower respiratory tract infections. Again, generally viral infections, what they need is hydration, do not need antibiotics unless the child is in ICU for secondary infection, but most of them are viral. So hydration, bronchodilators, and if the cough persists for longer duration, maybe the combination of bronchodilators and a short course of nebulized or steroid MDIs. Okay. So far we have looked at 2 presentations. Now let's look at the third one. 5-year child who has been frequent wheezer in the past. This child had annual day. Now the Feb and March is going on. They all have annual days nowadays, where they sit and play in the dust. So he has been coughing for last 2-3 days. Did not have fever. So doesn't look a respiratory tract infection now. And he has been getting these coughs multiple times in the past. He has a nebulizer at home, which is a common thing today. And when we see him, he is little breathless. He has bilateral severe wheeze, proper wheezing, audible wheeze, mild retractions, and the child looking very anxious. That look is very important. Now, this child who has had recurrent coughs and cough episodes in the past has required multiple nebulizations in the past, and with this, and has been labeled, has never been labeled, but the mother also has history of recurrent cough. So there is a family history, very important message here. And this time the child is looking anxious, he's having retractions, so he's distressed, so we advise admissions. Now these people who have nebulized at home in the past would often say, my Delhi doctor has told that he doesn't need anything, we just need nebulizations and we'll do it at home. Very common experience today. So he takes nebulizations, he starts oral steroids and goes home. Not an uncommon scenario. So what will you tell to monitor? So these are the danger signs, what we monitor in a wheezing child at home or even in ward. This child would have got maybe admitted in ward. When do you shift to ICU? One is obviously saturation. Most people today have such pulse ox at home. Second, intake and output. By and large in children, if the child stops feeding and drinking well, that is generally suggestive that you are probably going towards danger signs. Third, we say single breath count. Now in a say 2-year child, what will you call him? So we ask, how is he crying? Is he crying continuously or is he crying This means he is having grunting. The short crying episode means you are not able to cry. The respiratory reserve has gone down significantly. Is he active or dull? Is he irritable? Again suggestive of sickness. So these are the signs which we are told to monitor, and when he comes later, his RR has gone up to 50, heart rate is 50. Most important, the wheeze is audible, and now the child is very dull, very drowsy. So this is a sure shot PICU admission. Drowsy child is a status asthmaticus, in fact more than that. So we advise PICU admission, started with oxygen. Not to forget, the treatment of asthma is obviously bronchodilators and lots of things we have discussed in the morning. But treatment of status asthmaticus starts with oxygen. So oxygen with nebulizations, then IV steroids, magnesium, bronchodilators, SOS aminophylline, and then ketamine and all those things. Let's not go too much of details, but what is more important, when do we ventilate asthmatic child? For 3 things. 1, watch for sensorium. Drowsiness is never good. Number 2, hypoxia. Severe hypoxia is again not good. And one easy marker to guide where you are is looking at the blood gas. Deteriorating or rising CO2, rising lactates, these are rising acidosis. These are the signs which are symptoms, these things which tell us that you're probably deteriorating. Again, in today's times, the similar story of adults or also exists in children. When we are talking or counseling asthmatic parents, then we have to talk about long-term management. It is not unusual that you take it for 4-6 weeks and then the medicines are stopped. So excellent counseling is important. And again, Dr. Jaya Lakshmi would agree, the questions are also probably common in children. Can he eat bananas and oranges and curds and whatnot to eat? I think everything can be eaten unless you are known allergic to something. Otherwise, we don't give any no's to eating. Okay. Let's look at another example. 18-month child who has been well so far. He has been coughing for last 2-3 days and there is no fever or cold or travel or respiratory tract infection, but the cough is very significant. And they are saying that he was well till 2 days back and he suddenly started coughing. He's coughing too much. For first day, they went to some doctor. The second day, he was admitted to wards. Now the saturation has started falling and he's unable to sleep. It's more than 36 hours. The child is just coughing. They don't know what is happening. So now this child has been referred to pediatric ICU. They have till now given antibiotics, steroids, nebulizations, oxygen. All have been ticked. What now? So respiratory rate of 50, distress, tachycardia and bilateral wheeze. Everything is fitting. So is this LRTI, lower respiratory tract infection, bacterial, viral? What is this? So if you look at this, there was no fever. There was no antecedent issue there. There was no family member who was unwell. But this has started suddenly in a childhood of 18 months. And this is his X-ray. If you see, the left side looks quite hazy, but the right side looks quite hyperinflated. And now on detailed inquiry, what we hear is he was playing and eating and he suddenly started coughing. So very likely this is a foreign body. Okay. So what we did, we inquired again and again. They did not know what he had eaten, but he was eating something on his own. And then we went ahead with a pediatric surgery opinion and a bronchoscopy, and then it removed the peanut from his right main bronchus. So history is extremely important because that would tell us where and what is the problem. Okay, this is again a scenario in last 1.5 months. This is 32-weeker baby who was born 1.7 kg. That means no IUGR. He was born for the premature labor. He was in NICU for 2 weeks but did not require any ventilation. He was on oxygen for 2-3 days. Then he was just putting on weight, and he was discharged with a birth weight of he was discharged on day 21 with a weight of 1.7 kg. So he lost some weight, now he has gained some weight, he looks well. He is not a setting for a chronic lung disease, which would have been a case for 26 weeker. This baby is fairly okay. He is been bottle feeding, not an uncommon problem today. And now he is today 3 months and he has been coughing for last 1 month. Okay, 3-month child who was 7th month born. Now he is postnatal maybe 3 months, so 1 month corrected gestation age, and he is coughing significantly. So what now? They have taken 3 opinions till now. They have tried nebulizations, they have tried oral medicines, everything. Nothing has worked. Now what? So when we talk to the parents, we take detailed history, and now we think there is a rush to put on weight. Okay, he was a slowly gaining weight, but he is looking smaller for a 3-month child. All neighbors and relatives putting pressure, so they are overfeeding this child with a bottle, and then this child has been vomiting because of that. So it was a GER, overfeeding related to reflux, which was causing bronchospasm, laryngospasm. And what we just did, don't overfeed, stop bottle feeding, feed with a spoon or a pallet. And after 3 days, the vomitings have stopped. Few days of prokinetic, few days of domperidone, but the child is doing well. Okay, another case. This is a 7-month baby. He is having repeated cough and cold for last 3 to 4 months. Weight gain has been slow in this child. He was born with 3.2 of birth weight, but at 7 months we expected 7-8 kgs. He is only 5.2 kg. So something missed there. Okay, so failure to thrive, repeated cough and cold, maybe 1 episode of fever, nothing significant. Till now tried all cough syrup, nebulizations, MDIs, antibiotics, everything. Nothing has worked. Now what? So when we look at this child's X-ray, which was done outside, you can see a large heart. Okay. Now this finding is not uncommon in children because of few things. It may not be expiratory film, it may be inspiratory film, or the child would be crying. So it is little difficult to pick up that. So we repeated the X-ray, the finding was the same. Plus on both the bilateral, the perihilar, you can see there is slightly increased bronchovascular marking. So what is this? And then when we ask the parents, why is he not putting weight? He doesn't feed well. What is the problem? So he gets tired easily. So what is this getting tired? So they had stopped direct breastfeeding, they were on bottle feeding, and now we ask, and then they also start telling, okay, he gets sweaty when he's feeding. So this is a suck-rest-suck cycle suggestive of a congenital heart defect with increased pulmonary blood flow. So we did an echo and which showed large PDA with a VHD. The problem is in a child of 3, 4, 6 months, the heart rate is 140, 160, baseline heart rate. So it is very difficult to auscultate a murmur at times. So that is what was happening in this case. So it was a congenital heart disease which was presenting like this. Okay, let's look at another example. 4-year boy with recurrent cold, much more cold than cough. Cold generally starts in the beginning, then the cough develops. Night cough is also there. And this child is very fond of ice cream. The parents are proud to tell us that. And if you hear to this child, his speech is also not very clear. Okay, he speaks little muffled, or what do I say, very unclear speech. And then on detailed inquiry, there is snoring, a child of 4 years snoring, sleeps with open mouth, he has coryza, harsh sounds, most important tonsils. And needless to say, tonsils are easy to pick up, adenoids are not. So tonsils are not really bad, but we did his adenoidal extent. You can see this doesn't work. Okay, you can see that on the posterior pharyngeal wall, slightly above nasopharynx, we can see the large adenoid. So we started with nasal steroids and of course the other treatment, montelukast and diet modification, and then the child recovered. Okay, so in summary, this is first sentence is very important, but I think our numbers are bigger than that. 40 to 50% of children wheeze at least once in their lifetime is a statement from a textbook of pediatrics. But if I'm not wrong, I think I saw, yes, doctor also here and a senior pediatrician. So the numbers are probably bigger in metro cities. Maybe most children have today wheezing at least once in their lifetime. But all childhood wheezing is not asthma. That is one important message to be conveyed to parents. Detailed history, age group, how does the symptoms progress, the recurrence of symptoms, how is the growth, how is the weight gain, how is the development. All these things guide us to some clinical diagnosis. Examination, it is at times, especially in smaller children, because they are not cooperative with high heart rate and respiratory rate, it is difficult. We also need to monitor what is the response to what we have done, the therapy. And the differential diagnosis can be starting from bronchiolitis or Wallery, that is wheeze-associated lower respiratory tract infections, GER, foreign body, iridoids, congenital heart disease, and the other differentials which I did not include because of short of time, which may be TB and cystic fibrosis. Even CP or delayed development child can have a reflux related to wheezing episodes. And when we talk about HRD counseling, we need to talk about steroids, growth. They always ask about what if I give steroid, will it hamper the growth? The answer is no. Topical steroids do not hamper growth. In fact, the recurrent asthma episode, recurrent illnesses do falter growth. So that is one answer which I always give to parents. And obviously no limitation while eating any naturally grown food. Important to enlighten them to give MDI as planned and come for regular follow-ups. Certainly complete the vaccination and of course focus on influenza vaccine on an annual basis. And most children outgrow their problem by 5 to 6 years of age. So these are more of Walleries than typical, we call it a childhood asthma. And a child who continues to have wheeze after 5 to 6 years of age, or if there is a strong family history from maternal or paternal side, or the episodes are without associated with fever, then we start thinking towards more of asthma. And don't forget the other differentials. That's all I have to say. Thank you.
Thank you, Dr. Abhijit. Now I request Dr. B.G. Ranpise, Senior Pediatrician, to give token of appreciation to Dr. Abhijit. थैंक यू डॉक्टर अभिजीत, थैंक यू डॉक्टर रणपिसे। नहीं भाई, ये चाहिए ना, इसके सामने क्यों? भूमिका ये नहीं चाहिए। स्क्रीन पे कुछ नहीं। डॉक्टर जयलक्ष्मी, स्क्रीन पे कुछ नहीं है। So our last awaited program is panel discussion. The topic for panel discussion is asthma and allergy, unrevealing a tangled relationship with a focus on new biomarkers and latest options. Our panelists are Dr. Nilesh Chinchkar. Dr. Nilesh Chinchkar is consultant chest physician and pulmonologist, director Chest Care Center and Niramay Hospital, Panvel, and attached with Apollo Hospital and Medicover Hospital. Dr. Vivek Patil. Dr. Vivek is senior most pulmonologist of the Navi, Mumbai. Dr. Ravikant Jhala is senior allergist at Niramay and Polaris Hospital. Dr. Rashmi Menon, she is consultant ENT surgeon. And moderator for this session is Dr. Jai Lakshmi. Okay. हो गया बस हो गया और किसको बुलाना? डॉक्टर दीपिका इज नॉट है, हो गए 4 लोग. ओके, डॉक्टर जाले बोला मैंने. यस.
Hello. So we have had a real treat today of all wonderful talks, and thank you for the patient listening and a lot of interest shown by all of you. So we'll have a panel discussion now, and we'll also take the audience questions. So to Dr. Nilesh Chinchkar, I'd just like to ask you about the choice of inhalers in asthma. So what is your choice of inhalers, and what is the problem you face usually with the inhaled medication?
There are many inhalers available right now. There are many inhalers available right now. It's a huge basket available in the market, and many companies are coming into the respiratory area with the newly launched inhalers. Inhalers, if you go in the past, age-old inhalers where it was typical levosalbutamol inhalers, which was used to be like 4 to 6 times in a day. Then invention of long-acting bronchodilators, it changed all the views of the treatment of the asthma. We used to give it twice daily, and now once daily combination inhalers are also available. Now, considering choice of the inhaler in asthma, it depends on the clinical symptoms. Basically, remember one thing: treatment of asthma, first line of treatment is inhaler, and inhaler. No oral treatment should be started in any asthma. No, only oral treatment should be started in any asthma. If you want to give oral treatment, then it is always an adjuvant treatment. Inhaled treatment is a primary treatment of asthma. This one thing we need to remember. Second, coming on to the choice of the inhaler, now there are long-acting inhalers and ultra-long-acting inhalers are available. Long-actings are twice daily, and ultra-long-actings acting are once daily. So, if a new patient walks in, you have to decide depending on the symptomatology of the patient, what phenotype of asthma he is having, and what is his choice of using inhaler.
Would you use a once daily or a twice daily for a new patient?
For a new patient, obviously the preference, my preference is using once daily, because adherence is main problem in the treatment of asthma, and once daily is very easy to remember. People do not tend to forget taking a dose. They also feel that एक ही बार लेना है तो अच्छा है. So once a daily is a natural choice. If any old patient comes to me, then I would like to stick to the older inhaler, whatever he is using, if the symptoms are under control. But if symptoms are increasing, if he is going into a frequent exacerbation, then I would like to choose a different combinations. The combinations available are like beta agonist, combined with inhaled corticosteroids, and a few inhalers are available in combination with glycopyrronium as well. Now, if there is a eosinophilic predominant asthma, you have to use inhaled corticosteroids. That is the mainstay of treatment, along with the long-acting beta agonist. And if having a neutrophilic phenotype, or if the patient is having more exacerbations not controlled on the usual inhalers, then you can add a glycopyrronium containing inhaler as well. So this is
Thank you, Dr. Nilesh. So coming to Dr. Vivek Patil. Dr. Vivek Patil is, I think, among all of us, along with Dr. Zala, one of the most experienced in lot of allergy testing. What I would want to know is, from your experience of allergy testing, what are the common allergens to which the patients are having the allergy?
Yeah, here in Navi Mumbai, what I have found during all those years of practicing as an allergist is we get lots and lots of house dust mite allergies. There are plenty of house dust mite allergies amongst ourselves, and partly it's because of the conditions that we are living in, the humidity that we have all the year around, and the lack of ventilation and the sunlight in the bedrooms. So maybe because of that we have got this particular predominance of the house dust mite allergy. Plus, having said that, quite a few number of patients, they do have pollen allergies as well as the fungal spores allergies. Plus, insect allergies as a part of the a cross reactivity to the house dust mite allergies, as well as the cockroaches and the mosquito allergies. We have found it quite a bit. And amongst foods, there are cross-reactive allergies to the seafood or the shellfish and stuff like that.
So one more question I want to ask, which patients always ask. So should they stop banana or should they stop any particular fruit without doing an allergy testing? How will you guide them?
See, there are two things that I generally tell my patients. First and the foremost is to pinpoint the things which he or she is probably allergic to by doing a skin prick test. And having said that, there are certain other things which are called irritants. So the irritants are a generalized avoidance measures that we generally tell patients to avoid the cold beverages, the cold things, the cold air, the change of weather, the change of climate, or for that matter, the choke and the stuff like that whenever they are having an acute inflammation of the respiratory tract because of some or the other reason. Maybe the allergic inflammation of the airways is one of those reasons. So once we identify the allergen, they have to avoid those allergens per se as a best thing. And then of course they also have to avoid the irritants. Now the patients have their own misconceptions about certain foods. Like somebody says the milk is responsible for the cough, and banana is so all those misconceptions are there in the society. What we try to tell the patients is to avoid the allergens on the priority, and then also avoid the irritants for a few months of time till the time their allergies are under control.
To Dr. Rashmi. So I want to know about FES. We keep hearing when we refer to the ENT, they say we are doing FES. And often our patients undergo FES, they go. So how exactly do you go? What is this procedure? Is it done in the OT? Is it done in the OP? How and what is the benefit of it? What is the use?
Functional endoscopic sinus surgery, or FES, is a surgery, endoscopic surgery to open up the sinuses, the osteometal complex or the frontal sinus, or even if you have a nasal polyposis. So the FES is not the first line of treatment in any patient. The first line of treatment, as I said, it would be treating medically. You wait for a reasonable period of time, and then you review the patient. If the symptoms are persisting, you do a CT scan, see what are the symptoms or the findings, and then decide on the surgery. The advantage of FES is there is no open surgery. It goes through the nose. There is no scar for the patient, and there is excellent visualization because we are using a sinuscope. So you have.
So what anesthesia is used in this?
I prefer a general anesthesia, especially if it's extensive FES. Some people do it under local anesthesia, especially if it's just a localized sinus. We need a hypotensive anesthesia for this patient.
So it's done admitted patient?
Yes, it is a surgical thing. So you have, it has patients, it's not an OPD process at all. It is not something like an antral wash. It is not an OPD procedure, it is a surgery.
So coming to Dr. Zala. Again, Dr. Zala has wide experience in allergy testing. So tell me about the allergy testing when you do it. So when you do it, what are the, like you do the test for histamine. So is it supposed to come positive? It can come negative?
Yeah, before I just answer this, actually, I'll just little bit go ahead with the question which was asked to
your
Dr.
experience
Vivek
of the
Patil.
allergens,
The house dust mites, they are the creatures, they get deactivated only and only by sunlight, number one. So sunlight is most essential. That's the reason when you ask the patient, the usual symptomatology or the symptomatic this thing comes from is like late evening and till early morning. So this will give you the clue that the patients are having house dust mites allergies. Now to advise, simple advice is Most important is change the bed linens every 3 to 4 days. Foot mats to be changed every weekly. Curtains to be washed. Change in the sense washed. Okay. Curtains to be washed every monthly. This is one. Another little different thing which I have, I've been advising my patients. I don't know how many of you are, and sir also, Dr. Vivek Patil sir also agrees to this, is in the, you take a white cloth, little thick cotton one, little coal, sir, 50 to 100 grams of coal, put it in, just tie it and keep it at one corner of the bed. The mites, activity of the mites will be reduced to less than 40 to 50%. This is not known by many of the allergy specialists over here. Okay, so this is something which is very useful and is very simple, but needs to be changed every monthly. Okay, because house dust mites out of setting over here, at least 30% of these population also would be allergic to house dust mites.
So by coal, what do you mean? In what?
Coal is this कोलसा कोयला
Yeah, but how do you procure it?
वो छोटा छोटा वो तो अभी किधर भी मिलता है, वो मेरे को भी नहीं मालूम है, बट मिलता है वो मैं अभी तक मैंने actually this is a good question. Madam say I was planning to keep coal in my clinic and give them as a complimentary, you know.
Amazon
नहीं है, वो छोटा मोटा किधर भी मिल जाएगा. This is something which is little different. And now to come to my question about the allergy testing. Now see, all the time when we do the what I do personally, I tell when we advise the patient to undergo allergy testing, even after the complete history taking and all, we find out as to where the patient comes from. So presence of pollen differs from area to area. So for that reason, one must need to know the pollen calendar and pollination season. Okay, for example, Cynodon dactylon, that is a durva, very common, most common, which is round a year at every places. So abundance. Okay, kabhi bhi milta hai. Okay, so that is one thing which is all the time. But certain pollens which has the pollination season. So for example, say March to June, like that, you know, August, September, October, like that. So those knowledge of pollens has to be there. Now, when the patient does not, say for example, his patient is not that affording or something, what madam asked was ki whether you can, see, we can do definitely only controls in case of, okay, in case of like the patient is not affording for say certain thousands of rupees for allergy testing. Okay, it is like based upon the practitioner to practitioner, the charges are variable. Now say X amount like 8,000, 10,000, 12,000, whatever. So if that patient is not affording, we can just do positive negative control, only that much. And in case if the patient is not, this is another most important was the to stop the antihistaminic according to Bhumika, what she showed one slide. So that needs to be stopped prior to doing the testing. So this only controls when you do. Many times it comes as a positive. Very rarely it does not come as a positive. Now the positive means what? If supposing the histamine release is more, say 5 mm with 15 mm erythema, but at the same time supposing saline, that is negative control, also is little more. That means the difference between the positive and the negative control has to be very significant, unless you tell that patient or term that patient as an allergy patient. Now when you do only this much, and then you can give the patient, see if the patient is not affording, you can just give them the symptomatic management like it is given in urticaria, long-term antihistaminics and all those things. So you can definitely give them, you can give them some of the like Jalaneti, if the, I don't know, like, yeah, so those things you can advise. You can advise some of the asanas and
nasal douches.
Nasal, yeah, those things also you can advise, and so, you know, like yogasanas and all those things, which is you are the master in that, so that you can do that way also. So these other things also matters a lot. And at the same time, in this patient, whoever patient, allergic, always every allergic patient has got in them the psychological triggers of allergic disorders. Okay, they have certain 5 to 6 things. Out of that, at least one thing would be definitely positive. That is, number one would be the this, what do you call it, anxiety. Second is stress level would be higher. Third would be they might be little irritable type of personality. Then short temperedness will be found in them, because these are chronic things. Now, whichever chronic, of course, it is like coin has got two sides. So physical, one side of the coin is physical thing, the other side is the psychological aspect of that physical disorder. So definitely the negativity of the histamine can come, but if in case if it is something different, some cause of that is something other than the allergy. Now once we find that positive and we try to convince the patient, we can do it in parts also. Like not necessarily we should do everything together. Okay, only 3 mites and 6 dust if I wish to. And he said ki cockroach and mosquito is very common allergy even in Los Angeles.
Can test only for the common allergens.
Yeah, common allergens also we can test selectively. So that out of that, if whatever comes, then we can also give them the trial of, like say dust mites allergy is come positive, we can give them the trial of only dust, house dust mites, sublingual immunotherapy, and they get better. That is also good enough. Thank you.
Dr. Zala. One more question, and I'm opening the thing to the audience also. Any questions you can ask to Dr. Vivek Patel. Many times when you do the food allergen testing, it comes positive to a wide variety of things. Patient says, I'm eating these things, but I have no problem. So how do you guide this? Sometimes dal will be positive and apple will be positive. A patient says, I'm always eating it and I have no problem with that.
Yeah, it invariably happens that way only. See, when we test for all, what we are trying to see is the sensitization of that individual to the things which we are testing. Now, the skin prick test or allergy skin prick test is going to give you an information about the sensitization, not the allergic disease per se. So the sensitization means that particular individual is sensitized to that allergen. That doesn't necessarily mean that he is manifesting the disease because of that allergen. So he may or may not be manifesting it because of that allergen. So what we get at the end of the testing is a basket of the allergens on which he has to focus, the patient has to focus, like he has to see it for himself or herself, whether he is getting any problem because of that. Generally the foods which we get on the borderline areas, those are the things which are normally not responsible for the patient's disease or ailment at that present point in time, but it is always better to avoid those, because there is always a chance that if that particular allergen is consumed or is in contact with the patient for a long period of time, the allergic reaction can get severe in the future, and then ultimately he will land up having the direct effect of that allergen. So in order to reduce that hypersensitivity, it's better to avoid that. So that is one thing which we can convince to the patient. But if it is not avoidable, or if the food constituent is such that it will be a nutrient which we are asking the patient to stop, we have to weigh the pros and cons of that, and then accordingly we can advise. But we have to ask the patient to keep a close watch on this. These are the allergens he can develop the problem because of. Yeah.
Thank you so much.
Yeah, it is. Generally, it happens after about a couple of years or so. Say, for example, I have done a allergic skin prick test now. So that sensitization will remain with the patient. Body's allergic tendency is for the long term, but body can develop and redevelop the sensitization to different allergens at different times. So today you are allergic to, say, for example, wheat. Tomorrow you may grow out of that and you can develop allergy to the rice. So that can always happen. No, body, it's body's own coercion.
That is also significant. That is
yes. Yeah. So what I do generally during my reporting is I don't report it as 1 plus 2 plus or 3 plus. I give the number, the amount of the erythema, the amount of the wheel that we have, 2 mm, 2.5 mm, 5 mm, 7 mm. so that it becomes very easier for the future or the other doctor to compare as well. Whenever we have the same patient coming to me after 10 years, I know that what was the amount of reactivity to that particular allergen that time and how much it is now.
And how often do you think we should repeat the test?
Not required before 3 years, or for that matter, generally
Unless-
the patient, maximum number of patients, they settle down. Unless until they have fresh symptoms or the fresh different organ involved, not required.
Any questions from the audience?
want
Yes,
to add
doctor
something.
has one question.
I just want to add something on your question. Basically, many allergens are coming positive when you do a skin prick test. There are two things. First is you have to do a test properly. It's an intradermal prick and it should be done properly with the proper stillet, because there are many stillets. You both must be knowing many better things about it. Many lancets are coming. Many lancets and many sizes of lancets are there. So you have to select it properly, point one, and then you have to prick intra, because many are doing with the technicians. Technicians keep changing. So that one thing, pricking is very important. Putting an allergen, adequate amount of putting allergen is important. Pricking is important. And second thing, it's basically a reading of a report, because many things are coming positive. I have seen reporting of 50 allergens positive. Now nobody can offer a immunotherapy on 50 allergens, and nobody is so allergic कि 50 के 50 कोई एकदम severe allergy रहेगा. ऐसे नहीं होता. So depending on the history, you have to select the allergen. If you are going to test all the allergens, 220 allergens का kit होता है. If you are going to test 220 allergens, then it becomes difficult actually to report it. So these two things are also important.
Thank you. You were asking something.
Supposing a patient is admitted with anaphylaxis, Dr. Vivek, and food allergy. So it is already, the patient is stable and the symptoms all are, it's not, the patient is fine, and then they want to know what is the allergen or the cause the anaphylaxis. So when the patient is inpatient and they want to test, so what sort of test? You will ask for CRP, complement result diagnostic, or you wait for a month for the skin prick test till
Generally, anaphylaxis is different than the IG mediated thing. No. First, a tryptase test is required to diagnose. No.
take a month or so. See if they
No, the tryptase is to diagnose the anaphylaxis, serum tryptase levels immediately and after 48 hours. So that will diagnose the anaphylaxis. If it is anaphylaxis, it's completely different story. CRDs is right now the gold standard is allergy skin prick test. Whoever is contraindicated for the skin prick test will be asked for the other in vitro test,
So would you
including
consider this
CRD.
anaphylaxis as a contraindication for doing the allergic skin prick test?
Allergy skin prick test should be avoided immediately.
When would it be safe?
After a month, after patient settles down.
Any more questions?
Regarding the basically dust mite allergy, whether the nowadays they recommend low cover and mattress cover, how much that will help?
There are so many measures to avoid the house dust mite allergy. I personally tell my patients to change the bed sheets and pillow covers every night before they go to bed. Okay, now it's practically impossible to do that. But what happens is, if I tell them to change them every third day or fourth day, they will invariably change it after a week. So at least I'm sure that they will change at least 2 to 3 times in a week. So that is one thing that is very important. Secondly, what you said is that house dust mite proof covers. That also is very important. That is definitely going to help the patients, because these are fabrics which will prevent the dust mites from coming up to the surface to a large extent. And that is going to definitely help the patients. Yes.
There was sorry, I'll just take your question. There was the Allergopharma German, like Merck, had that bed sheets, basically earlier available in India, which was mite.
Tyvek.
It used to not to be, the mites were not transferable, like, so that bed sheet used to be, you can put over the mattress and quite expensive it was. It's I think started single was around 9,000 at Indian currency and onwards, like, so that was there. Even pillow covers were around 4,000, 5,000 each. So that was there, but unfortunately that Ellago Pharma, they have stopped their operation in India. Otherwise it was very useful, like it could reduce 20% load, you know. And unfortunately what has happened in Bombay and surrounding areas are the buildings are so close to each other. So even during daytime, the people has to keep the lights on, and there are no sunlight which enters either from the east or from the west. I mean, in the sense either in the morning time or during evening time. The sunlight doesn't come at all. Idealistically, sunlight should be allowed to come. Do not close the windows or the curtains. So this small advices also matters a lot. And sir, according to sir said, is very good advice that I should now start giving patients that daily they should change. So they will do it at least after 3 days. I tell now them 3 to 4 days.
You are having a question.
Yes, good question. Now, see, this is life में everyone has got to earn, you know. Bread and butter तो सबको चाहिए, पेट तो सभी को है, ठीक है ना. तो उनको भी कमाना है, तो उनका सब अभी चलना चाहिए, और वो भी कुछ बुरा नहीं है. अभी अगर मेरे को फुल डर्मोग्राफिज्म है या कुछ भी ऐसा है कि सर रिकॉर्ड जस्ट नाउ सर टोल्ड कि वेयर इन द पेशेंट वी कैन नॉट एडवोकेट अपॉन दैट पेशेंट एलर्जी स्किन टेस्टिंग, those patients you can definitely go for either ELISA or CRD or something like that. But those are, see, if you go and say, for example, I'm not for any of the labs or something, but say, for example, standard labs like Metropolis or Agilus, like SRL and all. So those, if you do one antigen would cost around 1,000, 1,200 single. So that means if you go to test around 60, it becomes more than 60, 70,000 rupees to the patient. You get my point? So this is the reason, of course, and on the basis of those blood tests, we cannot treat the patient for immunotherapy, cannot be given on that basis. That is again written by World Allergy Organization and World Health Organization. So on the basis of in vitro tests, one cannot advocate allergen immunotherapy. So that is another thing. But in case if you want to detect, avoidance is the best measure for any allergies. Now, according to what sir was telling, I have found in my practice, like one food is not consumed. If somebody comes to me and telling me कि I have got मूंग दाल का allergy, तो first thing तो वो patient अकेला मूंग दाल तो खाता ही नहीं है, मान लो, उसके साथ कुछ तो खाएगा ना, चपाती खाएगा, चावल खाएगा, कुछ भी खाएगा. नंबर 1. नंबर 2, चलो उसने सिर्फ अकेला ही खाया और उसको तुरंत हुआ. That also many times does not mean that the patient is having moong dal allergy, because something which he has consumed around 3-4 days back, which has reacted 3-4 days later as an antigen antibody reaction. So late reaction can occur. So most important, what Dr. Patil said rightly is to conduct allergy test for different foods, and whichever comes strongly positive, whichever are the commoner food, which are day to day, like milk products are common, besan like gram bengal is common. Say rarer are what, like now I mean, like many people do not over here may not be eating rajma, rare, soybean, rare. So you should try to eliminate the rarer food. Onion, garlic, all those things are common. So whatever are commoner, then can be when we can advise those patients. Avoidance is number 1. Number 2, if some such strong positivity comes, then we can put that patient on allergen immunotherapy sublingual. But most important part here again is a compliance, and explain to the patient that you have to continue this for this many years. You have to be with me. You have to bear doctor like me. It's like that. Thank you.
Thank you. My one last question to Dr. Vinod Chauhan. So nowadays we have changing tracks from the allergy. We have a lot of patients who come with viral infection or so, and after that they have a lingering cough. So the cough is quite difficult to treat. Most of us may be dealing with this. What is your approach for this cough patient, and how will you treat?
So nowadays we are seeing most of the cough which is persist for long duration. So most important in this thing to rule out the just any serious illness behind that cough, find out the any differential diagnosis, and just rule out the any major cause of the cough. It's before labeling is as it is only the post-viral bronchitis.
Correct.
So many cough can be malignant, many cough not can be infectious, many cough can be some rare causes also. So because the scenario is going on, post-viral bronchitis, viral thing is happening, and since because of the COVID, so make sure you are ruling out all the major causes of the cough to treat as a just only post-viral bronchitis cough.
Yes, that is the most important. First, you have to rule out any sinister,
Yes.
and then we can start treating as a. So, but what will you treat? Okay, you ruled out the sinister. So, what will you do for that?
Frankly, says there are multiple brands in our country, so you have to switch over the brand name. Frankly.
Yeah. So basically, it is yeah. One last question, and then we close for today.
Because resistance cough.
Yeah, he said that. So we have to rule
so
out.
after
acid
ruling
reflux.
out the
Yeah.
causes,
Yeah.
you have to just treat the
So basically,
symptomatic.
rule out any acid reflux, any tuberculosis, any
So
malignancy.
in that there are, as I mentioned, the causes. Most common cause of the cough in our country is the postnasal drip, upper airway cough syndrome, gastroesophageal reflux disease. Sometimes it's a psychological, sometimes it's a malignant, tuberculosis. There are many causes, some rare causes that can be the connective tissue disorder related
Interstitial
cough.
lung disease
That
can
could
be
be the parenchymal lung disease. There are many, that could be the tracheal stenosis, tracheal. There are multiple causes. So the concern is to just rule out the
Eosinophilic.
cause of the cough. Sometimes eosinophilic cough is also there. In those situations, oral steroid helps. And yes, sometimes the inhaler therapy with the ICS are also helping.
Thank you.
Dr. Nilesh,
Thank
want
you,
to say
Dr.
something?
Which is your question?
See,
Doctor, as a
basically-
last question, we'll just take.
Because some of the yoga experts nowadays, they are for the snoring and oral breathing, they are recommending taping the mouth. So how much that's going to help for the snoring at the same time oral?
Taping the mouth does not help. Does not help. So we can.
Supposed to actually, because patients are mouth breathing because they cannot breathe through the nose. So that is very dangerous thing to do that. It has to be corrected.
So last, Dr. Sensor wants to
Coming
say,
back to
and
the
then we close.
that question, basically, it's a chronic cough we are facing, and there are a few major causes of chronic cough. The cough more than 15 days is to be considered as chronic cough, and you have to rule out one and every reason for the that chronic cause. Now, what are the things, like he has already mentioned postnasal drip, GERD, and post-viral illness, everything. But to detect it, most important is history. Your history is going to give you a 50% clue, and rest other lab parameters and everything is going to conclude the disease. Now, what history you are going to ask for a chronic patient? You have to ask whether it is happening for the first time in your life or it is happening every year. And if it is happening every year, in which season it is happening? If it is happening every year, are your other siblings or other family members are also having the same disease? Now these, if everything is yes for this, then it is going to detect, it is going to tell you the clue of seasonal allergy or a post-viral illness because other family members are also included. Now ask him the history. Many of the patients right now is going to give you a history that yes, I had fever 15-20 days back, and after that my cough started. So it is a clear indication that fever, he has got some infection, maybe a viral infection or some reaction, and then it started with the cough. Now another thing is, ask him whether it is a only dry cough or it is having expectoration. It is happening, you have to ask him a diurnal variation, whether it is happening early in the morning, late night, or during a daytime. Now late night coughers and early morning cough is more related to airway disease or asthma. So these are the history points you have to ask him, and you have to first clinically judge and clinically make a diagnosis, and according to you have to do an investigation. Now if these history, if it is that patient is giving this history, then a simple eosinophilic count or IG level is going to conclude your diagnosis. If it remains undiagnosed, a spirometry is a better tool. And believe me, I am doing more spirometry than chest X-ray. Chest X-ray is actually a second line investigation for me. I have my technician and he is always busy whole day doing spirometries, and it is giving me a diagnosis. Most of the airway diseases are really diagnosed on spirometry. So use spirometry as a tool in chronic cough patient after ruling out acute infective illness.
So thank you very much, Dr. Nilesh. Thank you to all our panel for their insightful answers.
Just on the lighter vein, I had a patient with asthma, and I was asking her about pets, whether she has cats, dogs. She said, no, I don't have. So the asthma was never resolving. Finally, I asked her any other pet. She told me she has a rabbit at home. So it is very important, I think, to name each and every pet when you ask. It's just on a lighter way.
I hand over the mic to Dr. Sangeeta for the concluding remarks. We have to close. So any further questions can be taken after, during the lunch time.
No, wait. So now I request Dr. Ninad Kakar to come forward and give token of appreciation to Dr. Vivek Patel. Dr. Vivek Patel. Now I request Dr. Nishad Shah to come forward and give token of appreciation to Dr. Nilesh Chinchkar. Now I request Dr. Mangesh Mehta to come forward and give token of appreciation to Dr. Vinod Chauhan.
So we come to the concluding part of today's session. I wish to thank IMA Navi Mumbai, and I would wish for token of appreciation to Dr. Rajeshri. I request Dr. Vinod Chauhan to hand over token of appreciation to Dr. Ghanshyam Dulera. I request Dr. Vinod Chauhan to hand over the token of appreciation to Dr. Ghanshyam Dulera. I wish to thank our sponsors, Dr.